पुनीत,
यस सर।
राजनाथ साहब को भेज दिया?
हाँ जी सर, भेज दिया है।
और इन जो अपने गेस्ट
डॉक्टर गुलेरिया और मैडम सुधांशु को।
ठीक है।
हाँ जी।
ऐश्वर्या, ऑल सेट?
Yes, sir. Good morning, sir. Yes,
गुड
sir.
मॉर्निंग।
All set, sir.
ओके।
गुड मॉर्निंग शुभम भैया।
Good morning.
गुड मॉर्निंग शुभम।
Good morning, that.
हाँ सर। ओके ओके।
Good morning, Anil ji.
गुड मॉर्निंग मैडम।
Good morning, everybody.
Good morning.
मैम।
Morning, ma'am.
Yeah, so you can hear. We just still have 4 minutes left, isn't it?
Yes, yes.
So
Yes,
I'll just join you in a minute. I just wanted to see that everything is in order. I am sure everything is in
Yeah,
order.
yeah.
Okay.
Anil ji, I'm sorry, I'm just traveling to the airport, but I can still do the conference because it's still about 45 minutes journey. Is that okay?
Yes, that's okay.
Yeah, thank you.
This is the beauty of this
Absolutely.
online. Yeah.
Okay, I'm back. Good morning, Dr. Anil. Good morning, everyone.
Good morning. Good morning.
Hi.
Good morning, Mr. Suri.
Hello. Good morning.
Good morning, Dr. Hari Prasad.
Good morning. Good morning to everybody.
Good morning, sir.
Hello, good morning.
Good morning, Rajdan sir. Good morning.
Good morning.
Good morning, sir.
Good morning.
Good morning, Uncle.
Good morning.
Sir.
Good morning, sir. Good morning. Preeti here.
How are you, Preeti? क्या हाल है? ठीक हो?
Thank you, sir. ठीक हूँ.
Good to see you on these fora, and thank you for sparing the time. Dr. Garg pulls me in.
Sir, can we start?
Yes, I think we can.
Aishwarya?
Yes, sir. Thank you for the permission, sir. So we have all the speakers. So let me begin the conference. A very good morning, ladies and gentlemen. Respected dignitaries, delegates, invited guests, speakers, ladies and gentlemen, a very warm welcome to the World Healthcare Conference 2022. As we all know that, health is a blessing, but especially in the post-pandemic times, we have realized the importance of health, especially after the coronavirus pandemic. And the primary vision of the World Healthcare Conference is to improve the research and developmental activities in the medical field, and to make sure that there is enough talks, and this conference is going to be held per annum to make it an ideal platform for people to share views and experiences in medical science and health science. And the idea is to promote scientific knowledge interchange between academicians, researchers, doctors, and students working in and around the world. And so without wasting any time, with the theme Global Transformation in Healthcare Post-Pandemic World, I'd request Dr. Anil Garg, President, World Healthcare Conference WHC 2022, to please begin the conference by the welcome address. Over to you, sir.
Thank you, Aishwarya. It's okay?
Yes, sir. Yes, sir.
So World Healthcare Conference that has started a long back. The first thing is to congratulate all the healthcare doctors, paramedical staff who have done excellent work in last 2 years or more for fighting with corona. The innovations in vaccine sphere deserve a special mention, and we have to welcome this modern healthcare conference. You are all welcome, especially the award winners, especially guest of honor, Dr. Guleria, Preeti Sudan, Mr. Anil Rajdan, and all the guests from India and abroad. One thing is that this pandemic told us or teach us is that cost of Medicare should go down. How? First is the telemedicine or teleconsultation, and then if it is impractical, then follow-up action. So the cost of Medicare will go down, and it is doing that. Second thing, I must request all the international and national doctors, paramedical staff, nurses, and all others, and medical companies also, that we should have a patient-centric approach. Patient is first, and patient is in not in normal condition. So we should not take advantage of this. We should do something great for causing cure to the patient. With these words, I must request our most distinguished fellow in medical fraternity to kindly address us and just show us the light for future. Thank you.
Indeed. Thank you so much, Dr. Garg. I'd request distinguished Professor Randeep Guleria, Director, All India Institute of Medical Sciences, for the industry address. Very warm welcome, Professor Guleria.
I think he has not joined. So,
He will
All right.
join soon. He will join later.
okay.
Okay. So I think we'll just wait for him to join, and as soon as he joins, then we'll have the industry address. But now I'd request Mrs. Preeti Sudan, former Secretary of Ministry of Health and Family Welfare, Government of India, and member WHO, the Independent Panel for Pandemic Preparedness and Response, for the special keynote address. Very warm welcome, Mrs. Sudan. It is indeed our pleasure that you've joined us today in this conference. We'd request you to please present the special keynote address. Ma'am, over to you.
Yeah, thank you. So, Dr. Garg, the organizers and distinguished colleagues, Anil Razdan sir, and industry experts, the doctors, researchers, and all those who are interested in healthcare and present here, a very good morning to all of you. So, as the theme goes, today's and this conference of 2 days is aiming to discuss topic around global transformation in healthcare post-pandemic world. Now, I've been thinking, because you see, I would say that world has changed post-pandemic, or rather we should be saying that world of pre-pandemic is no more. So when we talk about transformation, I think if we can identify what are the major lessons that that we've learned, maybe we will understand the why and the what of this transformation which is already underway, and also which is needed not only in healthcare but in all sectors that impact our lives. So first and major lesson is that we are all interconnected. A virus outbreak in China has caused havoc worldwide, affected lives negatively in every possible way, affected economies, brought to limelight issues of inequity. So we whatever we do, wherever we do, we will cause worldwide impact is something that we've learned. Next is that the global health governance needs an overall. WHO, UN, they need to be strengthened. They need to be made more accountable, and they need to be financially more independent so that they can take decisions independently and, more importantly, timely. Third lesson is that technology has a major role in the way health is being dispensed, will be dispensed. Dr. Garg briefly mentioned it also in his welcome address. And another lesson that we've learned is that health is everybody's concern. It's not just the healthcare professionals, it's not just governments, it's everybody. It's the industry, it's the communities, it's the civil society. Each one of us is actually responsible for not only our own health, but also, I would say, community health, institutionally, how we organize things. So that's another thing that I would like to highlight. And the pandemic has also shown that mental health is so very important. And in India, we are now articulating it as a very important intervention. It has found place in our budget. So it's rightly acknowledged as a very important issue. Therefore, given these learnings, the obvious transformation that is required worldwide and in India in particular is that investments are required, and investments of the right kind. I would like to underline that, in areas of critical care, emergencies, primary health care, and also in collaborative research, in diagnostics. And basically, we all have to work together. We need, therefore, to invest wisely, and I underline that again, in ensuring a resilient health system that will serve us both in normal times and during times of disaster. And a resilient health system is one that has the ability to prepare for, to learn from shocks, one that is enduring, one that has equity as a central principle, is comprehensive, addresses the whole spectrum of healthcare needs, preventive, promotive, primary, secondary, and tertiary. And another important thing is that the central governments, the state governments, the civil society, private sector, academics, the academicians, researchers, all have to work together to actualize our long-term vision as well as time-bound plans to ensure that adequate investments in terms of infrastructure, human resources, information systems, procurement and supply chains for medicines and diagnostics, health security, mutually beneficial ways to share best practices and resources for capacity building. So it's quite a tall order, but I'm sure that together it is achievable. WHO had actually started talking about, and it was one of the mandates of, I would say, the world, of universal healthcare even before the pandemic. Now, actualizing universal healthcare is actually the transformation that is needed, and that encompasses all the elements that I have listed out earlier. Now, what is universal healthcare? The WHO says it means all individuals and communities receive healthcare services that they need without suffering financial hardship. So therefore, access and affordability are critical. Since we have foreign participation here, I would like to say that India is one of the very few countries that has since 2018 incorporated preventive and promotive healthcare in their health delivery paradigm. It's important. Why is it important? Because we've seen that during this COVID pandemic, it's still ongoing. So we've seen that people with comorbidities, people who were with low immunity, the older people, you see, so all the vulnerable categories, as we sort of named them, have suffered more. So therefore, wellness in healthcare is also very, very important. And India is one of the few countries that, as I said, has incorporated this. So in our health policy, and in 2018, when we launched a very ambitious Ayushman Bharat program, it had two pillars. It had health and wellness centers in primary healthcare, and also, you see, ensuring that with what we call PMJ or Pradhan Mantri Jan Arogya Yojana, the most needy are provided protection from catastrophic expenditure as government became a payer of hospital expenses for about 500 million population. This is the largest health assurance scheme. I say assurance because it works on trust mode also, and insurance also. It depends on the states, that's their wish. So this is the largest health assurance scheme in the world, and it has benefited millions of people. And we've seen that the services are actually done in the public-private partnership mode. So therefore, it's very important. Dr. Garg mentioned about affordability, bringing the healthcare costs down. So this is one way that government has actually done so for the needy and for, I would say about 40% of our population. Now I'm a passionate promoter of preventive and promotive healthcare. And why I'm saying is because of our lifestyles, because of the general environment in which we live in, because of environmental issues also, because environmental health is also very important. I think this is what we are also learning, and we've already learned. So therefore, the health and wellness centers that I briefly mentioned, this is I would say a place where we have started doing preventive NCD screening, non-communicable diseases screening for 5 NCDs. That is the hypertension, diabetes, and 3 cancers: oral, cervical cancer, and breast cancer. So why it's important is because you see, I have seen it myself when we started it. I had the fortune of being in place as health secretary. That you go in villages, there is no actually chance that women get, especially women, middle-aged or old men, to come to a place where a specialist will actually diagnose them, whether they have, a lifestyle disease of diabetes or hypertension. So what difference it makes is that free medicines are also provided there. So therefore, when we talk of transformation, we talk of bringing healthcare near people, ensuring that the out-of-pocket expenditure on, say, medicines is decreased, catastrophic expenditure in hospitalization is also taken care of, and also most importantly, that health is not seen only as curative care, it is also seen as well-being of a person. So we are moving from merely curative care to wellness. That is what, again, I would like to say. And also data has shown that you see where the healthcare centers are close to community, access and equity both are addressed. In India, I mean, we have seen in US also, US has a great system of insurance, but the primary healthcare or the preventive and the promotive healthcare has not received as much attention. In fact, they are investing 18% of their GDP in health. But still, you find that obesity, and these NCDs and cancers are on the rise there. So that is why in India, we are now talking about this wellness bit in healthcare. So yoga sessions, eat right movement, fit India movement, all these are important issues of healthcare, which we need to understand. And also the social determinants of health are very important. That is why in India, we had this Swachh Bharat mission. We also have this, clean water mission. Why these are important for healthcare is because, again, sanitation, clean drinking water, and general affects general well-being. In fact, there's a WHO study which said that because of this Swachh Bharat Abhiyan, about 5 lakh diarrhea cases in children were actually prevented in a year. So therefore, when we are talking about healthcare, we need to talk about all sectors coming together to create an environment of well-being and wellness. Of course, I don't want to underscore the need to expand, and I had highlighted earlier also that investments in healthcare infrastructure, in creating centers of excellence, in augmenting human resources, both doctors and allied health professionals. Now, thankfully, we also have legislation in place, and the vision is to have at least one medical college in every district through private or public participation. 157 in addition to 540 or that we have are already approved. Then 22 aims are underway. So a lot of investments are underway as far as health sector in India is concerned. And I hope that we will be a lesson to the world. And leveraging technology, there is no option but to go for it. And the sooner we do, and the more equitably we do that, will we be able to dispense healthcare in a more accessible manner. Let me share with you some, how we leverage technology during COVID times in India. So we actually have, you should visit a website called covidwarriors.gov.in. We have all the names, state-wise, district-wise, of health professionals, of volunteers, of retired doctors. So these are the people who the government could access for help during the COVID times, and the state governments have done that. Then we also set up very quickly a platform called iGot. This is a training module website, so that because we didn't know about how COVID is evolving, and we were experimenting, we were repurposing medicines. So do see that website. In fact, volunteers can also learn about and take a course and get a certificate online. So igot.gov.in is another way of that technology was used very quickly to dispense training to our health professionals, to our ASHAs, to our ANMs, to the field staff, and everybody who was involved in taking care of us. Then we have this, of course, helplines. Dr. Guleria, I don't know whether he has joined, but he did a tremendous job. There's a helpline number for clinicians. That means doctors who were dispensing healthcare, how do they if they want to consult seniors, if they want to know what's happening in other states, if they want to know what's happening in AIMS. So there was a 24/7 helpline for clinicians for consulting each other, sharing experiences of, COVID care during these testing times. And of course, government in this budget, the Indian government in this budget has announced a special mission for mental health, creating centers of excellence. Here also, I would like to say our Apex Institute of Nimans had a 24-hour helpline, has a 24-hour helpline in various regional languages also, because language also is one, you could be a barrier. So that was also taken care of. And of course, telemedicine. So there was this software that we have from Mohali CDAC called eSanjeevani. We were actually using it as an e-learning software for 53 medical colleges. We had knit them together, for peer learning. So it was quickly transformed into a telemedicine software. And today, millions of people have actually sort of benefited from these telemedicine services. We're now creating hub and spoke models so that you see the specialists can dispense and healthcare through these services. Of course, Arogya Setu and Cowin, you've seen how technology has helped us to keep track of each and every vaccine that our subcontinent, you see, has dispensed, and it's a case study of its own. So we knew which state has how much of vaccine, which person, who is the person who's got the vaccine, who needs a booster dose, who needs a second dose, and all that. So technology has been used extensively. Actually, I also want to share with you, we have been sending SMS messages to pregnant women in rural areas as to, they have to get their ANCs and immunization and all that, their TT injection and all. But it's now all getting knit together in this very ambitious program that was announced again in this budget of Digital Health Mission, Pradhan Mantri Digital Health Mission. So it's, I think this is the way forward. This is the transformation that's happening. And this is the result of this transformation will be visible, I would say, even in a couple of years. We don't have to wait for too long. We are already seeing it. So in my opinion, the transformation, elements of transformation are collaborative research, sharing best practices, strengthening infrastructure for a resilient health system, training our, training our human resource, augmenting human resources, and using technology, and also having all the social determinants of health, a focus on the social determinants of health, so that a wholesome, vision of healthcare is the way forward. Thank you.
Thank you so much, Preeti ma'am, for setting really the tone for this World Healthcare Conference. Indeed, as you pointed out, what the world needs is to move from really the curative care to really the holistic concept of health, the holistic concept of wellness. Thank you so much for that address. And now it is time for the awards ceremony. These are the EEF Modern Healthcare Global Excellence Awards 2022 in the healthcare sector and the Global Healthcare Awards 2022. So the annual EEF Global Awards were introduced by the Energy and Environment Foundation to recognize and honor outstanding organizations that are taking responsibility for defining a commercial future by adding value through excellence in healthcare, innovation, technology in a disciplined manner. The Global Healthcare Awards encourage and motivate to adopt best practices and become role model for others to emulate, and also encourage implementation of strategies for improvement really in operation standards, create harmony between industry and the environment. So I'm very pleased to announce the EEF Modern Healthcare Global Awards 2022, and they are being awarded to selected organizations by an eminent jury. Now the winner of the EEF Global Healthcare Leadership of the Year 2022 is Dr. K. Hari Prasad, President, Hospitals Division, Apollo Hospitals Enterprises Limited. So a brief introduction, of course, Dr. K. Hari Prasad is the Chief Executive Officer. He steered Apollo Hospitals, Hyderabad, and Dr. Prasad is the first individual outside Europe to be honored with a fellowship of College of Emergency Medicine, UK, and the first individual in India to be honored with a fellowship by the International Federation for Emergency Medicine. Dr. Prasad is author of the book, I Am Possible, in association with Kitaban Publications. And Dr. Hari Prasad is the recipient of many national and international awards. So we are very pleased to announce Dr. K. Hari Prasad as the winner of the EEF Global Healthcare Leadership of the Year 2022. I request Mr. Anil Rasdan, Chairman, Energy and Environment Foundation and former Secretary, Power Government of India, to please give away the virtual award. Over to you, Dr. Hari Prasad. Congratulations, sir.
Thank you very much. It's indeed a great privilege to be receiving this award. The last 2 years, the world has been engulfed by the pandemic, and I guess the one sector which has stood resilient, which has stood strong, and which has really fought the virus from standing in front has been the healthcare sector. And I dedicate this award to every single healthcare worker across the world, not just within the Apollo Hospitals group, not just in India, but across the group. It is indeed a great privilege. And I would like to thank the Global Healthcare Awards and the Global Healthcare Leadership for giving me this award. Thank you so much.
Congratulations, Dr. Hari Prasad. My pleasure to confer this prestigious award on you. We want you to be a beacon for guidance, because there is an age and place in a profession where you have to play the role of the leaders who show the path to other people. That yes, success can be achieved, obstacles can be overcome, and excellence is possible, keeping in mind also the ethics of the profession, as well as an open mind to future research and ideas. Thank you very much for being with us today, and I only hope that this award will spur you and others in your organization to better healthcare. Thank you very much, sir.
It's a privilege to receive it from you. So thank you very much.
Thank you so much, and congratulations once again, Dr. Hari Prasad. And now let me announce the EEF Global Healthcare Women Leadership of the Year Award. And the award this year has been bestowed upon Dr. Shikha Nehru Sharma, founder, Nutrition and Wellness, NutriWell Health India Private Limited. And Dr. Shikha Sharma is a well-known name in the preventive healthcare sector. She was focused and pursued with the right eating habits and lifestyles for the preventive healthcare with the scientific approach. In 2020, Dr. Shikha envisioned expediting her goal of improving people's lives through research-backed preventive healthcare, through education, technology, and media, forming 3 exciting startups: Unitas Health Academy, 8 Well Nutrition Software, and One Health Platform. And Dr. Shikha has already been honored with several prestigious national and international awards as well. Energy and Environment Foundation honors Dr. Shikha Nehru Sharma with the EEF Global Healthcare Women Leadership of the Year Award 2022. Congratulations, Dr. Shikha Nehru Sharma, and indeed our pleasure. Congratulations. Would you like to say a few words?
Firstly, I'm humbled and honored by this award, and thank you for bestowing this award to me. And I must say that this is really encouraging. And the reason I say this is because many years back, when I passed out of Maulana Azad Medical College and I was working in the ICU as a very junior doctor, that's the first time it struck me that unless preventive healthcare becomes part of the ecosystem, the whole structure would remain fractured. The healthcare system would remain fractured. And at that time, this decision was not very popular because preventive healthcare, and particularly through the field of nutrition, was not very popular. I also am I'm in gratitude that I'm born in this country, because in this country, Vedic nutrition, which I'm a great fan of, and I have been a crusader of integrating Vedic nutrition into our lifestyle. Vedic nutrition is basically that stream of Indian nutrition or Indian Vedic sciences, which has hardly been known in the modern century, which is about the right kind of food we should eat according to our biotypes. Now, as a doctor, I could clearly see that in ancient Vedic sciences, they were talking about nutrition and genetic type. Of course, since genetic word was not used, but the whole ethos was about genetics and nutrition, which modern sciences and are going towards epigenetics and nutrigenetics. So, as a doctor, what I found is I found that in our ancient wisdom and traditional wisdom, there are a lot of things which can be included into modern sciences, and all sciences, if we work in a collaborative fashion and not silos. Actually, healthcare equity and accessibility can really become a dream. From a dream, it can become a reality. So during this COVID, uh, what we try to do in a very, very small way is launch nutrition software which has Vedic nutrition plans, because we thought that unless this software is available, unless, like Madam had said, technology is used, it cannot be disseminated very fast. So the nutrition software was launched. Secondly, like Madam had said, that training and certification is very important, because today any patient wants to know that whether the healthcare professional is trained and certified and scientifically he or she knows the job. So we launched the training and online training and certification to have more and more people, professionals certified in Vedic nutrition. And last but not the least, One Health platform is getting launched this month. And One Health platform, our aim and our dream is that it should be one platform where people can access scientific research, and that research is backed by, like, for example, All India Institute had published a research 20 years back about milk and acidity, that milk should not be given in acidity. But today, a lot of nutritionists are giving milk in acidity. So these researches have to come out in public sphere in a simple language. So this is our dream, that bring out the validated research-backed information, and this platform would also be to allow services, people who are offering services to come on this platform. So I am deeply in gratitude and thank you so much. It is hugely motivating and encouraging for me, and I promise to work harder so that we can bring healthcare to all. Thank you.
Thank you, ma'am.
Thank
And
you.
again,
Thank you,
congratulations.
Dr. Shikha, for your very, very wise words. And I think what you said is really wellness has to become a part of a human being's existence. It is part of one's education. Somehow I feel that in the whole education process, if young people are given more or less a compulsory sort of a lecturing or some kind of tutoring on how to behave as an adult, I think wellness and nutrition are something that the present pandemic has taught us is something which was missing in our curriculum. And I think it ought to be included in some form in learning as part of attaining adulthood. It's part of raising a family. It's part of ensuring a healthy life. Thank you very much for your contribution.
Thank you so much, Rastan sir. And now it is time to announce the EEF Global Healthcare Professional of the Year 2022. And this award is being bestowed upon Dr. Venkat Ramana Sudigali, Consultant Radiologist, UK, Ireland, and India, and Director and CEO, Excel Hospital, Hyderabad. Dr. Venkat is a Consultant Radiologist, NHS, UK, and Ireland, Royal College of Radiologists, UK. Dr. Sudigiri is a British citizen now based in India after 20 years of experience in UK NHS. Dr. Sudigali is qualified senior consultant radiologist, expertise in CT and MRI, specialist in emergency radiology, and he's the director of Excel Multi-Speciality Hospital in Hyderabad in India. He's using technology to provide highest quality patient care across the globe, quality improvement, and clinical governance advisor and entrepreneur as well. So Energy and Environment Foundation honors him with the EF Global Healthcare Professional of the Year Award 2022. Dr. Venkat, over to you. Congratulations, sir.
Thank you. Thank you very much. Can you all hear me? Because I'm in the airport, just about to board a flight.
Yes, sir, we can hear you.
Thank you. Thank
Yes.
you. And first of all, I would like to thank the Global Healthcare Awards team. And also, I'm very much honored to be selected as one of the recipients of the award. I would just like to say a few words about the initiatives taken by Global Healthcare Awards Committee, including Dr. Anil Garg. And ever since COVID, there has been exceptional efforts on together eminent speakers from all over the world to speak about healthcare, the pros and cons of our system, and what we can do to make healthcare better for our worldwide population, which was very much a need of the hour at that stage. Now, we are completely aware we should be cautious and we should learn from what we experienced in the last couple of years, which are provision of high quality of healthcare to the mass population in an equitable way. Because I may be COVID free, but my neighbor may be still COVID positive. So it's very important that we consider healthcare of the society in general, and provision of equitable healthcare is of utmost importance in the next decade or so. As somebody mentioned, we realize the importance of technology, realize the importance of investing appropriately in the healthcare system, both in primary as well as preventative healthcare, and not just the tertiary healthcare that we were always trying to concentrate on throughout the last few decades. Last but not driven by evidence, and COVID has again needs to come. We should invest research facilities, preventative medicine, primary healthcare, which is well established in other countries, but in India, it is still yet a stone to be a landmark to be achieved in a big way. And a population of 1.5 billion, it won't be easy to change leaders of the nation can start promulgating the principles of primary healthcare and equitable healthcare to the mass population. I end once again by to the whole team of global healthcare initiatives, and again, once again, congratulate them and hope we have much more discussions and action at the same time to bring about a positive change to the whole healthcare system of our nation. Thank you very much. Thank you.
Congratulations, Dr. Venkat. And we only hope that professionals like you can provide relief and also provide ethics to your fellow doctor community, medical community, because it's only excellence in ethics that will take healthcare forward. Congratulations.
Thank you.
Congratulations once again. And it is now time for me to announce the EF Global Healthcare Global Single Specialty Hospital of the Year 2022. And the award is being bestowed upon UN Mehta Institute of Cardiology and Research Center. And we have Dr. R.K. Patel, the director of the hospital, joining us. Dr. R.K. Patel, congratulations, sir, for winning the award. Sir, over to you.
Thank you very much. The Energy Environment Foundation for awarding us a Sunga Specialty of the Award to UN Mehta Cardiology and Research Institute and Health and Welfare Department of Government of Gujarat. We are extremely honored to be receiving this award. I would like to thank the committee for selecting, recognizing our effort, particularly in government setup. Our institute is emergency related 1,251 bedded tertiary cardiac care super specialty teaching hospital. It is now the biggest and also the best single super specialty cardiac teaching in the country, and one of the biggest in the world. The institute is rendering services mainly to the poor, non-affordable cardiac patients of the India. It is a teaching, research, academic, training, unique charitable institute having super special residency program. Institute is a center of excellence for charitable activities where world-class quality care in cardiology at no cost At our institute, 90% of the patients are given the treatment without any taking charge or concessional cost. It means non-affordable patients should get either free or concessional treatment by government of Gujarat and government of India through a very visionary global health scheme, that is Ayushman Yojana, under the leadership of our present Prime Minister Shri Narendra Modi, to the poorest of poor patients, not only for cardiac, cancer, kidney, and other diseases. The institute is running a unique emergency cardiac service where any patient admitted in emergency department for cardiac treatment will be provided immediate life-saving treatment without any advance payment. Means it saves the life and gives the new life to the patient without any damage. Institute has a super teaching course where having DM cardiology 18 seats, MCH DM without any payment, without any donation, free, which will give a base super doctor to the country. Institute is having lot of excellence in minimum invasive without any opening of the sternum. Pediatric is one of the best programs in the country by government of India. That is, all the children, irrespective of caste, income, are given free treatment. In the field of cardiology, life-saving treatment provide new active life and not the extension. New active life gives 100% cost. Our motto is compensate and quality care at concession, no cost. At the same time, I'd like to thank the organization in giving one suggestion that there has to be a single super specialty tertiary hospital rather than multi-super specialty. Multi-super specialty division should be part of it, but one branch should be developed in the country either by private or government. Government means AIM. There can be one AIMS heart, one kidney, one heart, one endocrine, one neurology. Yes, supporting multi-super may be there. Then and then we can be world-class treatment to all the classes of people, including poor people. Thank you very much for awarding and recognize our effort in awarding us. Thank you very much.
And thank you, sir, and very many congratulations. Razdan, sir?
Thank you very much. And I think Dr. Guleria, I'm informed, is still in some emergency meeting, and I think the program may kindly move on. It has been an extremely rewarding experience, personally for me, for having listened to the opening words and address of Ms. Preeti Sudan, who, besides being the health secretary of the country, has been involved in various worldwide programs, which gives her the experience, hands-on experience, wisdom, empathy, and a vision, I think, which are extremely necessary for people at the helm of affairs for this very sensitive topic, which is vital and relevant to human life and also to the well-being of citizens. We talk of various schemes and programs.
Sir,
but
I'm
I
sorry to
think,
interrupt you, but sir, but we have one more award left.
yes, thank you very much. Sorry for beginning my address. I thought that you wanted me to start off there, but I think please finish the award. I shall come back to my address.
Sorry, sir. Sorry for the interruption, but let's give away the last award that we have, the EF Global Healthcare Operational Excellence Company of the Year 2022. And I'm very pleased to announce that this award is being bestowed upon Aurobindo Pharma Limited. And we have Mr. Suresh Raman, Vice President of the company, joining us. Congratulations, Mr. Raman.
Yeah, thank you. This is Suresh Raman from Aurobindo Pharma Limited, API division. So Aurobindo Pharma Limited, thankful to EF Global for awarding us Operational Excellence Company of the Year 2022. Aurobindo has emerged as a top 2 pharmaceutical company in India with a revenue of 3.3 billion, the 7th largest generic company globally, and we export to over 150 countries across the globe, having a more than 25 facilities across the globe and employee strength is more than 24,000, and all facilities in India are approved by leading regulatory agencies. Since inception, Aurobindo is working for continual improvement in operations by setting appropriate key performance indicators. In energy efficiency, adopting the latest energy efficient technologies standardized to source premium energy efficiency equipment. We have a dedicated in-house team led by BE certified energy auditors who does periodical audit of our boilers, utilities, steam systems, mass and energy balance in production processes, effluent treatment plants, and solvent recovery systems, which consumes 56 to 62% of our energy. The total 69 numbers of energy conservation initiatives are identified with the potential monetary savings of 392.8 rupees million. During the financial year 2021, the company accrued electricity savings of 28.4 million units, coal cost savings of 2508.6 metric tons of coal. This arose to bring down 26,710 ton of carbon dioxide emissions into the environment. In terms of overall specific energy consumption, it has been resulted in 18.4 increment in SEC against a 16.5 decrement in production due to pandemic. Even we too undergone the pandemic of phase 1, phase 2, phase 3 of corona. And it is a truly non-linear nature of consumptions. As I said that our utilities cost 56% to 62%. So there are the baseline which takes completely even if it happened to be a less production. In the energy excellence, we have continued to improve in the various initiatives like Internet of Things, in utility systems, inventory control through ABC analysis, and harmonization of the standard operating procedures. We exercised virtual warehouse where the non-moving materials had gone more than 180 days. We brought the control in raising the purchase requisition as we have a 25 units across. So we controlled through our inventory by having the virtual warehouse and moving the material from one unit to other unit, keeping this conscious call. Through above all the initiatives, we reduced engineering expenses by 20.3 million against the expenses incurred. And then environment and safety, we continue to improve on keeping the new technology, installation of double stage scrubbers in the process to protect the environment, and membrane bioreactors for the effluent system for controlling our BOD, COD, and as well as the suspended solids. And we continue to establish our 30 megawatt captive power solar power plant to minimize the company's carbon footprint. We recognized by the energy efficiency unit by CII for our unit 1, unit 9, unit 11, unit 14 for the energy efficiency unit, and excellence energy efficiency unit for our unit 9. Aurobindo also backed Golden Peacock Occupational Health and Safety record during the financial year 2021. Thank you all.
Thank you, sir. Very many congratulations, sir.
Congratulations to Aurobindo. Keep up the good work.
Thank you, sir. Thank you, sir.
So we congratulate all the winners, and I'll request Razdan sir to please continue with the team address.
Thank you very much, Aishwarya. At the very outset, as I was mentioning, that I would say that we are fortunate to be blessed with Ms. Preeti Sudan's very wise opening address, which speaks of her hands-on experience, both at national and international level. It's full of empathy and vision and a touch of hard reality. And that is, I think, words of advice for practitioners as well as policymakers and those who are involved in the welfare of the profession, particularly in teaching. These are kind of the vision that you have to implant in the future medical practitioners of the country. I would say that the stellar performers of today also have a learning for others that these are the fields that are opening up. These are the fields that are relevant. And I think we have to take a holistic view of medicine. We keep saying that. But health is virtually a part of the entire human existence. You can have periods of learning, periods of prosperity, periods of employment, But health is something which begins with the first cry when you're born and the last breath that you take in this lifetime. So that, I think, is the overarching importance of health. We've talked of quality of health, the kind of professionals that I think we need to build into the profession. It is, I think, a subject which is not engaging the true attention of our civilization. We say it's a very noble profession, but we don't give adequate attention to it. There are aspects of healthcare. There has to be huge investment. There has to be huge research and development. They say profit and healthcare. Should the two be mixed? In my view, they cannot be separated. Because wherever there is progress, there has to be investment. There has to be investment on future research. There has to be investment on new medicines, on new devices, on new forms of learning and diagnostics. And unless there is a return on investment, nobody is going to make an investment. How many of us for investment are doing it purely for philanthropic reasons? Let's face the hard reality. But I think all this investment and all the practice of healthcare must be seriously regulated, and regulated through transparency and an equal respect to patients' rights besides the rights of the investor. Because health emergencies are like wartime. And in wartime, many are ruined and many are made. Just unfortunately, as in the history of famines in the world. Some empires have been built on famines where others have perished. But I think wisdom demands that there has to be, as I mentioned, transparency, encouragement for expenditure in research and development and healthcare, and at the same time, a serious attention to parents' rights, which in spite of all the legislation on the subject, I think are an area of huge opacity and lack of enforceability. Every patient who's been through a bad experience cannot pursue processes in courts unless he has hard material or evidence, and that evidence is sadly lacking. The regulatory mechanism in healthcare, I think, is extremely poor. The right to inspect, the right to detect infections in hospitals, the right to intervene in case of malpractices has to be timely. At the same time, there should be no harassment of medical personnel who in any case are engaged in a very tense environment and a very busy environment. So I think this is part of the theme of health and the citizen. They are inseparable. The government cannot do everything. Government can only provide the bottom layer of protection. Private enterprise has to capture the rest and will capture the rest. There's been talk of a helpline for doctors and professionals. This is already fairly active, and I think it is an area of constant learning and education, and a subject which, through modern technology, has been facilitated. Then there's the importance of nursing care, in my view, its importance. It's, I would say, its certification and supervision. There are numerous nursing colleges or schools that have sprung up. Do we have the right kind of certification? Do we have the right kind of inspection? Is a professional body seriously examining all the quality of education that is being imparted? Because it is my serious view that the strength of a hospital, particularly indoor treatment one, is the strength of its nursing staff. Doctors can come and briefly prescribe medicines, look at the treatment chart and move on. But if it is the Florence Nightingales of the profession who ensure proper health care, whether at home or in a hospital. Telemedicine has been rightly talked upon, and I think telemedicine has certainly caught on and an extremely educative and important tool where the best in the profession are able to do hand-holding for people sitting in remote locations, or also providing knowledge to the top of what is happening at the ground level, what kinds of cases are emerging. This is an area which will just keep growing, and I only hope that it gets the encouragement that it deserves. The last pandemic has seen a very serious proliferation of WhatsApp medical advices. The disease of WhatsApp is as rampant as any virus. And unfortunately, there is no control. So there has to be some degree of caution and control. I do not know what kind of control can go into it. But this WhatsApp medical advice is something that will pose a constant threat to proper medical advice. When we talk of advances in medicine, which in the course of this two-day event we shall be talking about, there is the importance of artificial intelligence or machine learning. In my view, artificial intelligence really provides a window to the future of healthcare. There have been great advances in artificial intelligence. And what I see future of artificial intelligence is that why can't we install devices in public places particularly, which are prone to infection vectors, indicating that this place is unsafe for ingress. If we can detect pollution, why can't we detect viruses? Are there severe concentration in an area, in a marketplace, in a public place, in public transport? I think this is an area that needs to be given very serious attention. Because if pollution devices can be installed, if other alarms can be put somewhere, why can't artificial intelligence or machine learning, whatever you might call it, install these devices in areas that are dangerous so that it's a public guidance for people to avoid this kind of thing. Similarly, water sources, large water sources, of course, individual water sources cannot have that kind of thing, but large bodies which should raise alarms that yes, we are screaming for help, please keep away. Do not consume this. That's the kind of, I think, care that we need for health. Pesticides in water. These detectors, I think, have to become a way of modern life. You call it another area of, in my view, high tech. Can't the human body have implants which notices the rise of these parameters which are dangerous in a human body and even carcinogenic growth or any such detection, which can, through implants, transfer to a machine that data. This, I think, is the future of medicine and public health. Expenditure on R&D in healthcare, I think, is a subject that needs serious scrutiny. I've had the occasion to deal with R&D in a lot of technology areas, particularly in the sphere of energy. And one reason why I think some countries have moved ahead and others have stayed behind, even countries like us, is because our expenditure on genuine R&D, besides government expenditure, has not been in proportion to the needs of development. And countries like Israel, Japan, US, Korea, even China, which have forged ahead, have really made very substantial expenditures on genuine research and development, and not merely as a bookkeeping or accounting exercise for tax benefits. That's an area which I think serious professionals in the sphere, like Ms. Preeti Sood, Dr. Guleria, and others who would be participating in this conference, and a lot of other wise people on board today with a clear public conscience, and who have contributed their lives to the advance of this sector, have to put their heads together. In the sphere of health, there is a wealth of knowledge, I think, in ancient and traditional wisdom. Because health began with the birth of man, with the birth of civilization. And I think this traditional knowledge, whether it relates to healthcare or nutrition, is something that has to become part of education of a youth, so that it goes with that person through life. After all, what is education? First of all, you've got to take care of your own body, your own machine, and of your family as you rear one. That, I think, is something that we forgot for a while. Homes used to give it. Maybe grandparents used to give it more than our parents, who are busy in their own activities. That has to become part of the education stream. I would only conclude by saying that profit and healthcare, they cannot be separated. Investment in healthcare must be encouraged, but it needs to be regulated. And it needs transparency and a genuine respect for patients' rights, as well as respect for those in the profession. They should be allowed to do their work with dignity. A very dignified profession and a very essential profession. Thank you very much, and I congratulate the award winners once again and wish the conference great success. Thank you very much.
Thank you so much. Thank you so much, Razdan, for that special address, the theme address. Thank you so much for that. Before we welcome Dr. Michi Mehta, global leading holistic health guru and corporate life coach. And we are very pleased that we are joined in this conference by Dr. Michi Mehta. So before we move on to the special keynote address by him, I'd request Mr. Anil Razdan, Chairman, Energy and Environment Foundation and former Secretary, Power Government of India, to please present the vote of thanks.
And this is Anil Garg, and this is my portfolio.
I'm sorry. I'm
Yeah,
sorry.
no,
I was
no
thanking
problem.
Razdan, sir.
He's
And I
our
request,
boss and chair. So
yes, sir. I'd request Garg, sir, President of the World Healthcare
yeah,
Conference.
it's okay. distinguished dignitaries, Mrs. Preeti Sudan, Mr. Anil Razdan, Chairman of Energy and Environment Foundation, and former Secretary Power, Government of India, for very encouraging and nice words. These are not only lecture, but it is wisdom. And that wisdom is up to date and very relevant in modern times. Mr. Razdan has taught us transparency, three words: transparency, quality, and speed. We should do all the three. We assure you, sir, from our end, we will do it, and we will request the population and healthcare industry throughout the world to adhere to this. We have to thank our sponsors, Essentia, Krishnanand Suri, Dr. Aarti Thapalyal. They are here for sponsoring, silver sponsor. Then our Mr. Jamir, Dr. Jamir Pasha for supporting us, Dr. Gaur Dynastics, Dr. Ravi Gaur for supporting, and other associations for supporting this great cause of modern healthcare and at affordable cost. I will not take much time. I will only request Dr. Michi Mehta to address us. Thank you, Aishwarya.
Thank you so much, sir, for that vote of thanks. Before we move on to Dr. Michi Mehta's address, here is a brief introduction. He's a global leading holistic health guru. He has completed 52 years of yoga and a span of 41 years of professional run. He has bagged prestigious awards like a health and wellness icon by the Economic Times. He has received an award at Azadi Ka Amrit Mahotsav 75th year celebrations from the Ministry of Cultural Affairs in Switzerland for excellence and pioneer in holistic health. He's also serving Ministry of External Affairs Videsh Bhavan Mumbai Cultural Health. He is an author of 2 bestsellers and recently launched Immunity Plus, a book with Padma Shri Super Chef Sanjeev Kapoor, and his various upcoming books are Focus to Lotus, Curd Karma, and Women the Healer. And his research papers, there are several, including Monumental Code, The Vedic Wisdom, Immunity for Humanity with Dr. Ali Rani, Yoga for Spine, and Grow Tall. He is also a leading columnist with the Speaking Tree. He has been a speaker at Harvard University, IIMs, and IITs, and he has been appointed as the Fit India Movement Champion by the Sports Authority of India and is part of the steering committee at the Indian Merchant Chambers. He is an advisor, counsel for fair business practices, and advisor to Delphic India for holistic health and wellness. The columnist and the TV host show is also a life coach to Bollywood superstars, top politicians, several Miss Worlds and Miss Universes, and the Indian Army as well. So the author, poet, philosopher, the brand, the institution, the legendary Dr. Michi Mehta, who gets you energized, naturalized, optimized, maximized, wellness revolutionized, and gets you Mickey-mized. So that's the brief introduction. I request Dr. Michi Mehta to please present the special keynote address.
Hi friends, how are you? I heard Mr. Razdan speak, and I was very touched because he touched upon one very, very important part of health. Health means healing, health means wholeness. Healing and wholeness will never be complete without a compassionate, warm touch, feeling, empathy. And that comes from doctors, nurses. Nurses were never thanked earlier. The Florence and Nightingale was the one who was really glorified, and I'm happy that she was glorified. Because I would say doctors cure and nurses heal. I also say medicines cure and nature heals. Love is the single most important energy for health, wholeness, healing. In my parlance, health means the etymology comes from Latin, healed I, healed them, healed how. You become complete. The memory of wholeness returns. This also happens with natural nutrition, cosmic nutrition, an attitude of optimism driven by faith. And I tell people that स्वास्थ्य की एक परिभाषा है स्वयं में स्थित, स्वयं में उपस्थित, स्वयं में होना और स्वयं को होने देना. Now, स्वास्थ्य की दूसरी परिभाषा ये है कि स्वास्थ्य में आस्था छुपी होनी चाहिए. So you should be faith driven. A human being, only a human being can rise above gods or fall below animals because he has consciousness. And he is conscious that he is conscious. He is the one who could be a Krishna, Christ, Muhammad, Mahadev, Zarathustra, Buddha. Every human being is a god in human form, waiting for his own blossoming, nurturing. What stops you and me? So let's, friends, return ourselves to health, healing, wholeness. Let's get integrated. And most importantly, our lives are only here to evolve. Let's forget weight loss and let's focus on evolve. Let's get into absolute balance, which is equilibrium, equanimity, homeostasis, and get santulit. संतुलन में हो जाए समर्पण और समर्पण से मिले हमें समर्थन, समर्थन से हम हो जाए सामर्थ, सामर्थ से हो जाए हम सक्षम और सक्षम से हम हो जाए समृद्ध और एक संकल्प करें कि हम पीड़ा मुक्त रहें, मनुष्य जात पीड़ा मुक्त रहे और संकल्प से बनी सृष्टि और संकल्प से हो जाए सिद्धि. So सिद्धियां के लिए हमें संकल्प करना जरूरी है. Only man has the power to think, intent, manifest, and if change is constant, let's be the choreographers of our own change, and then we can get energized, maximized, optimized, internalized, eternalized, evolutionized, revolutionized, revitalized, regularized, all negativity neutralized to get Mickey-mized. Most importantly, let's understand that health is not just absence of disease. Health is the ultimate alchemy of growth, expansion of awareness, increase in your consciousness, sajagta, jagruti. Very important. Antrik jagruti, very important. Hosh, bodh, gyan. We are from the Rishi Munis. And the Rishi Munis were philosophers, scientists, and poets all at one. भूगोल है हजारों साल पहले, साइंटिस्ट से पहले हमारे ऋषि मुनियों ने बताया. ये जगत है, जग जिसकी कोई गति हो, हमारे ऋषि मुनियों ने बताया. वेद और योग को कर दे एम्ब्रेस और ह्यूमन बीइंग को बढ़ावा दे विद ग्रेस. मनुष्य वो जो मन का मारा, जो प्रकृति से पूरा होता है, वो कृष्ण होता है. जो पूरक होता है, वो पुरुष उत्तम होता है. शायद वही पुरुषोत्तम राम होता है. तो हम प्रकृति से पूरक हो जाएं, कॉस्मिक न्यूट्रिशन ले, लेट्स टेक सनशाइन, फ्रेश एयर, hydrate ourselves, let's harmonize with the gravity of the earth, let's get illuminized with the sun once again. And the 10 commandments of wellness here are that let wellness be the religion number one. Religions divide, wellness unites. All right. The best exercise for biceps is to uplift the poor. The best exercise for strong shoulders is to take the responsibility of the underprivileged. The best exercise for strong legs is to be deeply rooted in humility, to be better fruited in humanity. Sleep every night with a wish to heal yourself and wake up every morning with a promise to heal the world. And then, of course, life will be a magic. Live the life of magic. Be the choreographer of change. Be the God that you are born with, to be with, to become. In being is your seeing. रामा को उल्टा कर दे तो अमर होता है, अमृत हो जाता है. और जो प्रेम की धारा, करुणा की धारा बाहर जाती है, वो राधा बन के फिर से लौट आती है. तो हमारे सनातन धर्म को सलाम, प्रणाम, and thank you very, very much, Garg Saab. Razdan ji, your note was very, very good. I've taken a lot of lessons from it. I'm very, very obliged to be a part of this. And with this, I will take leave as I have one more assignment. But I will always be present to serve mankind whenever mankind calls on me, nature calls on me. So thank you, God, for bringing us together. And let 7 billion minds, 7 billion hearts throb together for this world to be a healthy, healed, and harmonious place to live in. Not a single child go hungry. Not a single citizen should go without medicines. Not a single woman should be unclad and without a roof. There is enough for everyone. Let's share whatever we have. We are just the custodians of what we have. We are blessed. Thank you so much.
Thank you so much, Dr. Mehta. It is indeed our pleasure to having been joined in by you and listen to your words of wisdom. Thank you so much for that address. And with that, we wrap up the opening, the inaugural session. And with that, we open the World Healthcare Conference of 2022 with the theme Global Transformation in Healthcare Post-Pandemic World. And we'll take a very short break here. Congratulations to all the winners. And we have very stimulating plenary sessions that are going to come up ahead through the day today. And in these sessions, there'll be discussions on various aspects related to the healthcare. And we have several speakers joining us from across the world. And there'll be discussions related to all the aspects related to the healthcare, and especially there's going to be great discussion on the transformation, the changes that have taken place and that need to take place after the coronavirus pandemic has hit the world. So looking forward to a very stimulating session, a very good conference through the day today and the day tomorrow as well. It's going to be a 2-day conference. So warm welcome to all the speakers who are going to join us in the plenary session. And with that, we take a very short break and looking forward to great sessions coming up ahead. So we'd like you to please join us for the plenary sessions as well. And we'll be starting off in about 10 minutes from now, and looking forward to a very stimulating session with all of you. Thank you so much for joining us in the inaugural session. Congratulations to the winners as well. Looking forward to your mentorship, Dr. Razdan and Dr. Garg, and of course, our special guest, Mrs. Preeti Sudan. Looking forward to providing us with the directions, be our light and guide. Thank you so much, gentlemen and ladies. It was indeed a pleasure. Looking forward to a great session ahead as well. Thank you.
सर 5-7 मिनट में मिलते हैं
जी
Dr. Mazan Gopal ji, thank you very much for coming.
Thank you, Anilji.
Just we will see you in next 7 minutes.
Okay, I'm ready with that. No issues.
Yeah, please.
Thanks.
Welcome, Dr. Jamir.
Good morning, sir. How are you? Nice to see you.
Yeah, thank you very much for your time. I know you are time pressed.
My pleasure. Thank you very much, sir.
Yeah, but we will start within next 5-7 minutes.
Sure.
Yeah. Thank you.
Dr. Garg, very good morning.
Good morning,
Very
sir.
good morning, sir.
Very good morning, sir. Happy to see you, sir.
Yeah, thank you.
So we are going to start the session in about just 4-5 minutes from now.
Right.
Okay.
It's
Okay.
so has Anil Rastan sir joined us? Is he there?
Shira is there.
No, I mean, as in, I couldn't see his video, so it's just confirmed.
Yeah, he will just join within a minute or so.
Sure, sir. Sure, sir.
Is there?
Yes, sir. So if we will have all the speakers, then we'll start sharp at 11:30, sir, with your permission.
So, sir, we can start within next 2 minutes.
Sure. I'm ready.
Sure, sir. Thank you, sir. We'll just wait for 2 minutes and we'll start sharp at 11:30, sir, with your permissions.
Mr. Jamir, Aishwarya, Mr. Jamir Pasha has to leave to airport, and that's why he's put at number 1.
Sure, sir. Sure, sir.
Be on time.
Sure, sir. So Rastan sir, shall I start? since we
Please
have
go ahead.
all right. So very warm welcome to all the speakers. This is the plenary session 1, and I welcome all our guests for this session. So this plenary session is going to focus on accelerating digital transformation in healthcare, artificial intelligence, machine learning, and deep learning. And I'm very pleased to announce Mr. Anil Razdan is going to be the chair for this session. Dr. Razdan is former Secretary Government of India and also the chairman of EEF. Let me announce the names of the key speakers for this session. We have Dr. Zamir Pasha, surgeon, Shahnawaz Hospital, Tamil Nadu. Very warm welcome, Dr. Pasha. Very warm welcome to you, and thank you so much for having joined us. We also have Mr. Sudarshan Jain, Secretary General, Indian Pharmaceutical Alliance, and Senior Advisor, Apex Partners. Very warm welcome, Mr. Jain. We also are pleased to having been joined in by Dr. K. Mazan Gopal, Senior Consultant Health, Niti Ayog. Very warm welcome, Dr. Gopal, and thank you so much for having joined us. I'm also very happy to announce that Mr. Neeraj Lal, Chief Operating Officer, Apollo Hospitals, Ahmedabad, is also joined us. Very warm welcome, Mr. Lal. Ms. Florence T. Hudson, Founder and CEO, FD Hint, Executive Director, Northeast Big Data Innovation Hub, Columbia University, US, is also with us. Very warm welcome, Ms. Hudson. Thank you so much for having joined us. And we also have Dr. Venkat Ramana Sudigali, Consultant Radiologist, UK, Ireland, and India, and first ever Ambassador, UK Royal College of Radiologists and Oncologists, and Director and CEO, Excel Hospital, Hyderabad. So these are the key speakers, and I extend my very warm welcome to all of you for this plenary session. And without wasting any time, I'd request the chair for this session, Mr. Anil Razdan, to please begin the session. Dr. Razdan, sir.
We lost your
Razdan,
voice.
sir, can you hear me? Sir, please begin the session, sir. I have introduced the speakers for the session.
We lost your voice.
Sir, can you hear me now?
Yes, I can hear you now. May we begin the session?
Sorry.
I
Yes,
think
sir,
Dr.
please.
Zamir Pasha is a surgeon, and he is going to be from Shahnawaz Hospital. He is a working experience, and I would invite him to begin the discussion on accelerating digital transformation in healthcare.
Thank you, Dr. Anil Razdan. May I? May I have the privilege of sharing the screen, please?
You can share, sir.
Please go ahead, sir.
Dr. Jamir, at the bottom, share the screen, please.
So there'll be an option just below the screen, just below the laptop. Laptop. You'll see an icon.
Can you see now?
Not yet.
No, sir.
Yes, and share screen.
Yes, sir. There'll be an option.
Yes.
If you click on that option, then we'll be able to see the screen. Yes, sir. Now we can see your screen, sir. If you could.
But
you need to, sir.
I need to open this.
Yeah, you need to just open the presentation, but we can see the screen. Yes, sir. We can see it. If you can just make it full screen, sir. Yes, sir. Perfect.
Oh, yes. Thank you very much. Thank you. And thank you very much for this wonderful opportunity and a unique opportunity to describe and discuss along with this elite fraternity about the digital transformation that has taken care. And dear Lord, thou great physician, we rely on thee. And that happens to be the first line of the Indian Medical Association, on whom we trust, the superpower, the active power, which has given us this digital power to transform the horizon of the Medicare into medical technology. And we have borrowed many from our biomedical engineers, and we have converted all of this into this unique phenomena called the human being. And being human is now the most important part of this robotic technology of artificial intelligence and all that we have in this cranium, which is going into several terabytes. And this is what is going to now take us into that entire horizon where we can fly the skies, trample the ocean, and transform the earth. And no matter what we can do, we can take this into advanced medical technology. And what is medical technology? This gives us earlier diagnosis. There is a minimal invasive treatment. Gone are the days when at the very mention of the name surgery, these patients used to flee from the scene, but they now demand surgery because of the minimal access treatment and the surgical techniques that we are now employing. We are able to do this. And with this, we are able to achieve shorter hospitalization and rehabilitation. This helps us in our country's productivity. The family head is able to go back to his family. The family lady is go back to her household chores. The entire country is in productivity, and we are cut short of the man days. And this also reduction cost. The cost is definitely reduced, and thereby we are able to achieve both the best and also the wonderful technology that we have in our armamentarium to this. And this gives us healthcare quality improvement. And so we have all this with us now. And the steps in the medical technology is that we have now an idea. This idea comes into being. And this idea was there about 3 decades ago when the laparoscopy came, even 100 years ago, with the light that we can go in and see into the darker horizons. We are able to use this technology to throw light into the darker internal organs of our body. And 30 years ago, as a surgeon, when I was introduced to laparoscopic sterilization, because that was our government's program. Can you believe we had this family planning program, which happened to be the government program 30 years ago? And as a surgeon, I used to go in, do the family planning sterilization operations, and fondly look into appendix, look into liver, gallbladder. And I used to wonder, when will I be able to tackle with the problems and pathology in these organs? And not much later came the advent of laparoscopic surgery. We were able to do all that. And once this, we were able to go into the prototype and to bring it all this and patent that. Once we got this patent, and this patent disclosure is something that we have to own up for every idea that we have conceived, conceptualized, created, and brought into action. And this, you wouldn't believe, we were asked to go and do this patenting by none other than our Bharat Ratna, the past National President Abdul Kalamji. He was the chief guest in one of our functions in one of the doctor days in Mumbai. And he said, I admonish you for the fact that you do these things and never publish them. You never patent them. He said, we need to do all these researches and then get them published and also get them patented. And then we need to also test this on human beings. Before that, we need to go into animal testing. And here, the animal testing has got to be very, very sympathetic towards the animal, because we need to have empathy. Empathy is where we feel the pain of another human being or another living being. And that, even when I was being trained in Rochester, in the United States, we used to go into this animal lab, which was down below the laundry, and then go, because, we had to keep away from the eyes of Society for Prevention of Cruelty to Animals. This is not cruelty, but anyway, this is being done. And then we go on to the first thing in man, and also for the patent grant. And once that is done, we need to go into the approval of the FDA, and then we come into the market. Because by then, the safety has to be established to even 1%. For me as a surgeon, I may operate on 100 patients and have a complication in one patient. For me, it is 1% morbidity. But for the patient, it is 100% morbidity. That is how it should be seen. And so we need to ensure absolutely zero morbidity and mortality before we can do that. And the milestones and the time taken for this is immaterial, but that doesn't mean that we can, at the altar of safety, we can sacrifice any of these safety measures. And so once we go in, we need to take care of all this as we do it in an animal. And once we do this, we need to be very, very careful. And so the healthcare challenges to do all this are the quality of care has to be absolutely impeccable and perfect. And the rising cost of the human values, human relations, the human capital. We need to have lots of paramedical staff. We need to have a lot of technical staff. We need to have all those biomedical engineers who need to be there 24/7 to help us in times of crisis, in times of need, and demographic changes also. Because from rural to urban, there are lots of people who come to us at the dead of the night, and then we need to take care of all of them. And so again, this wire has been placed. I'm doing experimental work on a pancreatic duct in an animal in Strasbourg in France. And once we do this, we are able to make sure that this works. And to make sure that this works, we have to be very, very careful. And so in the past, the disease was defined by symptoms, pain, vomiting, and exertional dyspnea. And we had an uniformity of disease. Once a disease comes, a diabetes, then we need to look at the multifarious manifestations of diabetes. And there was uniformity of patients. They came as only patients, but now we also have to not only look them as patients, we also have to look them as litigants too. And that is the practicality of today's work. And universal treatment and sickness was also there. But in future, we have to identify and protagonize the mechanism, the heterogeneity of the disease as to various manifestations. Say, for example, even the recent viral infection, the COVID-19, where it first came and invaded the lungs, where it came and then into the gut, then into various manifestations, bringing about premature aging, and people are now even complaining about lethargy, about fatigue, and the less working energy and inertia of them. And the variability of the patients, from a small child to an elderly person, to a pregnant lady, to an active IT techie. All this we need to have, and we need to do individualized therapy. That is judicious use of your common sense. Because our teachers used to tell us, if you diagnose a rare disease, you will be rarely right. If you disease a commonly manifesting disease, you'll be always right. That is what they teach us. Because when we see the obvious, we forget the obvious, think of only the very rare things. That should not be the case. And then we need to also look at as predictive and preventive care, that is wellness. We have been focusing most of the times only on illness. No, now has come the time where we have to make sure that the illness does not come at all, and there is only wellness. And so the technology drivers are now microcomputers, the nanotechnology, the bionics, the regenerative medicine. And all of them have now brought this into focus in our field, in our realms of surgery, as to how I should go. And most of them is Greek and Latin to me, but I know how to use them. I can drive a sports car. I can drive a chopper, flight, but how does that work inside? It's all only known to my biomedical engineers. And so I have this microcomputer and nanotechnology, and we have nanomedicine too. And this bionics is something that gives me, I work for hours and hours in what we call, go back to our days of Sushruta, Gurukul. This is where I now appreciate and applaud our gurus, because the teacher goes up 7 steps. The Adhyapak is the one who teaches what is in the textbook, whereas Guru is the one who lives the way and leads the way it should be done as prescribed in the Vedas. And that is how a Guru is there. And that is why I reiterate again that I have undergone Gurukul, because I have no chance. Only once I have to open up the abdomen, only once I have to open up the chest. I cannot keep on opening, closing again like a book. The opportunity does not knock twice. Opportunity is only once. Grab it and at the same time succeed. Success should be your mantra and your motto. And the regenerative medicine, this is something we have to look into stem cell therapy, because as we age, do we have the same cells as the ones that we were born with? No, they are regenerating, they are replenished. Every day we are shedding millions and millions of our skin cells, and they keep on regenerating. How to keep this regeneration up and in a higher altitude is now the motto of the surgeon and any medical man. And again, as we work on this, we have to do what are these things that we need to have defined energy. So we define energy in quantum physics and chemistry and convert them into biology for human beings. So these are the magnetic, the electronic, the optical ones, and the thermal ones. We are living human beings, and inside we have a thermal mechanism. This thermal mechanism is always maintained at 37 degrees Celsius. We are always warm-blooded animals. We came out from the sea. And so as we came out from the sea, we were able to live on the land, and the entire earth, as you might always know, is 2/3 covered by the sea and only 1/3 is land. And once we came out, here also we have to have in mind the sea is sodium chloride, salt, as you all know. And as we came out out of the sea, and in our cell, the sodium is outside and the potassium is inside. That is how we always, our examiners ask us the questions, what are the trace elements that are intracellular and extracellular? So immediately I think of the way that we came out of sea, we came out of the ocean, and so the sodium is outside. Sodium is extracellular and potassium is intracellular. And this we have to have in mind whenever we think of all these trace elements that also goes up to make the body. Right from oxygen, the O2, where it divides into O and plus O into a nascent oxygen molecule. All that is being done. The moment you go into the physics and the physiology and the biochemistry and the entire pathology of any disease, your imagination and the way you think about our body and the way you conceptualize your body undergoes a radical change. You believe in something called faith. Faith is nothing, is implicit faith in something that is always being controlled, that is beyond our imagination, that is beyond our comprehension, that is beyond our imagination. And so, going on to this, we have to have these applications as to give a drug, and then therapy techniques, whether it is nanothermal. Then we go on to the diagnostic modalities and the imaging technologies and the antimicrobial techniques. Human beings are not only the living beings on this earth. Again, I would reiterate again to my friends that we also cohabited by coexisting with us as millions and trillions of living things we do not know, right inside body to every nanosecond, every nanometer outside, undergoing replication, undergoing reproduction, causing all sorts of materialistic things for our existence. They are the ones, the probiotics, and these are the ones that are there inside, right from helping our digestion to go on to do our circulation, everything. And so we need to control them. How do we do them? We call them nano robots. They can be cremelocyte or respirocyte. All these are nano robots working inside. Only now, after so many technical innovations, we are able to reproduce them. And so again, going into this pathology, we need to find out how do we go at them. We need to touch them, feel them. And to do this, we need to have the bionics. And I need to have a technical finesse and a technical expertise in my hand to identify. And how do we identify What the mind does not know, the eyes do not see. So unless I know about them, I may not be able to identify them. I may be identify this as a glass, but it would turn out to be a diamond. I do not know. So until I know that this is a diamond with cut, clarity, sense, carat, I may not be able to identify the diamond. So I need to have this. So I need to have both my hand and the eyes working in tandem to do this artificial intelligence. And again, as I open this inside, I need to know what I'm doing to recognize the disease before the symptoms. That is what I said, predictive, wellness. Which of this human being, which of my brother and sister who are coming into my hospital, or as I go into their habitation, would I be able to identify them? That is why we run camps. We run camps to identify them. And you won't believe the tribals living in the hills. When we went to do a camp, we found that 60% of them are suffering from diabetes. Until then, they were ignorant about their disease. So we can call them ignorance is bliss. They were living with it, but we identified them. And once we alarmed them about the complications of diabetes, they became very, very fidgety. But that doesn't matter, but we need to do all of that to increase the longevity. And of course, the minimal invasive treatment, the treatment should not be gone are the days when we said big surgeons, big incisions, big opening. But now are the times, big incisions, very, very minimal invasive techniques or no invasion at all. So these are done to do tumors, to identify dementia, and this depends on the quality of the image that I have to translate into practicality as to find out what this disease is, and to also map the brain area function, and to also find out this holography. Holography is something that brings into focus the entire body surface into its thermal functions, what are the constitution of the nodes of the entire system. And we also do endoscopy, as I told you. Endoscopy. Scopy is to go inside and find out endos is inside. And so I go inside and put all these complicated gadgetry and find out what I'm doing. And these involve a lot of biological processes. Like say, for example, I'm going into this oocyte to take out this ovum. And this requires a biological process, and we need to have a substance, and we need to observe, analyze, and reproduce. So this are, again, as I told you, we borrowed shamelessly and very liberally from our biomedical engineers, from deep sea exploration to pharmacogenetics, and to do this induced pluripotent stem cell. And absolutely, we are doing it for good. And we always appreciate them, applaud them, and always invite them always to our conferences to come in and join us to take us into digital transformation. And we need to address this in the international forum also. And here again is with Kalamji, who has always been a man. You wouldn't believe he was the one who found out the first artificial limb that was very, very light. He took the metal from the rocket and brought it into artificial limbs for the people who had no legs. And with that, they were able to do wonders. And would you also believe that he was the one who introduced the very economical heart stent, which can be introduced into the heart? And this is the way, besides rocket technology, besides being a missile man, he was also a man with a lot of human care and human cure with a humane approach. And he's here with me. And so we need to have the integration of the current intelligence with technology. And we also need to have this mobile medicine application. We right now have all the CCTV technologies. We always have, even right the way, you click your car key from your house onto the mobile, and you keep the mobile near your car key, and you will be able to open up the unlocked key and you can unlock them. That is how we are able to transfer this. And you won't believe, my Professor Marasco in Strasbourg, the patient was in Strasbourg. He was sitting in a console in New York. And from there, he was able to do a laparoscopic cholecystectomy transatlantic via this mobile application. So this is the world's first Guinness Book recorded transatlantic surgery. So we have this telemedicine, smartphone assisted surgery, and here I am with the world surgeons who are together. So we have all this Da Vinci robotic surgery, which is now an intuitive surgical. We are able to get into the abdomen and come out with minimal, and we get applauds for all this. And now we have come to the cyberplasm, where we have synthetic biology, we have microscale, we have a biohybrid robot, and here are some of these things that go in and do everything that I can do with one hand. It can do all that I can do, suturing, knotting, and everything it can be done. And so synthetic biology like chemoreceptors, photoreceptors, and output is optoelectric transducers. All this can be done. So the panoramic work, the world is totally right in front of us. It is for us to grab it and bring it for human research, human care, and for humane work. And thank you very much, Dr. Anil Kumar Gargji, for that wonderful opportunity. Thank you so very much. Thank you for this wonderful work. Thank you.
Thank you, Doctor. I think there's a request from Dr. Venkat Ram Sudigali that he is to catch a flight, and maybe Aishwarya, if we can allow him to speak first.
So if you allow, sir.
Please go ahead.
Dr. Venkat?
Dr. Sudarshan Jain is also on the same phase. So let him finish first.
Okay, okay.
Thank you, sir.
Go ahead.
Aishwarya, please
Yes, sir.
ask Mr. Sudarshan Jain to speak.
All right, sir. So I'd request Dr. Sudarshan. Sir, Dr. Jain, can you hear us?
I
Dr.
think
Jain?
they both have gone for a coffee break.
So perhaps, so if we could ask the next speaker, sir.
Dr. Mazan Gopal. Dr. K. Mazan Gopal.
Unmute, sir.
Thank you,
There,
sir.
Dr. Sir.
Thank you very much for this opportunity. Can I share my screen?
Please, sir, go ahead, sir.
So I would be
don't
sharing
see
just
an
a
image
small
on the screen.
presentation. I would be sharing just a small presentation about the accelerating digital transformation in the country. Because if you look at the way things have progressed during this COVID time, had it not been the digital things which are available, it would have been very difficult for us to manage the home care management which has happened. You might have seen how the pandemic has given an opportunity to accelerate the things. Had it not been the pandemic and the focus on providing treatment to the comorbid conditions, the telemedicine guidelines would not have seen the day. And we would be still practicing the previous things and which the honorable courts have taken cognizance and they have passed orders. So my presentation is very short. It's not that I would be just focusing on how the digital things are happening in the country and how we can accelerate that thing. So as we know that on 15th of August 2020, Honorable Prime Minister, he has launched the National Digital Mission with an aim to create a unique health ID for each individual to provide access to integrated services across different tiers of healthcare services. If you look at the health services, we do have a fragmented health services wherein 1.4 billion people chasing 1 million doctors for healthcare services, for their healthcare needs. We have to see that how we address that issue. We do have a vision to create health IDs for 1.3 billion people, which are linked to electronic health records, and with a pan-India exchange in a very secure manner. We have a vision to create national and regional registries, which will be created for clinical establishment, health professionals, health workers, pharmacies, health facilities, and health pharmacies and the health professionals will be provided with a unique identifier. The electronic medical record will have patient health ID, health facility ID, physician ID for easy tracking of records. Why it becomes important? Because during the COVID times, where whole of the world was grappling, who are the persons who have been escaping the virus. If had we had the electronic medical records, we would have been in a better position to inform the clinicians and the policymakers. There is a vision to set up a nation telemedicine network, and there is a increasing use of information technology for pan-national surveillance and monitoring of the program. You have seen the little bit use of this Arogya Setu app, which was meant for doing the tracking of the patient. It used a very robust kind of technology in which the Bluetooth technology and the mobile triangulation was used for knowing the contacts of the particular patient. And you see that how the things was managed beautifully during the earlier part, during the first phase. As the number of cases increased, then because of the other issues, operational issues, but still it is holding true, and we are using that system. The other system which has been used for surveillance and monitoring is the use of COVID management, COVID platform for right from the vaccine scheduling, the logistics management, as well as the certificate generation. Then there has been increasing use of digital technologies for capacity building and training, which we have used beautifully, because during the having witnessed the earlier pandemic of H1N1, this pandemic, every other day, using digital technology, we were interacting right up to the district level with the state governments. That was happening. In fact, for passing on the information. Previously, it was the mail and other things, but now this time we have used the digital technology for imparting capacity building for the health worker, the clinicians across the country, and it could happen because of the digital technology. The other vision is that we should be deploying IT tools for governance and information dissemination, which we have been doing now during the COVID time. We do have a digital mission, which is efficient. We are having a vision to have an efficient, accessible, affordable, timely, inclusive, and safe system, which is patient-centric, wherein all the policymaker, providers, private entities, health professional, non-profit organizations, they all would be working towards the benefit of the patients. And all the other ecosystem, in this ecosystem, you will be having central government, state government, program managers, regulators, association. This is in the development phase. Now you see that how the journey was accelerated in the National Health Policy 2017. We have envisioned to have a digital health technology ecosystem which recognizes the integral role of technology, that is e-health, m-health, cloud, Internet of Things, wearables, etc. in healthcare delivery. When the Ayushman Bharat was launched in 2018, we realized that we should be having a stack. And we released a national health stack that provided a framework for India's futuristic digital system, specifying component required in the health IT programs, which this translated into a national digital blueprint, which was finalized as an architecture for digital health in the country for evolution of digital health ecosystem. In this, it's not that we were not doing anything, but whole of the efforts started a decade earlier with the constitution of the Center for Health Informatics, National Center for Electronic Health Records, and National Resource Center for Telemedicine. We started way back in 2013. Now you see that how things have now getting smoothened and getting into motion. There are many digital initiatives which the ministry has been doing. We have an integrated health information platform. We have our hospital information system. We have reproductive health system. We are having National Medical College Network. We are having TV monitoring system. We have online registration system. We are having Mera Hospital, Kilkari, e-Raktkosh, but these are all fragmented and they are working in silos. If a common identifier is there, where what we have envisaged in the digital architecture, then this all systems will be talking to each other. And integrated health information platform is a step in that direction. These are the current challenges. The current challenges, as I mentioned earlier, we are having a fragmented health system, fragmented information system also, which are working and operating in silos. Apart from that, whatever infrastructure we are having, they are all stressed out. They are all overwhelmed with information collection and this. To compound to that, we are having a standardized format so that we don't have a standardized format which can be used across all the system. Hence, whatever information we are collecting, that becomes not interoperable. Multiple systems are collecting a single information. Suppose I am a person, my information is collected for immunization, my information is collected for malaria, for TB. As a result, lot of systems, they are all independent systems, resulting in data duplication. As a result, none of the data we could use, and this is leading to data redundancy. Apart from that, one of the important things we have tried to address is through the unique identifiers, which for the providers, for the patient, for the health facilitator, for the which we are trying to address. One of the important challenges which is there to having a common data analytics platform. Data is being thrown from various systems, but do we have the capacity to analyze that thing? We are talking about AI, blockchain, and other technologies. But for that also, for running that system also, we require data of good quality in a standard format. So that is an area where a lot of work is to be done. That is data analytics platform. And apart from that, we do have to have an adoption platform also. Which kind of platforms are to be adopted for having this use of this information system? Many of the systems which are developing, the preference, there is a least preference for the cyber security with data privacy issues and other things coming up. A bill is already there, which is under discussion. And if it is but the system, people who are making the system, they should focus on giving importance to cyber security as well. One of the important challenges in the adoption of new technologies, the applications and process to implement. You see, the OPD appointment system is there. How far it has been implemented and how far it has been effective in the public system, that needs to be reviewed. Apart from that, the health industry faces resistance in comparison to other industry. So we require a clear and comprehensive digital framework for addressing all this issue. But we do have an opportunity. The trend is that increasing use of IoT and devices, as Dr. Jamir has mentioned about the different equipments. We do have a promising 5G, wherein the other technologies and other things which will be used by surgeons and others, that would be quite accelerated there. We are using blockchain for creating things using data. We do have telehealth, which has shown that how a patient can be managed remotely in an ICU, as well as a patient can be managed through our e-Sanjeevani program at a primary health center level, sitting in Delhi or sitting in the state headquarters. We do have web portals for patients. Now you would be seeing a lot of things. We do have telemedicine, we have mobile health apps and portals. Besides that, we are now using increasingly the artificial intelligence for use of this. So we are moving in the right direction. With new technologies, we overcome the existing challenges and optimize our business processes. We need to adopt to the rapidly changing digital world and use technology to improve efficiency. One of the important aspects which is there, that identifying the problem or opportunity and determining how technology, including future technology, will solve it. But we have to critically analyze that how it won't solve the problem. So this is where the major bottleneck lies. But we do have a national architecture framework. We do have converging disparate health information system. We have given a blueprint for how we can have a federated architecture with open standards, with the use of unique identifier, privacy and consent management. These are all there. Architecture is there. So we are moving in the right direction, and we see that how the implementation of all this thing will lead to acceleration of the digital things in the country. This is all from my side. Thank you very much for this opportunity. Thank you very much.
Thank you, Dr. Mazan Gopal, for that very comprehensive insight into the digital world, and hopefully we move forward on it. But a little worry that goes along with it is privacy of health data of individuals. How do you prevent that and misuse of that, or even blackmail on that count? So that, I think, is a challenge which we have got to address also, because these are floodgates which are open for public scrutiny, And these platforms have to have cyber security, and I think individual security moving along with it, but a great work. And I think the pandemic has only helped perfect these tools to a large extent and help in administration of this pandemic in a very scientific way. Public must know, public needs to be informed. At the same time, the privacy and the integrity of the individual has to be retained. That is a challenge for big experts like you. Thank you very much, sir.
Thank you, sir.
Our next speaker is if Dr. Venkatraman had requested that he be allowed to speak unless he's already boarded his flight. Dr. Venkatraman there, please.
I think so, he's not.
Or
No,
Mr.
sir, he's-
Sudarshan Jain. There was a request from him also. If they're not there, then we move on to Mr. Neeraj Lal.
Sir, very good afternoon, sir.
Thank you very much, Dr. Neeraj.
Yes, sir. Yeah. Thank you very much, Dr. Garg and team for World Healthcare Conference. I'll be sharing my thoughts on the hybrid healthcare. We are moving to hybrid healthcare. Now people just coming to the hospital for the surgeries, procedure, and the critical care, but hospitals are going to the hospitals. I think thanks to the pandemic, which has changed the way the healthcare ecosystem work. If you see pre-COVID times, doctor used to do virtual consultation on a telemedicine network, which is less than 5%. Now, after the pandemic, I think penetration of digital healthcare is happening across the board. Because I know in Apollo, what we are attempting to do, say, for example, AI cameras. AI cameras are used to capture the emotions of the patient, capture the emotion of the staff, and capture the emotion of a doctor. Say, for example, in an OPD setup. So AI cameras is capturing the happiness emotion, the sadness emotion. We have experimented in one of our hospital. We have seen if patient is waiting for a doctor for a consultation, and if he is not very happy, he's sad. Our customer care manager, by the use of AI cameras, dashboards, they can see this patient seems not to be very happy. She approaches to the patient and say, I came to know you are not very happy. How can I help you? So all those things can be sorted out with the use of digital healthcare. Say, for example, a doctor coming to the hospital in the morning, his happiness index is 85%. While going out, his happiness index has gone down to 47%. A call will go from the HOD of the department or a HR head. Hey, doctor, you're not very happy. How can we help you? Is there stress on the job? So we are using these technologies for the benefit of patient care. I will be talking about OPD CSP. We have created one platform which is known as OPD Care Suite Persona. This is linked, it is actually happening in Apollo Hospital in most of our settings. It is linked with the appointment system and a HIMS of the hospital. As soon as patient takes an appointment, it gets reflected in the doctor dashboards. All the patient billed for the consultation also come to the dashboard. And it is linked to the nurses module, where she is supposed to take the vital of the patient so the doctor can see while the patient is going inside the consultation room. It calculates inside like BMI. So we have a predefined templates of various consultation, maybe medicine, surgery, and so on. These different templates, a doctor is spending more time in talking to the patient rather than jotting down his observation while seeing the patient. Voice recognition is there, so the prescription can be made. Machine learning is there. We have linked this OPD CSP to our lab management system and PACS, so that if doctor want to explain in the form of a flow of a blood or a diagram, it can be done. And we have seen with the help of this, our increase tracking we can do between OP and IP. We can reduce down on the stationery, and we can reduce the prescription error. So we are using this technology, and we are using health level 6, which Apollo have reached in most of the time. We have adopted many ICUs. So in the city of Ahmedabad, we have 75 beds, but we have managing around 25 ICU through the e-ICU concept. We are doing remote monitoring. We have machine learning. So all these small ICUs, which is managed by the critical care consultant in tier 2 and tier city. We connect their ICU, their multi-para monitor to our central command station, and our critical care consultant will helping these people and patient for optimum care. Apollo have also launched Apollo 24/7. So this is a hybrid healthcare platform where a request for the doctor, a request for the pharmacy, pathology can be done. Home healthcare is a big thing which is happening after pandemic. Now most of the people are not coming to the hospital. Therefore, we are going to their homes. We have started a concept known as we are coming to your home under the home healthcare concept. So most you does not require to come to the hospital for small thing. So the real tertiary care, if at all you require, you can come down to the hospital. And I think with the help of first time I have seen in the annual operating plan for the hospital, the focus has been given to the budget for the digitizing healthcare. So I think the coming trend is very good. More than 50% patients we are seeing on the digital platform in the form of OPD. Only they are coming to the hospital for the surgeries procedure as well as a critical care. So I just want to share my thought. Healthcare is growing with the help of digital technologies, using remote patient monitoring, using AI, and so on. Thank you very much for giving me time to share my thoughts.
I think it's been a very, very revealing talk by you, very optimistic. But may I just ask you straight questions? Has it reduced the healthcare cost? Because healthcare is a great expenditure today.
Yeah.
Far beyond, it's like the petrol bills.
Right.
The other is that what is the integrity of this data, the privacy of the individual, see in all this?
Right.
How is the individual sure that his privacy is not being violated or is not being exploited by a barrage of people bouncing on him through the electronic media, offering him all kinds of services and allurements? And number three,
right,
what is the law that is regulating this healthcare? What are the remedies for a patient who is subjected to this kind of a treatment? Because as a former administrator, I would keep the citizen first for anything. All these developments are excellent and they are the need of the future. But at the same time, we've got to ensure that we are transparent and that the patient's rights or the patient's charter is effectively updated to incorporate these modern tools of medical practice.
Right, sir. You are right, sir. These are the concerns which is there into the healthcare. But first thing, talking about the cost of healthcare. So the cost of healthcare is going down. If you see, most of the patients visiting to the hospitals are for primary care and the secondary care. So the cost of traveling has gone down. And since we are going home and we are doing a virtual consultation, our 47% of the consultation is on a virtual platform room. Say, for example, a mother, a father cannot bring his wife or a family member to the hospital by taking a cab or this thing. It has reduced. We have not increased the cost. And I'm sure most of the private hospitals have not increased the cost. Our ICUs, we are only taking care, like say, for example, the ICUs which is available in tier 2 and tier 3 cities. They used to come to the main mega cities or metropolitan cities like Delhi, Bombay, Ahmedabad, and so on. So now they are not coming. The primary treatment, the ICU, the bed which was available in the tier 2 city, now it is connected on our network. A critical care consultant with multi-specialty consultant is monitoring now. Since we have a tie-up with these all the ICU, we are managing these ICU, and they are coming to the hospital when they require for the high-end surgeries. We have started a diamond daycare suits where our 37% of the procedure we are doing on a daycare. So minimizing the hospital stay so that bed turnover is more. Now, number 3, you're talking about patient data and safety. Sir, we have a Apollo 24/7 network. It is a private network which is stored in a server. it has been on the platform like Google Pay. So it is a unique ID. I'm sure most of the people in this country are using various apps in order to deal like Swiggy, food delivery, your payments and all. So it is a private network which have full security control. Our server is based in two location, which is eCloud, and it is managing on using a blockchain technology. So far, we are controlling this thing, and Government of India is also very active. If you see now the new policy which has come with the same number, we have a 72 hospital network across the country. Say, for example, a person is there in New Delhi, transfer to Ahmedabad. So unnecessary the health file. He is not supposed to bring the health file. He is bringing the card with the same number. There's no need for blood test and all. We can see his private, his prescription, his pathology, his radiology which he has done. So minimizing the cost of this pathology and radiological investigation and connected to a healthcare ecosystem. So we are using all this thing in order to protect the patient rights as well as the concern.
Thank you very much. I think you see that's a very good model.
Yes,
You
sir.
are reducing energy use. You are also ensuring that the psychology of a patient is not affected, particularly when he is visiting a hospital in pain and sees more suffering.
Yes,
it
sir.
is certainly that trauma which a patient undergoes and the relatives undergo is minimized.
Yes, sir.
That is a great help. But I would say that, you see, have we updated a patient's charter in relevant to this? Enforceability of his rights. Supposing he's given wrong treatment.
Right, sir.
Right. Has that e-governance come into play? Because you see, being a career administrator, I always look at things that, yes, there's citizens' rights also. We all have to carry on our respective activities. And if we can ease doing business or ease healthcare, tremendous achievement. But at the same time, what is the relief of a citizen? Because there are the best hospitals in the country, unfortunately. I've seen some of them. And the security staff is paid more than some of the nursing staff.
Right, sir.
So that the patients who are in a state of anger do not come and gain entry into those institutions. And inside the closed doors, there's total opacity. It's the netherworld. It's the other world which you and I have been told exists, but we've never seen.
Yes.
That is how a patient sees beyond the ICU doors or beyond the hospital doors. Now, that is an area that I think those dark alleys that you need to address.
Right, sir. I agree with you. Fully agree with you.
Sorry, I'm frank, man. Because
No,
I've got
these are the gray areas. I think this charter is very important. We have created a medical board. Whenever some issues are there in the ICU or the critical care, instead of a one doctor, we created a medical board which is recorded and in which all the patient relative called and various specialists sit there. And so these are the things is happening. But you are very right. There are certain gray areas where we all as a hospital managers and administrators need to focus more on. I fully agree with you.
Neeraj ji, they're not gray areas, they're black holes.
Black holes.
I've been a student of physics. Okay. So anyway, now thank you very much. And I think it's a very, very good development. But it needs to be balanced with patients' rights also.
Yes.
I think if Mr. Sudarshan Jain has joined us.
Mr. Sudarshan Jain will be joined around 12:40.
Okay, then in that case, I think Florence Hudson, Miss Florence Hudson.
Yes.
The floor is yours, Florence.
Really?
Florence is the founder and CEO of FD Hint, and executive director of the Northeast Biodata Innovation, Big Data Innovation, sorry, Columbia University, USA. Please go ahead, Florence.
Hello, everybody. My name is Florence Hudson. I'm delighted to join you today virtually from New York for the World Healthcare Conference in India on April 2022. So I want to thank Dr. Anil Garg for inviting me very graciously. I really appreciate the opportunity to participate with you. And what I'll be talking about today is accelerating digital transformation in healthcare. So first, a little bit about me. So I'm founder and CEO of FD Hint LLC, which stands for Florence D. Hudson International, a global advanced technology and diversity and inclusion consulting firm. I'm also executive director of the Northeast Big Data Innovation Hub, headquartered at Columbia University in New York City and funded by the U.S. National Science Foundation. I'm also chair of the IEEE Underwriters Laboratories Working Group on Clinical Internet of Things, Data and Device Interoperability with TIPS. TIPS is a new framework we've been developing with IEEE, the Institute for Electrical and Electronic Engineers, since 2016. TIPS stands for Trust, Identity, Privacy, Protection, Safety, and Security, and we're also writing books about it. So a little bit more of my background. I'm a former IBM Vice President and Chief Technology Officer, Internet 2 Senior Vice President and Chief Innovation Officer, Special Advisor for the NSF Cybersecurity Center of Excellence at Indiana University, and I began my career as an aerospace engineer at NASA and at Grumman. So now that you know a little bit about where I've been, let's talk about where we're all going. So as we know, advanced technologies are enabling digital transformation all over and in connected healthcare. The Internet of Things, the Internet of Medical Things, leveraging artificial intelligence, machine learning, big data, or as I like to call it, distributed big data and analytics, because the data is all over the place, especially with these Internet of Things devices. And the opportunity is to leverage that data, increase interoperability, keep the information private, keep it secured, and leverage all this information to have more context and make better decisions. Augmented reality, virtual reality, extended reality, non-reality. There are a lot of new technologies. And then, of course, blockchain, or as I like to refer to it, the more general term, distributed digital ledger technology. So there are a lot of opportunities to enable all these new technologies. And it's really exciting because digital transformation and leveraging of these new technologies enables data access and interoperability to improve insights for precision medicine, making more contextual decisions, getting more insight. And there are many data sources and types and modalities. There's genomic data, clinical and fundamental research data, clinical care data and observations, different modalities, image, text, numerical, video, audio, what the human sees, what the caregiver sees, what the patient sees in themselves, what the provider or doctor sees. There's also life science and environmental data. One of my colleagues working at Harvard University, Dr. Chirag Patel, does research on genomes and exposomes. So genome, what you're made of, and exposome, what you're exposed to. Very interesting, and how that relates to potential healthcare outcomes. And then there's connected health and wearables data, the Internet of Things. It could be a brain implant. It could be an implanted cardiac pacemaker. It could be an insulin pump. It could just be an Apple Watch or a Fitbit. But all of these devices are gathering data. And if we have interoperability, we can leverage that data contextually to see what's going on, get new insights, make better recommendations. But how do we enable interoperability? And how do we enable it safely, which is what I'm really focused on. So how do we protect the devices, the data, and the humans? So there are two sides to this coin. Increased connectivity can bring all this value, but also can increase risk. So we think, what could possibly go wrong? Well, as I usually say, once you realize that everything is discoverable and everything is hackable, pretty much, then we can talk about what to do about it. So there is healthcare device hacking going on. Jay Radcliffe, whose picture is here, famously actually hacked his own insulin pump. And that was very interesting. It was on the news here. And when the hackers do things like that, he's an ethical hacker, then they share that data with the device manufacturer so they can do something about it. Pacemakers are hackable. There was an announcement in 2019, and then the FDA did a recall of 465,000 pacemakers due to hacking fears. The hackers could reprogram the devices. The devices are exploitable with adjacent access and low skill level. Adjacent access within, like 10 meters. How many people, if we were all together in one room right now, how many people are within that distance of you? Do you trust them? Should you trust them? Do Do you trust the device? Should you trust the device? Should your device trust another device? And the RF telemetry protocol utilized in these devices did not implement encryption. And 20 products utilizing this telemetry protocol were affected. So this is real. And what we need to do is make sure that we're trying to reduce this risk. There's also risk to scientific devices. It could be, MRI machines. It could be scientific research machines. All of this is hackable, and we need to protect the devices, the data, and the human. So we must secure the path forward as a team together around the planet, enabling interoperability for improved healthcare context and outcomes while protecting data, devices, and humans. So my top concerns are connected healthcare devices and data. They could quickly kill you, God forbid, if they hack into a device in your body. If they change the data, there isn't data integrity, and there's sensing and actuating going on. So actions are being taken on bad data. That could be very bad. Connected hospitals, campuses, cities, and vehicles. People in the vehicles, the hospitals. There are TV shows here in the US where there are ransomware attacks and the systems are going down in hospitals and they can't use the machines and they're in the middle of a robotic surgery. There's a lot of risk. And then clinical, scientific, and research device and data integrity risks I was mentioning. So we need to reduce the risk at the device level, the component level, all the way in the hardware, all the way to the intellectual property and the design of the chip that goes into it on a printed circuit board. Software and service hacks. We need to reduce the risk from the physical health and safety perspective, which could be related to these devices being hacked. There's financial risk and reputational harm to the companies associated with this, to the hospitals, to the device manufacturers. And then there's data integrity, privacy, and theft for data at rest and data in motion that we need to reduce the risk about. So we need a defense in depth strategy at the hardware level, the firmware level, the software, and the service level. And we need to evolve our policy, culture, and standards to address this risk. When I was still an IBM vice president a couple of retirements ago, I don't do retirement very well. So I retired from IBM, then I retired from Internet too. Now I have my own consulting firm and I work at Columbia. But when I was a vice president and I was developing the Internet of Things strategy at IBM and corporate strategy, I was working with KPMG. And so as they quote me here, they're going to try to hack everything. I'm most worried about security in healthcare, in cars and moving vehicles and critical infrastructure. And security really needs to be designed into IoT solutions right at the start. You need to think about it at every level, and then you need to continuously monitor it and stay ahead of the threat. So how are we going to do this? Well, we've been developing this new cybersecurity paradigm. We started this in 2016 with a workshop with IEEE, the U.S. National Science Foundation, the Department of Energy, the Department of Homeland Security, a bunch of industry, academic, research, and government entities. And we talked about the need for end-to-end trust and security for the Internet of Things. And we created this TIPS framework. So we look at this as the new cybersecurity paradigm, putting the human into the mix, putting the human in the middle. Not only do we have CIA, as we call it, confidentiality, integrity, and availability of data, but we need to maintain trust and identity of the data and the devices and the humans, privacy, protection, safety, and security. So what is trust? Allowing only designated people or services to have device or data access. Identity, validating the identity of the people, services, and things so you know if you can trust them. So trust and identity usually goes together. Privacy, ensuring device, personal, and sensitive data is kept private. And as you know, there are regulations regarding this. GDPR is one of the most popular ones, and there's more that's going to be coming, I would expect. Protection, protecting devices and users from harm, physical, digital, financial, and reputational harm. Safety, providing safety for devices, infrastructure, and people, and at the security level, maintaining security of data, devices, and people. And this affects all of our worlds. So we've been developing this TIPS idea and this TIPS framework since 2016. And we have a number of documents we've been creating so that people could learn more about it. So we have 2 IEEE papers, one enabling trust and security, tips for IoT, another wearables and medical interoperability, the evolving frontier, that are available on the IEEE website. These were published in 2018, and you can find them there. We also, in 2018, began a pre-standards work stream on clinical Internet of Things data and validation, interoperability with blockchain. Because IEEE Standards Association went to figure out blockchain for clinical healthcare and clinical trials. And as we did this pre-standards work, we realized it's not about blockchain. It's really about TIPS, having a real framework for trust, identity, privacy, protection, safety, and security. So this pre-standards report is also available on the internet. All this is free. It's behind a firewall, but once you go through it for free, you can download it just fine. So what we show here is this potential framework, and you see a lot of diligence in here, which is the depth we really have to think at. Starting at the top, always put the humans at the top and the devices that are touching the humans, the user experience and user interface, then the applications, precision medicine, artificial intelligence, machine learning, advanced analytics. Integration, many standards. As I say, the beauty about standards is there are so many of them, but FHIR, HL7, Jello, SNOMED, LOINC, you probably know some of these. Then the APIs, the application programming interfaces and software development kits that enable this integration. Distributed ledger technology could be part of it. Connection layers, data ingest and management, and all the data sources and targets on-chain and off-chain if you're using a digital ledger technology or blockchain type of capability. And up and down the right, you see all the TIPS elements: security, encryption, federated identity management, privacy, compliance, and governance at every level. So this is the level we're thinking at as we're creating standards now, working with IEEE and Underwriters Laboratories. So IEEE UL P2933 is the name of the working group that's actually working on this. And it's Clinical Internet of Things Data and Device Interoperability with TIPS. We have over 250 people from around the planet, 22 countries and 6 continents. When we first created this, they said, how many people will be involved? They said, maybe 20 or 30. And so many people realized this is an issue that a lot of people jumped in. So we have subgroups: trust, identity, privacy, protection, security, data and device validation, interoperability, intelligent integrated systems design, including artificial intelligence, machine learning, and then a wrapper of use cases and scenarios to explain what these mean. These requirements are, how they apply, what they would change, and the human factors associated with it. So you're welcome to join. It's free to join the working group. You could go to the website that's noted here, and you could also reach out to me on LinkedIn. As I mentioned, we're also writing books on this. There's a Women in Engineering and Science series at Springer Nature, and they've asked me to write a few books. So the first one was Women Securing the Future with Tips for IoT, published in 2019. Multiple use cases: smart hospitals, supply chain, encryption in servers, healthcare, all different areas. And then including the Large Hadron Collider at CERN, one of my friends there. And then now we have Women Securing the Future with Tips for Connected Healthcare, and that book is expected in the next couple of months. And I invite you to read it. I invite you to join the conversation. And in each of these books, I bring 17 women along with me to get them published and give them a voice. We also work between the Northeast Big Data Innovation Hub that I lead and IEEE to deliver a global connected healthcare cybersecurity workshop series. We did 5 of these workshops in 2021. You're more than welcome to go look at them. They're on demand, and they also have reports that were written by my students at Columbia regarding what the outcomes were. Global connected healthcare risks, cybersecurity risks and roadmaps, privacy, ethics, and trust, validation, interoperability for data and device identity, integrated system design and technology and policy. And we're planning more for 2022. So you can keep an eye on that at my website, fdhint.com. So before I go, I want to talk a little bit about how we're using artificial intelligence and machine learning in health research and how we're teaching artificial intelligence and machine learning in new digitally transforming ways. So the Northeast Big Data Hub, funded by the National Science Foundation, which I lead, headquartered at Columbia University, is a community convener, collaboration hub, and a catalyst for data science innovation. We have 4 focus areas: education and data literacy, including this very cool National Student Data Corps, which is now global, which provides open online data science education and to anybody, including in India or any country. We have people in Africa, Australia, Lebanon, Turkey. So you can go to our website, nebigdatahub.org, to learn more. And now what I want to do is talk a little bit about our COVID Information Commons, which is also funded by the National Science Foundation. We just got a $2 million extension at the end of 2021 to extend this for 4 years. So this provides an open resource to explore NSF-funded research addressing the COVID-19 pandemic and to enable researcher collaboration. There are a couple of thousand awards in here. We're going to be adding NIH as well, National Institutes of Health Awards. What we do is actually, I want to show you a couple of ways we're leveraging machine learning. So there's actually a COVID Research Explorer machine learning maps tool. If you go to the website, covidinfocommons.net, and when you click into it, you can actually see machine learning clustering of the awards. In this case, what I did is I put and machine learning, so against the awards. So these are about 78 awards where machine learning is mentioned, and you can see how it's clustered. What you can do is look at this information. You can identify, as an example, the institutions where they're doing the research, and then you can just click and change the view, and you can see who the researcher is. So I happen to know Michael Pisani because we do monthly COVID Info Commons webinars, and he presented on one of them, and one of his students did as well. So if you click on him and you go into the abstract, you can actually see he's working on explainable ML machine learning for the analysis of COVID-19 chest CT. So very interesting. So there's a lot of leverage of AI and ML going on, and it's increasing. So that's what I wanted to share with you today. I hope you found it interesting. Feel free to reach out to me on Twitter, on LinkedIn. Feel free to send me an email. And I hope you have a wonderful day and a great conference. Thank you.
Thank you, Florence. That was a wonderful presentation. As I could see it, F stands for fascinating in your terminology. I'm looking at what are the regulatory concerns as we are going towards telemedicine, remote medicine, Internet of Things. Is there a regulatory practice that is developing and a regulatory law on the subject?
This was a recorded presentation, and we will pass on this information to her and in a recorded way, so we will get quick answer. Okay?
Thank you. Thank you. May we have now the next speaker?
Aishwarya?
Mr. Sudarshan Jain there, please.
Yes, sir. Yes, sir.
Mr. Sudarshan Jain, if he's there.
And Dr. Venkat also, if we have Dr. Venkat, then we can have his presentation.
Is he back? Dr. Venkat? Dr. Venkat Raman Sudigali?
I think both of them are not here with us. We don't have Dr. Venkat as well as Dr. Jain.
Okay. Well, I think in that case, if Dr. Mazan Gopal, Dr. Pasha are with us, and also Mr. Neeraj Lal,
yes,
that maybe if they could engage in a little interaction with me on what Florence Hudson's presentation was. I thought a very futuristic kind of presentation, very analytical, using all the analytical tools, placing all the data for them, and see the tips, the cybersecurity paradigm that she has talked about. I think they're all extremely relevant in the emerging medicine. I know we're all in the midst of busy practitioners of medicine and professionals. If they are there to interact, I'd be very grateful if they can throw some light on this subject, on the state of development of these regulatory practices in our country.
Mr. Lal, if you could, we could have
Yeah.
some remarks
Yeah.
from you, sir.
Yeah. Dr. Anil, if you can just ask me again, I cannot able to hear.
Sorry.
Yeah.
No, you see what, Neeraj, what I was talking about.
Razvan, sir, you need to unmute, sir. Your mic went on mute.
You see, was talking about a lot of regulatory practices that are coming into play.
Yes, sir.
She talked of the STIPs, PPS, trust, identity, privacy, protection, safety, security, which she called the new cybersecurity paradigm. And she also talked of the enabling trust and security, which is coming out of the IEEE.
Right.
And efforts developed to have you see, data protection and device protection,
right,
and integrity. Now, what is in our country or in developing countries, are we using these things? She talked of recall of, I think, very, very, FDA had recalled 465,000 pacemakers due to hacking fears.
Yes.
Now, what is in India? Would you be aware of any such recalls or developments or interventions by any regulatory authority?
Yes, sir. In our country also, healthcare is progressing. And I always say this, thanks to this pandemic, I think this new healthcare policy, data security, consents and everything is happening. Regarding the recall, I know in a few of the hospitals where I was working in Bangalore and Hyderabad, a Medtronic has taken the stands back. There was a recall thing and around thousands of stands was taken from the various hospitals which they have given. Earlier, see, telemedicine was there in India since long, but there were no rules, there were no guidelines and all. We have connected through many rural villages and all. But now with the help of this new bill, which has come, which is talking about unique healthcare ID, like our PAN number or like our Aadhaar number. If you see now, the government of India have selected few hospitals in the country. Apollo is proud and privileged to have in that group, elite group, in which they are connecting the healthcare. Firstly, they have come up with the insurance. Now they're connecting these people with a unique healthcare ID, which they're telling UHID. So UHID will help us to access data. Say, for example, I'm seeing one patient. I cannot see any other patient data if that doctor is not linked to that portal. So like there is various healthcare level. We have reached to healthcare level 5 and the world best have reached beyond. So I think with the help of this Government of India initiative, most of the healthcare, say for example, you see the things pre-NABH and post-NABH. Until 2005-6, no hospital in the country was doing a quality practice in the form of a quality and accreditation. Now, over 5,000 hospitals in the country, both in small and large healthcare setting, they're part of this. So I think now good news is that pandemic have changed the way our healthcare is practices across the country. Now we are talking about data security, various platform and all. If you see last 3 years, many healthcare startups have come. Now I think with the help of these things, which is coming up into the healthcare ecosystem is changing. And like say, for example, JCI is there in USA for the last 60 years. And our NABH is just 10 to 12 years old. So I think we are there. We have started on a positive note. Now, most of the healthcare I was talking about, whenever we purchase a HIMS, most of the healthcare companies is talking about health language number 7. Most of the equipments are connected through our HIMS, which was not there earlier. I'm sure the healthcare positivity is there. And with the help of government support, we can connect to the healthcare setting. Say, for example, during the COVID time, the municipal corporation of various cities don't know how many ventilators and how many beds the hospital have. Now, some of the municipal corporation have created a portal where like it is like book my show. So if I want to book my ICU bed in one of the hospital, I can go to the website and see which ICU beds are vacant, which ICU beds are with ventilators, and I require them or not. So I can do that. So I think India is a big country, and we are in fact United States of India. We are country within the country. So, and since healthcare is a state subject, I think we can able to do that. I think a few years from now, I think we can have a digital healthcare with all the guidelines and all the consents and security which we are talking about.
You see, the specific question that I had in mind was, she talked of, you see, stents, for example, there's 465,000 stents withdrawn.
Right.
Or recalled, so to say.
Yes.
The same it's an unrelated field today, but a field that I deal with is, you see, there's been fire incidents.
Yes.
In electric vehicles, scooters.
Yes.
A CEO of Niti Aayog has said, in fact, that the recall policy should get very active.
Very active.
Wherever there's a failure, please recall the defective.
Right. Right.
Now, we're talking of stents. You talked of ventilators. What is the monitoring body? Are they performing properly, not performing? What are the incidents of recall, of malfunction of these things? You talked about the NABH or whatever that regulatory body is. But I'm also aware that how at the time of inspections in hospitals, suddenly all the parameters are put in order, and once the inspection is over, it is back to normal.
Right, sir.
It's
You're
like
right.
office inspections.
Right.
I know there will be failings in any system, but have there been incidents of recall in medical devices or in services?
So in our country, the recall of medication is there, which is controlled by a drug authority in the area. So there is an incident of drug recall whenever any medication has to be taken. It is a part of our quality practices also. Every hospital has to declare the recall policy. Regarding one incident which I know about the devices, which I was talking about, Medtronic drug eluting stents, which has been taken back because that particular batch was not okay. But I think now the regulation was not there across the country in the term of medical equipment and all. However, there is one of the law which they say, like say for example, cardiac cath labs, radiology settings and all, they talk about the expiry. See, you cannot be, like say for example, you're talking about vehicles. Therefore, the same thing, you cannot run the cath lab beyond certain number of working hours. It depends upon the X-ray tubes and all. So I've seen in few of the hospital when a cath lab has done n number of years with n number of cath lab procedure, you need to either extend their life or you have to replace with the tubes and all those things. But I'm sure as India is progressing fast, the medical equipment regulatory authorities, like we establish our medical device consortium in South India. So I think our parent body will be here, which will control all these equipments and when they are supposed to recall and all.
Thank you, Neeraj. I see on the screen Mr. Sudarshan Jain, I think, has just joined us. And since we have only about 7 minutes left for this session, may I request Mr. Sudarshan Jain to kindly make his presentation. He's Secretary General of the Indian Pharmaceutical Alliance. You talked of drugs recall and he was there. Very timely. Sudarshan ji, please go ahead, if I'm audible.
Dr. Anil Garg, first my apologies to the group. So can
आपकी आवाज टूट रही है.
Hello?
आपकी आवाज टूट रही है, जैन साहब. No, I'm having a break in your voice. Can we get your video also?
जैन साहब आप अपना वीडियो बंद कर दीजिए.
Is it clear now, sir?
So we can.
Or I will put.
Please mute your video so that we can listen you.
Anil,
2 minutes. 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 2
I think there is a big connectivity issue that we're facing.
Let him try. Let him try.
Yeah.
In the meantime, sir, one thing which I want to share, as you have raised the issue of the equipments, I've just cited an example how the information systems are important, because now we can track the equipment from the manufacturer to the site. But when the pandemic started, we were grappling with the issue of number of ventilators. So then we searched upon the installation base with the manufacturers, and we came to know that during the time 2019-20, around 80,000 plus ventilators were given, they were supplied, but only 36,000 were functioning. This kind of mismatch, that means use of digital tools for tracking this equipment would be very useful. Now we have been using digital tracking for the oxygen concentrators, which have been supplied to each and every sub-center, but similarly, that kind of thing will subsequently come into the system. I will stop here. I think Mr. Jain has joined.
Yes, I think very, very relevant, Madanji. Jain Saab, please go ahead. We can see you nice and bright.
Can you hear me, sir, now?
Yes, we can.
Okay, thank you very much, Dr. Garg. We have gone through a very unprecedented situation, and we are trying to grapple and develop our line. So we are having a big Indian Drug Manufacturers Association meeting in Bombay, where we are trying to learn what can be better. Now, as an industry, pharma industry, I think we have demonstrated resilience. During this period, we have supplied our medicine to more than 100 countries around the world, and we have been able to meet most requirements in the country. We can be proud of the fact that 180 crore doses of vaccination has been given. And if I summarize 5 learnings from the big thing, Dr. Garg, if it is fine, I will highlight those 5 learnings. First is the collaboration. If government and industry work together, they can solve any problem. And we have got the problem of making medicines available to larger number of population. And during the unprecedented times, we demonstrated that collaboration which was there and which was the hallmark during this period. So one is the collaboration, which is very, very important. Second is the role of digitization. And I will describe the role of digitization in 5 senses. Who could have imagined that the vaccine can be developed in 12 months' time? What developed Pfizer vaccine? We developed it up, and we did the clinical trial, we did everything. So development of vaccines in a short period of time. This would not have been possible, but better screening of the candidates and better screening which has been possible. Approval, third area which has been the approval process of the whole vaccination. So we came to the concept of emergency usage approval. And maybe perhaps my thinking is that model which we have developed for drug discovery during this period will be helpful to find the unmet needs going forward. Should a drug discovery process take 10-year time? And how we can improve the discovery, development, and access of medicine. There is a lot of learning from COVID, and it should be applied to this regulatory process around the world. Very, very important. The 4th area which I like to highlight, the supply chain capability, what we have been built. Right from sourcing of the products for vaccine, there are 150 ingredients, making sure that everything is available around the country, making sure how do you meet the explosive demand which takes place. So the supply chain systems which we have built around in many companies which were not there, and silos which have been broken. So not only with the government, but between the companies has gone up, which is very important. Supply chain. Manufacturing automation which has taken place. It would have taken more than 5 to 10 years, but continuous manufacturing, interconnect manufacturing system where quality and everyone knows that what is happening. So manufacturing system automation. Automation as far as digital automation is concerned, in terms of customer level teleconsulting today, which has become the whole model going forward. So, and even the way we take care of online, we could have had this conference. All of us are sitting at different places. We have been able to have this conference. So I will like to summarize some of the learnings. Crisis is a great opportunity. And the two big problem which we are having is the inequality or access of healthcare around the world, whether it is supply of medicine or whether it is availability of doctors now, or whether it is availability of infrastructure. This area, this pandemic has demonstrated that we have to deal with problem in a very high way. Can we train doctors for improving accessibility of medicine in rural places? Unfortunate part is that 2/3 of the population lives in the villages, whereas 2/3 of doctors are in the urban area. How we can use digital technology, how we can improve the process of discovery and development of drugs, how we can improve supply chain methods to make sure the availability of the products, and how do we take care of the employees given the whole thing. Now, if we take care of this, it will be a great movement forward and we will convert this crisis into an opportunity. Sorry, I joined late. I will stop, and if there are any questions, I will address Dr. Garg at this. Thank you very much.
Thank you very much, Sudarshanji. I think we have come to the end of our time. It's been a wonderful interaction. And if any of the panelists has a question to ask of another fellow panelist, I can leave a minute for that. I'm really thankful to all the speakers for their excellent presentations. Mazan Gopalji, would you like to put a few concluding remarks sitting in Niti Aayog?
Well, the work has started and we do have a blueprint and we are moving in that direction. It is time only, and we have to see that how the regulatory mechanisms also come up with data protection bill in Anvil. But simultaneously, as you have rightly pointed out, the cyber security, whenever we are making applications, we have to see that the cyber security angle is also being taken care. That's the thing. And second thing is we have to see whether a technology solution has been provided. Is it really going to answer our questions, or it is going to add hardship to that thing? It is building practice into technology or technology and the vice versa. We have to always see that whether we are building practice into technology. I will stop here, sir. Thank you very much.
No, I think you made a very relevant point, because I also firmly believe that we talk of no governance or less governance, but at the same time, you see, there has to be a parallel regulation. As devices are developing, as technologies are developing, and the individual is often the subject of all this. We've got to see that he doesn't become overwhelmed by forces, unequal forces beyond him, which he cannot control. All the measures that are being taken are for his welfare, presumably. And the governments of their day, they are in position to ensure that the citizen welfare is first. Technology will move forward, medicine, telemedicine, Internet of Things, these are there to stay. But the laws have to also develop so that there is no unequal development. And I mean, you can't arrest that totally. Inequality is inborn in the system. Even as they say, the length of the 5 fingers that we have in our palm is not the same. They commonly say कि पांचों उंगली ठीक नहीं होती, एक जैसी नहीं होती. Now that is part of it. Similarly, we're all placed, some are more blessed than the others. But what is the duty of the governments of the day? What is the duty of the professional bodies of the day? Is to ensure that this society for which we live and for which we work, we leave it a participative society, and also something in which the best can prosper. There's no hindrance to them. At the same time, those who are deprived are not left out of the party. I must thank all the presenters for this very illuminating and excellent talk and discussion. I'm enriched by it, and I hope so of the others. Thank you very much.
Mr. Chairman, I have to ask 2 things, 2 permission from you. Number 1 is, can we invite Florence for having a workshop on cyber security and protection of data, as well as security of data, medical data, in the next conference in person.
Absolutely. I was of the same view that I think she has certainly touched an area which is very close to my heart, and we would all benefit
And
by that.
second thing,
workshop.
one more thing.
That can be the theme workshop in your next year's meet.
Yes, sir. And second thing, we wish to change the dates. 14 is our Ambedkar Jayanti or something, and holiday. Even we cannot contact our ministry and Prime Minister's office, though the message was ready in Prime Minister's office, but we could not able to get. So next year we will have 12 and 13 April for the conference, healthcare conference. So we generally never change dates, but keeping this in view, 14th is a
public holiday. But,
yeah, public
but
holiday.
Dr. Garg, you see, Sunday is still a Sunday, is a holiday for us. And if it falls on a Sunday, but I agree with you that
yes,
public national holidays could be avoided as far as possible.
Yeah. So we will keep next year 12 and 13 April for the conference. Thank
Please
you,
go
sir.
ahead. Thank you.
Thank you, sir. Thank
you
you.
very much.
I have to thank all the panelists and Mr. Chairman for ably chairing the session and asking very, very relevant and pinpoint key questions. Thank you very much, sir.
Thank you. Namaskar.
Thank you indeed, gentlemen, for having joined us for a very stimulating session on accelerating digital transformation in healthcare. I'd like to thank all the speakers, Dr. Zamir Pasha, Mr. Sudarshan Jain, Dr. Mazan Gopal, Mr. Nitesh Lal, Ms. Florence Hudson for excellent presentation, and of course, Mr. Anil Razdan for chairing this session so wonderfully. We'll slip into a very short Power Connect lunch, and we'll be meeting in 1 hour from now, and we have the next plenary session, and that is going to concentrate on artificial intelligence, big data, blockchain, deep learning, and robotic surgery. So that is coming up in 1 hour from now. So looking forward to a great session in an hour from now. Thank you so much, gentlemen. Looking forward to your participation in the next session as well. Thank you so much for having joined us. It was indeed a pleasure having all of you. See you in an hour. Thank you.
Thank you very much. Thank you very much. Thank you.
हाँ पुनीत, ये डॉक्टर उमा नाम्बियार और इनको देख लेना।
Welcome, Dr. Uma.
Hi, thank you. Just
welcome.
गुड आफ्टरनून उमा जी।
हाय सर, सॉरी मैं ना आपको वापस कॉल भी नहीं कर पाई, मैं कोलंबो में थी और जस्ट आज वापस आई सुबह, so the whole thing got a little bit messed up for me. It's okay, but I'll manage.
Welcome, sir. Sir, the session will be start around 8 minutes, after 8 minutes at 2.
Sure. I was requested to join few minutes earlier to check the technicality.
Yes, yeah. You have presentation?
Yes.
So please check with share screen.
Should I share the screen?
Yeah, just we have. Yeah.
Is that okay?
Yeah, it's fine.
And I'm just moving the slide. Just check on that.
Yeah, it's fine. Thank you. Thank you.
Great. So I will stop sharing now.
Yes.
Great. Thank you.
Puneet, this session shows 4 speakers. We have 3, right?
In the session, Mr. Krishnananda Suri, he will be joined. And
No,
Professor
no.
Tanjila Sabha from UAE, Saudi Arabia.
3 people, no?
Yes.
Yes.
Yeah.
3.
That's right. Yeah. So, Mr. Ranjit, where are you based out of? Delhi?
Mumbai.
Mumbai.
Yes. Namaskar, Dr. Saab. Your audio is off.
Namaskar, namaskar ji.
Namaskar. You have made a fantastic arrangement. Wonderful.
Thank you. Thank you.
Very nice.
Umaji is always motivator.
Yeah.
For all these things.
I heard about her a lot.
Yeah.
I think we should connect after the conference as well. We should connect and figure out. Yeah, that'll be nice.
Definitely. And Umaji, we thought that we should keep this conference on 12th and 13th of April.
Ji, sir.
Next year.
Okay, okay.
Because this 14th is a date which is
बैसाखी होती है, हाँ नहीं
holiday.
बैसाखी है, कई लोग available नहीं होते.
जी जी. And particularly government officials and even Prime Minister's office.
They are on holiday, right?
Yeah, their message is ready, but we could not able to get.
Right.
So we will keep next
I
year.
know. In fact, it's many places it's like holidays, so people
Easter.
are celebrating.
Yeah.
Yeah. So even audience में भी कई लोग नहीं आ पाते क्योंकि सुबह पूजा वूजा होती है, फिर सब लोग अपना अपना फैमिली के कामों में लग जाते हैं. ये बहुत होता है.
Good afternoon, Dr. Uma.
Hi, Aishwarya.
Hello, ma'am. Good afternoon, sir.
Good afternoon, Aishwarya ji. How are you?
Fine, sir. How are you, sir?
Fine. Thank you so much.
Ma'am, we have Professor Tanzila Saba and Ms. Ashima Gupta as the speakers, but they haven't joined in as yet. So we are hoping that they'll join us, but we can, start off at 2 p.m. and probably, start with the presentations and, if they
Yes,
come in,
sure.
then
Sure.
they'll join in. So, ma'am, we'll start at 2 p.m. sharp if you allow.
Yes, of course.
Oh, all right. So we're just waiting for 2-3 minutes more, and sharp at 2 p.m. we're going to start the session. Second.
How many participants are there, Aishwarya?
So actually, there are 4 speakers, but at the moment we have 2. Of course, yourself, and we have Mr. Krishnan Suri, who has joined us. Good afternoon, Mr. Suri.
Hi, Aishwarya. Good afternoon.
Aishwarya, he wants to know how many audience participation is there.
I would not be able to determine that. I think our IT team would be able.
No problem. It's fine.
So, ma'am, since we have already 2 speakers and we're waiting for the rest to join us, with your permission, can I just start with the plenary session?
Yeah, yes, please go ahead.
All right. So, all right. Good afternoon, ladies and gentlemen. Very warm welcome to the plenary section 2nd of the World Healthcare Conference. And this session is going to focus on artificial intelligence, big data, blockchain, deep learning, and robotic surgery. And we are very pleased to have an eminent panel of distinguished people here who are going to dwell upon this very important topic related to healthcare. And Dr. Uma Nambiar, Chairperson, Digital Health India Association, is going to be the chair for this session. Officially, a very warm welcome to you, ma'am. Let me introduce.
Thank you so much.
Let me introduce the key speakers for this session as well. We have Mr. Krishnan Suri, Health Pair Lead, Accenture's Advanced Technology Centers in India, that is ATCI. Very warm welcome, Mr. Suri. We have Mr. Ranjit Varshikar, CEO, QBD International and United Nations Advisor, MPP Geneva, and editorial board member, Journal of Generic Medicines, UK, also joining us. Very warm welcome, Mr. Ranjit, to you as well. We'll have 2 more people who are going to be the speakers for this session. Professor Tanzila Saba, Associate Chair, Information Systems Department, Research Professor, IEE Senior Member, ACM Professional Member, and Artificial Intelligence and Data Analytics Lab Leader, and Associate Professor, College of Computer and Information Sciences, Prince Sultan University, Saudi Arabia, who's going to join us soon. And Ms. Ashima Gupta, Director, Global Healthcare Solutions, Google Cloud from the United States, is also going to join us soon. So I'll request Dr. Uma Nambiar to please begin with the plenary session 2nd. That is going to focus on artificial intelligence, big data, blockchain, deep learning, and robotic surgery. Over to you, Dr. Uma.
Thank you so much. And it's my pleasure to meet this panel, which collectively has more than 80 years of experience between. And I think if you include my experience, and we are crossing the century. Okay, so we are like, with more than 110 years of experience amongst us. But talking on things which, many of us are still in our infancy in learning. I think artificial intelligence, blockchain, big data, all these are something that has entered our life and our, I would say, the professional circles, and we've started talking about all this in the last 5 years, or maybe extend deeply, some of you maybe in the last 10 years. So it's an interesting aspect, and it is very exciting, and also the amount of confusion that abounds, at least in the user space. I'm from the user space, and the fear mostly because we don't know. So the fear of the unknown is always there. And because we have the panelists is a good mix of, compliance territory and also from the user stakeholders. So I'm going to invite Mr. Suri to really give his views on the topic and take his talk and enlighten us. To start with, Mr. Suri, please, over to you.
Absolutely. Thank you, Dr. Uman Amir. May I request tech team to flash the slideware for me? Fantastic. Thank you so much, tech team. Appreciate that a lot. Good afternoon, distinguished dignitaries, guests, and my fellow speakers. Thanks for the opportunity. Privilege representing Accenture in this forum. I am Krishnanand Suri, healthcare payer practice lead at Accenture. In my role, I collaborate with healthcare organizations, both payers and providers, right? Payers, quote unquote, health insurance companies, providers, hospital physicians, globally to solve their business problem at the intersection of industry and technology capabilities, right? Part of my role, I'm also responsible to build and curate technology offerings to healthcare clients and align with their strategy and business goals, right? So let me set the stage for our discussion today with what a great health experience looks like, right? If you could advance to the next slide. So healthcare ecosystem across the globe were tested in ways we never imagined possibly last year, right? So what we have done is between 21 to 22, we performed a health and life sciences experience survey, talking to 12,000 plus professionals, patients, members, citizens across 14 countries, right, to measure the effects of healthcare challenge overall. The results reveal that people no longer look at healthcare as one size fits all, right? What we learned was from the respondents that there are 4 key facets, right? Let me briefly touch on these 4 facets. Number 1, personalized and affordable care. Technology-driven convenience and accessibility, protecting the data. Like I think the speaker earlier from US was talking a lot about data, so we'll probably touch a bit on that. And then the 4th component, which is the equitable access for all, is an overarching theme for all the 3, which kind of congregates all the 3 themes, right? So let's see if we can touch briefly on each of these aspects, and then deep dive a bit more how we are able to connect the dots to digital technology. Now, personalized care aims to improve the quality of care, right, which reduces the overall healthcare costs, right? And we look at it in 3-dimensional way, right? Like I was mentioning earlier, 1 from payers' hat, right, the insurance companies' hat. Number 2, from providers' perspective, right? Hospitals, doctors, physicians, and number 3 is from actual members, aka patients itself, right? From payer standpoint, the paramount objective is to eliminate the wasted medical spend, right, that is caused by misuse, overuse, or underuse of the medical delivery system itself, right? From a provider lens perspective, if you look at it, we've seen the evolution of value-based healthcare delivery model, right, where hospitals and physicians are paid based on the patient health outcomes, right, not predominantly on the delivery of services. It could be diagnosis or procedures per se, but more focus on value, right, instead of volume. right? From members, we have seen increasingly anxiousness to manage their own health all by themselves, right? Which is self-help, supported by certain technology developments, right? And virtual care adoption is a huge testament to that. If you look at the second aspect, right, where our survey revealed that significant growth in virtual consultation during COVID pandemic per se, right? I mean, it drives to the fact that the convenience is really driving it, right? Convenience is the biggest incentive for the use of digital technology, right? Healthcare organizations diversified their care model, omni-channel presence, right? Like they are there in the internet, they are there on the video, they are there on the phone, every which way, right? They're trying to do a delivery of the healthcare, right? And then data aspect, right? Data is the new gold, right? This applies to many industries and more prominently for healthcare, right? More and more devices appear in the market to generate, humongous amount of data, right? Healthcare institutions produce enormous data. The pandemic actually also has really accelerated that, right? The piling of the data. And the third, which is, like I was mentioning, is the overarching theme, which is the vision for having the equitable access to all forms. Now, if you could advance to the next slide for me, let's take a look at how digital solutions are able to connect the dots, with all these four themes, right? If you could go to the next slide, tech team. Yeah. All right. Now let's zoom into personalized and affordable care for a second here, right? Now let's take a simple example, right? Fall, right? Which is falls, we call it, right? Falls can cause fatal injuries or can even lead to death, right? And this is very prominent in senior citizens we see of late. Falls, this will be a eyebrow raiser. Falls are the second leading cause of unintentional injury deaths worldwide, right? And it is only increasing multifold, right? And this is, like I said, prominent in senior citizens. Now, how technology is helping solve that basic problem, right? Using AI and ML, right? Technology is really coming to rescue to address this problem. And there is an evolution in technology. For example, IoT devices, which are powered with AI and ML, right? What happens is, the way it works, you wear a IoT device wearable on your wrist, right? And then that is pre-fed with algorithms with walking patterns and fall pattern recognitions, etc. Right? Therefore, whenever it crosses that threshold, it kind of alarms, right? It kind of gives you an alarm to be alert, right? And see if you can avoid the fall by yourself, right? Or if a fall occurs, it even detects and then gives a call to your emergency contact, right? In a North America scenario, it gives a call to 911 so that you can get help immediately, right? And even there is an advancement in the evolution of IoT device where, especially in the senior citizens where the support is limited, where let's say they are living all by themselves in a house, they take this IoT device and wear in their wrist. When a fall happens, the IoT is going to trigger the inflated balloons, like your airbags, right? So that the airbag comes around your neck, covering your head and the hip area, because that's where your injury could be fatal, right? And again, from there, it kind of gives a phone call to emergency contact or 911. So that's what we see the advancement of technology to help some of these healthcare problems using AI and ML, right? Another good example, I know one of my colleagues earlier touched on this topic. I think Neeraj Lal from Apollo, yes, talked about smart beds, which is a classic example of NLP, right? Is solving the problem today, right? Which is happy fear reduction. I really love the way he has kind of articulated it. What at Accenture, what we've done is we've gone a step forward, and we've also created some NLP algorithms, let's say for a paralyzed patient, right, where they cannot move their limbs, right? They're just lying on the bed and require some help, right? Let's say they want to recline their bed and watch a TV or eat food or something like that, right? So what happens is you can control the motion of the bed reclining with your eyebrows, right? With a bed reclining. Like for example, you do this, the bed is going to go up, right? You do this, the bed is going to go back, right? So we've done a prototyping of such use cases, right, which is going to come extremely handy using NLP technique, right? Now, similarly, there are multiple use cases that we could see how technology is helping in case of data using big data. Similarly, technology-driven convenience using virtual reality. What I want to do is I want to take a couple of more examples to show you, how Accenture is innovating in each of these problem areas using this technology. If you could advance to the next slide, if you don't mind, please. Yeah. The first facet that we have seen, which is affordability, right, which really boils down to medical cost reduction. In this example, I've taken a sample health payer, right, to see how a payer can eliminate wasted medical spend. In other words, abused medical spend, right? One of the major lever comes from utilization management, right, by efficient management of prior authorization, right? Let me give you a layman example of what a prior authorization really means, right? Physicians and healthcare providers must obtain advance approval from health plan before a specific service can be delivered to the patient, right? From a payment coverage standpoint, right? For example, it could be, let's say, a patient will have to go MRI scan, right? So a prior authorization needs to be sought from health insurance company before that service or diagnosis is performed. So what happened during pandemic, right? Pandemic has really forced to accelerate the pace of the cost. So some of the, some governments, right, they liberalized this prior authorization, right? Which means that, hey, when a patient comes, we don't have to really go through the prior auth process entirely, right? Therefore, focus more on the treatment first. What really happened was the cost of medical delivery has gone up significantly. So there is eminent need for COOs and CTOs, an urgency to see how we can reduce the medical costs. So what Accenture offers is the platform that you're seeing on the screen here, which has got three major components, which is medical cost forensics. This basically captures the data from insurance companies and then model the areas of opportunity based on the internal trends and anomalies, right? Likewise, you see clinical value targeting, which is primarily based off some of the critical hypotheses we have kind of curated 400 plus to identify the cost leakages. And then the third component of that is the clinical review optimization, right? Which is to understand what is the ROI, right? Let me give an example of the CRO, which is, let's say a patient will have to go through a hip surgery, right? Whether the person will need to do a prior authorization or is a question, right? If the hip replacement surgery itself costs, let's say, $1,000, whereas your prior authorization, the entire process itself is taking, let's say, $1,100 to $1,200, right? The ROI is not great. Therefore, they will have to revisit the policies. So this model really delves into analytics using AI and ML to really understand what is the ROI on specific services that a healthcare payer needs to perform. If you could advance to the next slide, please. This solution kind of ties back to the data problem that we've discussed earlier, right? Which is, in today's healthcare scenario, there are a number of data sources, right? And the data that you see here on the top side of the slide, where the spend of healthcare on data has grown from 14 billion from 2019 to it's going to go to 50 billion as a forecast till 2024, right? Which is a humongous spend, right? But are we really making the best use of data that is available? I don't think so, right? I mean, there's a poor insights that are being drawn from data today, right? Classic example, you get multiple sources of data, right? Which is structured, unstructured, image data, the streaming data, right? Structured is one that comes from EDI sources, like the standard 837 claims forms, FHIRs and HL7 formats, right? The unstructured data is data generated from doctors' notes, right? Or discharge summaries or lab reports, etc., right? And then if you look at the streaming data is something that you get from bedside, right? Which is the radiography images, the ultrasounds, or the vitals, etc., right? Or maybe it could be the data that you get from wearables, right? The walking steps or the HR, data, etc., right? So channeling and curating this data is extremely important, right? What you see on the screen here is Hadeep is a solution that Accenture is taking to its client as an innovation, right? You see 3 steps in that, where there is a structured and organized way of capturing the data in the first step, right, where we take origination, where the data is coming from. can do a data acquisition in a very organized and structured way, and then we curate the data using MI, AI and ML technique, right? Using data processing and preparation, using the standard libraries that is built based on artificial intelligence. And then finally, we kind of consume this data in a standard format, which means converting these unstructured, streaming, and some of the structured data into a solid structure format, which is industry compliant and can be consumed by different downstream systems, right? And therefore derive some of the insights from there. So this is another powerful data-driven innovation that has been, I think, picking up a lot of interest from a lot of the hospitals and health payers. If you could go to the next slide, please. This is a very interesting, looks trivial problem, but very prominent that we are seeing these days, where there are a lot of anomalies and accuracy problems in maintaining the provider directory, right? This is more than 5 billion market, right? Where you see 55% of providers have at least one or more inaccuracies, right? Which is, let's say, change in their phone number, change in their address, etc., and it is not maintained properly. 50% of the data is changing every 18 months, right? And the data is all over the place. Like if I am a member or a patient, who would like to reach out to a specific provider, it's more often than not I reach out to a wrong person, right? Or maybe a out of network hospital to take care of my services, right? So to solve this problem, I think what we've done is we've built a network, right, which is going to be regulated for payers and providers on a permissioned blockchain, right, where you have a single source of truth, right, where payers and providers update the data on a specific blockchain integrated network where members and payers and providers can access it, right? And then the impact of this is the cost of maintaining is going to go down by 2 billion. You can advance to the next slide, please. This ties back to, this is a pretty interesting use case I felt. This ties back to the virtual reality that we were mentioning earlier, right? A proprietary Accenture offering called Maya, right? This is specific for physiotherapy. If you could advance to the next slide, please. Next slide. Yeah. Physiotherapy landscape today, right? It is huge. It is a 19 billion market, right? Average physiotherapy costs anywhere between $50 to $350 per session, right? And then this is only increasing leaps and bounds by 300%. Now, what is really happening to patients in today's world, right? We see a non-compliance of 70%, which means 7 out of 10 people who are supposed to take the physiotherapy are not taking today, right? Why? Because the exercises that they're seeing are not interesting enough. There is no motivation, right? They feel boring. They feel like it is very boring. Therapy is without a therapist, and they feel it is not fun or a social activity anymore. Therefore, it is causing a big issue from a compliance standpoint, right? Now, let's see how it is addressed today in a traditional format. If you could go to the next slide, please. Let's take an example of a patient who has undergone a significant stroke event, right, and has a loss of ability to move their left hand. What happens today in the traditional treatment, right? Patient has completed the active treatment. They go to the doctor. Let's say their left limb is not normal and right limb is normal. Then they do a mirror therapy, right, where you put your right limb, which is active, on one side of the mirror. The other side is your left hand. Now, typically what happens is brain deactivates the cell of a dead limb, which is not functional limb, which is the left limb in this case, right? By doing this mirror therapy, what happens is they will make you move your right hand, right? So that it kind of brain sends a signal from eyes looking at the mirror, thinking that left hand also is moving, and therefore brain will start sending the signal and activating your cells to the left limb also, right? Is it really successful? Well, maybe not. Right, the rate of success that we have seen in this kind of traditional format of treating the physiotherapy is low, right? So for this, I'd like to show you a neuro simulation technique that we have created. Tech team, if you could play the video, don't mind. Video number 1. Video number 1, please. Tech team, if you could play video number 1 for me. Yeah, there you go. Thank you. Yeah, so here, so what's really happening is patient is guided with these exercises, right? These are more gamified exercises, right, to improve the patient engagement. So patient is allowed to wear a VR wearable glasses, if you will, right, where they see what you see in the motion here, right, where it can be simulated. There's simple instructions. Patient can take it at their convenience, at their place. Let's say I want to do my physiotherapy on a beach, right? You can do a beach setup in the VR, and then follow the instructions that you can see on the screen, right? And then do the motion of, let's say, left to right or whatever the case is. I think we have tested this specific VR-based physiotherapy technique on some of the patients, and the success rate has slightly improved from the traditional models, right? You could also see another example. If you could play video number 2 for me, please. Yeah, this is focused more on a patient who has got tight shoulder, right, a stiff shoulder where they're not able to move the shoulder. So this kind of gamified physiotherapy technique using VR is going to show you a ball to place it on a specific placeholder and then put it back on a little cage. So that kind of gives you a real-time movement based on the instructions of your left to right shoulder, etc. Right, and this also has given a lot of success factors per se. So net, the VR solution that has been created puts patient at the center, right? Which means taking the physiotherapy at your convenience from hospital to wherever you want. Let's say you want to do this physiotherapy in a park setup or a beach setup, right? And then we've also seen that the compliance with the tested population, the compliance has improved from 30% to 80%, right? And then the visits have come down to 80%. And then there's a recovery rate also has been increasing 50%. Now we wanted to take one notch up, right? Which is currently in a pilot phase where as the world has evolved with virtual reality to metaverse, right? That is the buzzword now, right? Where we're developing a real-time tracking of movements where physiotherapists can monitor the actual movements of the patient as an avatar, right? They create a virtual world where you have patients as avatars, and then the physiotherapists as a doctors coming in as an avatar, monitor you real time, right? That will help closely guide on the positions and range of the body as the patient exercises, preventing injury and enhancing the curated progress. Right. So the benefits are experienced by patients, providers, and payers equally, and we see a potential of expansion in additional areas like let's say solving a vertigo problem of heights, right? Let's say solving areas of physiotherapy or rehabilitation per se. Right. In closing, I wanted to mention that patient is at the center of innovation and healthcare delivery at Accenture. Right. There are plethora of innovations featured in our virtual booth, so I would encourage the participant to go to the Accenture booth that is set up in this conference and take a look at some of our innovations. With that, I would like to kind of take a pause for any questions. Otherwise, back to you, Aishwarya.
Thank you so much. And what we'll do is we'll do questions at the end. That would be better. So can I invite Mr. Ranjit for his delivery, please, Mr. Ranjit?
Yes. With the permission of chair, I would like to add 2 things. Number one, that our whole conference is on patient-centric approach. So you have, Mr. Suri, you have very well positioned patient first. Then second thing is that innovation. We are searching from last few years, innovation which is comfortable to the patient as well as cost effective, reduce the cost to the poorest of the poor, make it affordable. And if you come across any organization, any individual, any equipment, and Madam Chairperson, we request your organization also, device manufacturer, then we wish to recognize that organization, person, or the group for their contribution. Thank you very much, Mr. Suri.
Thank you, Dr. Anil, that much.
Yeah, Mr. Ranjit, you can over to you.
Yeah. So thank you very much, World Healthcare Conference, Dr. Anil Gargji, for invitation on a wonderfully organized this 2 days program on a very, very vital subject on artificial intelligence, blockchain, and all latest tools from automation perspective. And the plenary session 2 was the opening batsman did excellent job by giving a lot of information from the Accenture perspective on the healthcare related support and availability of the tools from Accenture, as well from the guidance perspective to the healthcare industry. So I'm going to take next step into this area, and I have been requested to speak on the pharmaceutical industry applications of artificial intelligence. Just quickly, within a few seconds, I have a 51 years of pharmaceutical industry experience, madam. And I have worked maximum time with Pfizer International. And after retirement in 2006, I have worked with the vaccine manufacturing companies, and I was advisor to the chairman of Serum Institute of India, Pune, and also advisor to Mukesh Ambani for their life sciences division. And since then, I worked with the World Bank as a quality expert for 10 years. And now I'm working with an advisor with the United Nations, Geneva. So I'm going to put in a lot of things into my presentation from the perspective of various experiences in the industry of 51 years. And it has been a great privilege, my privilege, to be part of this wonderful organization. So thanks to you, Dr. Anil, for inviting me for this program. Allow me to share my presentation now. Yes. Is this right? I hope you are able to see it properly.
Yes,
So
yes.
this is artificial intelligence application and benefits as well to the pharmaceutical industry. And as usual, I have the disclaimer, which in all my presentations worldwide, I do this as a precautionary measures for the participants. Interesting thing, my friends, I have seen the lovely document of Government of India, Niti Aayog, of June 2018. And they have got wonderful information there on the strategy for AI for all. And also, I was very much impressed by the Government of India's initiatives for starting training programs in artificial intelligence and its tools for the industry benefits and the universities as well. So it's really good initiative being taken by Niti Aayog. I would like to take you right through the current scenario of Industry 4.0, my friends. 4.0 is nothing but automation. And most of the automation, the outcome today, rather till yesterday, let me put it that way, is of a more on reactive mode. And today we are talking on the relation to the pharma perspective, pharma industry perspective as a pharma 4.0, my friends. And here we are referring completely about the connected plant. And what is that connected plant? It is all the millions of data points which are generated all over the site in the manufacturing location, and all our dots are collected, analyzed, and the analysis of that data generated is done, which was not done till last more than a year ago. And now the things have become more and more simpler for the industry to ensure to use that data to predict now, predictive analysis. And we are into the now the world of predictive analysis from quality and production perspective to minimize the variations in manufacturing and testing aspects, and try to advance to a real-time test, real-time testing, real-time release of the batches to the market, to move the batches with a high speed to the market. Reliability of the data to minimize the variation, and the energy consumption reduction. So all this was possible due to various advanced robotic technologies in IoTs, AR, the 3D technique for printing of the products for specific consumers as well, cloud computing and cyber security, obviously, which is required. So Pharma 4.0 is now leading the industry very, very effectively. So we are now moving from reactive reporting to the predictive analysis. And that is where the ISP Global is helping the pharma industry to ensure the digital data maturity, digital outcome maturity from the perspective of resources, information system for the manufacturing side. But what is important, they are focusing as well, is the culture of the manufacturing site or a corporate office. So there has no doubt several benefits are there, but why this has been a big benefit is there are several, but I have listed here few pain points of the pharma industry. Of course, the commercial aspects are always there, increasing the costs, the lower revenues getting generated due to the cost effect, the delayed launches, and there are a few product recalls which are through the global market because of various issues, and more issues are coming from the quality perspective of the product. And as per the survey done by United States FDA, almost 62% of the product recall from the market are due to the quality issues. And that is why there are shortages in the US market, and they are also strongly supporting now the AI utilization, digitalization of the industry. And US FDA has already published very good guideline and document from that perspective for the support of the industry so that they can start implementation of these for more efficient automated processes, data-driven decisions that are more on a predictive analysis basis, so that improved process monitoring, more accurate design space for any specification ranges, high speed operations to minimize the rather production time, to increase the productivity. The timely launch, obviously it has a tremendous effect as a cost savings. And in several cases, we have seen that we are almost getting 80 to 90% productivity, high productivity. So that itself is a big gain for the industry. And of course, all these automation is helping the quality of the product as well, which is keeping in mind the patients first, and the patients being most important for us. They are keeping us into the business. We have to ensure they are satisfied customers. And therefore, there are several applications now actually in pharmaceutical industry right from clinical trial and clinical research perspective. Then product development, though it is a quality by design concept is being implemented now. In addition to that, this artificial intelligence is tremendously helping us due to the heavy data points now being analyzed by the system. And of course, quality assurance and quality control lab, drug discovery as well, right from original molecule and to manufacturing of the pharmaceutical product and the pharmaceutical product development. So overall, you will see here this application of AI into the pharma industry is in every department. For clinical research, it is improving the trial quality. You see, the tremendous trial quality is benefited, reducing the trial time because you're accurately now checking the right volunteers are recruited. That's a big advantage, and with a high speed. Usually it takes right from 6 to 6 months to have recruit the patients or the volunteers, but here it is done in few minutes itself. And it reduces the volumes of data and the text all along, and benefit is obviously the cost savings and the speed. In manufacturing, it identifies timely the quality compliance issues, predicts the bottleneck of the process which is going to happen. So in advance, it informs that at a particular next few steps, and you are going to have some problem, take corrective measures now, and it also suggests the corrective measures. That's the beauty of artificial intelligence, and therefore it identifies the process anomalies and predicts the quality issues in advance to eliminate the quality issues. Over and above, the robotic process automation, which I'm going to discuss in next 2 slides, is it automates the batch releases completely. And this automation is helping us on a real time, real release, is that as soon as the step is completed, a critical step is completed, you are getting automated result printing. And you don't have to worry about anything else. There is no sampling, nothing. It is full automation. That is where I mentioned to you about 80 to 90% productivity increase in manufacturing, because you are saving sampling time. You are not now waiting for a QC laboratory to test. This is fully automated testing. That is, and therefore this predictive maintenance, which is enabled by AI, is also reducing the machine downtime because of various unexpected failures and no production disruptions, and there is no loss of expensive raw materials. So it helps to reduce the operating cost as well. So robotic automation in sterile manufacturing, and this is where it is a very, very important manufacturing aspect for clean room operations, where it has minimized human intervention. And this robotic automation is helping tremendously into the closed system to monitor completely the sources of all contaminants. And it completely minimizes the contaminants and helps to ensure the batch will not get affected due to any contaminations. Another is RABs, that is restricted access barrier system, with fully automated the H2O2 decontamination, that is hydrogen peroxide decontamination for the clean room prior to each batch of manufacturing, and reduction in the risk of the drug product through the use of automation and robotics of the failure of the batches. Total compliance because of minimum human intervention. In quality assurance, the LIMS, the quality management system, it is helping tremendously to automate a time-consuming and error-prone manual inspection task. So AI is doing complete automated inspections. It enables quality solution. And now we are moving towards a proactive quality, my friends. And of course, it helps also in internal audit process, and it guides the quality team, the likely errors to happen, address those, and how to address those also is advised by them, by the AI. So the quality people are also are very at comfortable situation, and they don't have to run here and there. You can see everything on the screen, what is going to be the next step, quality. And therefore, it has a tremendous cost savings, productivity improvements, and standardization of the quality processes. And now we are moving towards smart quality, my friends. And this AI is tremendously helping for us, the smart quality areas. So information required for precise assessment and high risk issues that which are likely to happen, which are the areas there can be some kind of quality failures or issues or equipment failures. This will be identified by the system in advance, and any newer complaints and out of trained problems also are immediately escalated and investigated quickly. And this AI is doing a lot of investigation job on its own based on the data collection. And therefore, we are able to give now the patients the responses and updates of their issues so that they know the organization is looking at their problems very seriously and they are at rest and they are confident of the organization. So trending reports are also available in real time, and that is why during packaging operations or manufacturing operations, there is a dashboard display of all trending reports of every day of every batches. So from the benefit perspective to quality assurance, it's very much objective, reproducible, and traceable activity for quality assurance. From the perspective of consistency of batch after batch, unit after unit, to ensure minimization in the recalls of the batches or the shortages in the market. So the patients are at comfort again. And obviously, it reduces the risk of the failure and reducing the cost of testing and the monitoring purpose. In supply chain, of course, it is a blockchain is a major thing today, and which is giving us tremendous benefit because blockchain is helping the whole information right from input to output and packaging is completely in different small blocks connected to each other. So it cannot have a cyber security issues. It cannot be hacked because whole information is completely separated and brought together in the form of chain. And that is why the experts in IT have opined that blockchain is one of the best systems for a supply chain monitoring to ensure the supplies are going to the right destination and ensure the right hospital or the patients or the pharmacies, all the data is automatically captured. And therefore, use of predictive analytics by making use of relevant data and forecast management in planning, retail, and sales operation is tremendously benefited with the help of artificial intelligence. AR in the manufacturing, we see here how the glasses, the fully automated glasses are seen here. This is one example which I am displaying here is of Corvair Pharma, the data management system, and the person, if whenever they have any issues online or in testing lab, they can generate the screen in their front and communicate with the right person wherever the person is available in the plant or outside the plant and communicate with the person. And you can see the same thing here as a digitized documentation, reduced deviations in manufacturing, maximized quality. and ready to use product without any hitch in manufacturing. And AI and AR are enabling production process virtually. A manager doesn't have, or supervisor doesn't have to go to actual production room. He can visualize from his own cabin to what is happening in manufacturing, and then he knows what is he monitoring, what should be monitored, and he can guide inside team as well from his cabin itself. So it is very timely intervention by the supervisory staff. So overall, if you see the Pharma 4.0 getting extrapolated to Quality 4.0, my friends, and to the Technology 4.0 with the help of continuous manufacturing, 3D printing, process analytical technology, and artificial intelligence as a future of pharma industry with the help of robotics, cloud computing, data analytics, and AI blockchain services. Now it's a big boon to the industry, and it's going to help tremendously the patients all over. And as a future, manufacturing quality is right from quality by testing, it moved to quality by design in last almost decade and a half, and now it is moving towards smart manufacturing and smart quality by control. It is not quality control, it is quality by control. So QBC is the latest trend now in the industry, and it has a tremendous benefit all over, right from properly monitored the manufacturing critical steps and on the spot testing and releasing the batches on the spot. And here you see one of the these McKinsey analysis displayed by them as a visualization what they see in digitalized laboratory and automation from that perspective. Therefore, they call it distributed quality control lab. It's fully automated and based on ELAN, electronic notebooks, and all different kind of the sensors used, which may be outside the lab, which may be outside the plant, the actual manufacturing plant, but inside the premises. So whole activity and effort in smart manufacturing and smart testing lab is a paperless operation, complete paperless operation with the help of robotic process of automation. So it's a tremendous gain, my friend, and I'm sure this short presentation has given some ideas to you what is happening now today in the pharmaceutical industry and where we are going to be in very near future. So thank you very much, Dr. Anil Gargji, for inviting me for this wonderfully organized 2 days conference. Thank you very much once again.
Thank you so much, Mr. Ranjit, and I'm sure we have a lot of questions. And it's an extremely enlightening talk, and it's really, told us that in pharmaceuticals, which is an important part of the healthcare ecosystem, how much digitization and automation is playing a role,
yes,
and increasing safety. And I just want to see whether Professor Sabha is here, because I don't think she is here. I don't see her. Aishwarya, is the Professor Sabha here?
No, sorry. No.
And also Ashima is not here.
Yeah.
So that's okay. We can go ahead with questions. And so are there any questions from the audience? So I definitely, I think I would like to start with some questions myself. It's both to Mr. Suri and Mr. Ranjit. From what I'm hearing is, I think it's like we are moving towards a healthcare ecosystem 4.0. And in keeping with what is the theme we have is, being patient centricity. See, we can never forget that at the end of the day, all that we're doing, irrespective of who who the stakeholder is, whether it's a pharma manufacturer, device, IoTs, apps, software development, and doctors and technicians, everybody. We all are here because of the patient and for the patient. And I think that has to always be our central theme. So, and in a scenario where patients have to pay for it, cost becomes very, very central part. Even if the patient is paying for it or a system is paying for it, because someone is paying. Yes. So at the end of the day, cost of care has to come down. So in this respect, when we say so much of automation has happened, and I want you to, relate to I'll go to both of you one by one, to relate to what you have spoken in relationship to the vision that the government of India has in terms of the ABDM, the Ayushman Bharat Digital Health Mission, because these do tie up, because Ayushman Bharat Digital Health Mission, I think it is focused. In fact, the core is just two things. One is use of data, and how that data is converted into useful information across the healthcare delivery system, and patient centricity, and making the patient powerful by, initially now starting with the UHID and eventually moving to a personal health record, which will be controlled by the patient. So when we all are going to move into that ecosystem, how do you see what, so Mr. Ranjit, we can start with you, and then Mr. Suri, how do you tie these two up? Because that's the journey we have to take, isn't it?
I understand. It's a good thought process you are bringing in, madam. And obviously, every organization would like to reduce the cost as much as possible. No doubt about that. And nobody would like to go to the benefits of 200 or 300 or 500% from that perspective, because this being a life-saving industry, and it is looked from that perspective, and the government has been always focusing on that. I have been on several times committee on NPPA, the pricing committee of the government of India. And also I have been working on quality committee suggestions for Drug and Cosmetics Act. So we have been discussing these very often with the government officials as well as with the industry as well, being part of industry. What is best we can do to reduce the cost? So if I am able to increase the productivity, Umaji, by using this automation perspective, I am minimizing the quality issues in manufacturing and testing, and I am ensuring that there are now minimization of the shortages of the product into the market, and I am giving much better quality, consistency in quality, total transparency in manufacturing operation due to the automation. Automatically the cost reduction is going to happen. And as I mentioned, there is a productivity going up to 80%. That has been practically seen, and especially by using process automations technologies. We call it very as a PAT, profit after tax, or process automation technology. So we always used to tell our finance guy that you release these many funds because you are going to have PAT there. So, but when he's asked PAT, we used to tell him that it is giving you profit after tax if you release my funds for that. So leave aside some lighter moments on that. But in real sense, it is going to benefit not only the industry, but the patients at the end. Slowly the cost will come down. And as the volume increases, cost will always go down. And that brings a lot of competition among the industry, madam. And this competition itself is reducing the cost benefits to the patient. And that we have seen in last 2 years, very, very more transparent way, because of the various medicines being published with the data on the cost. including the vaccines data. And that was the clear-cut picture that 250 per dose, which is costing, and the government is giving free. That means whether it is really 250 or no, that's the government and the industry knows. But if you see from that perspective, the global costing is at least around 2,300 rupees per dose. And India is providing at 250 rupees per dose. So that's a gain. And as being an advisor to the Serum Institute Pune, Cyrus Poonawala-ji, I have seen all these activities. Full automation is there. There are 27 cameras on vaccine manufacturing line. It is speeding up the release of the batches. The output of the batches every month goes up, which by using same time, by using same equipment. And that's where the cost comes down. And that is where we are beneficial in comparison to the multinational costings as well. Thank you.
Thank you so much. Thank you so much, Mr. Raji. Mr. Suri, you want to take a shot?
Yeah, absolutely right. Thank you, ma'am. So I think I echo the thoughts that my colleague Ranjit has shared, right? I think very, very, very valid points, by the way, right? Just to pile on to those points, right? From my perspective, I think there are three key points, right? So one, I think there is focused support from government we see to enable omni-channel healthcare delivery, right? For example, appreciating the virtual visits, right? Visit the hospital only when needed, right? Like things like for surgery or serious injuries, etc., etc. Otherwise, make sure that you make a most use of telemedicine via videos or phone call. Number two, encouraging the preventive health, right? We have seen a huge change, at least a paradigm shift from the last 2 to 3 years in terms of having a preventive health from wellness programs, right, or better care management programs. And COVID is a classic example, right? Needless to say, we all have gone through that process where government is taking appropriate steps, right, to see, and emphasize the importance of health. And healthcare as an industry has never seen importance as much as it did from the past 2 years, thanks to COVID, right? I mean, it has really accelerated where we are versus where we are supposed to be. And finally, I also feel that there is a lot of regularization and funding from the government to healthcare programs, right? At least from the place that I come from, where you have this program called Arogyasri, right, which is a parallel of PMSSY, right, where there's a lot of funding, there is a lot of emphasis. Good examples to Ranjit's point is free vaccinations, right? Free vaccination drive ahead of where corporate used to charge a lot of money. Government is really investing and pumping money to enable that citizens' health is at paramount importance.
Yes, of course.
Yeah.
Yes, Mr. Benji.
Yeah, just to add on further, is that this you did mention about Ayushman program, okay? And that the basic concept of having that is to give a reduced cost product to the patient or insurance perspective as well. So medical insurance, hospitalization insurance for poor people, which are in a large number in India. So from that perspective, the Ayushman Bharat Yojana, about 5 lakhs per person or per family, and generic medicines, opening several shops all over India for generic medicine, which are less costly than branded. And this now the industry is looking at from the perspective of giving generic medicines more to have a less cost. Now, it doesn't mean it has an inferior quality. The quality remains the same. And the organizations which are manufacturing it, you see the top 25 generic companies of India, right, starting from Sun Pharma to several organizations, Lupin, Cipla, etc., etc. So all of them are doing very good job as a generic also. Mm-hmm. They do have a branded activity. And for government initiatives and support perspective, we know that 5-year plan which has come up from by investing about I think around 2.4 lakh crores are going to be invested by government. Out of that, 75,000 crores have been kept aside for vaccine program. So all these efforts, joint effort from government, industry, and the IT support. Now we have got tremendous benefit, Umaji. India has got, rather let me put it in a different perspective. India is very lucky to have own IT industry which is supporting the globe, not only India. And that itself is supporting from the perspective of the automations, software, and which is very expensive globally. So all these are helping to reduce the cost and ensure the patients are in a right frame of mind to take the medicines.
Thank you so much. Mr. Suri, I just want to ask you one more question. From what we've seen, and I'm sure the deliberations of this entire session and the previous sessions as well, it is, we have no doubt that we are going very, in the journey of digitization, of the digital transformation of healthcare has started in India, and ABDM is playing a big role. But if this journey has to be sustained and if it has to go smoothly, there has to be a lot of capacity building that we need, because there are no newer jobs, there are newer descriptions, and there are newer tasks that are to be done. And we don't have sufficient manpower. So I want to ask you whether Accenture has, as an organization, looked at that and looked at what can be done for capacity building in this space. And not only as Accenture, even I suppose, what you know from the industry. Can you just enlighten us on that, or your views on that?
Yeah, absolutely. That's a great point, Mr. Mann. Thank you so much for asking that. So from sustaining how we can take the digital journey forward, not just within India, but globally, right? Accenture is doing a couple of things, right, to make sure that we align with the goals of the organizations, both payers and providers, from two facets, right? So I want to mention one, from a technology cross-skilling perspective, right? And number two, from a industry skill perspective itself, right? Which means, let's touch on the first one, right? Which is technology. Accenture is making sure that we kind of upskill and cross-skill people with relevant digital technologies, right? For example, if a resource is very good at, let's say, Java skill, how can we cross-train and enable the resource into cloud? Because cloud is a big theme these days, and most of the organizations are moving towards cloud in their digital transformation journey, right? So that cross-skilling is already happening, not just within Accenture. I think we see the same trend and pattern across the players, right, from an IT perspective. Number two, from a healthcare domain knowledge itself, right? It is extremely important and equally important from technology skill to have subject matter experts in healthcare, so that they can supplement and complement the IT knowledge base from manpower perspective, so that aligns and gels with business goals, right? For example, Accenture is already hiring some of the physicians and doctors into the firm, right? So they can work hand in glove with the technology partners, right? And then go together collaboratively to our clients, so that we can speak their language and then see how we can enable the transformation journey and experience itself.
Yeah, thank you so much. Because what has been a challenge, and what I know, what we have seen in the as users of all the different softwares that are being designed and that we have to use, it has been a challenge so far, because of the reason where people say that don't adopt and the hospitals don't adopt, and adoption of these technologies have been a little difficult, because mostly it has been designed by tech proners for healthcare by thinking of from their view of healthcare.
Yeah.
And it has not, so it is like, the healthcare is expected to adopt to tech. So instead of that, it has to be tech for healthcare. And I think we need to make this transition, and we need to really have the, to teach healthcare to the technologists, because we've been so far teaching technology to the physicians and the nurses. Of course, both have to happen, but I think we have to spend a lot of time teaching the healthcare and the healthcare related process to the technology domain experts.
You're 100%
thereby bring us in.
I think that paradigm shift is already happening, right? Because back in the day, if you ask me, right, at least 10 years back, right, technology used to drive the business, right? Whereas CTO are at the center, CTOs of the organization are at the center stage to see, okay, what is right and how we go from here, etc. But now it has completely changed. Business is driving the future of the firm, be it hospital, be it health insurance company, etc. Right? Business is at center of dictating how the future looks like and taking technology help to see how they can take next step further. Right? That shift is already happening. We see across the industry.
Yes, yeah. So that's a good thing. And so if we don't have any other speakers, any questions, do you want to give me a closing comment? Mr. Suri, what's your closing comment?
I think we touched on all the major topics, and thank you so much for all the good questions and guidance as such. Right. Overall, I would strongly encourage for the participants and who are on this call, and as well as who are already on the other booths, but do visit our booth. There's a lot of innovations that you could probably take a look and surprise yourself. And then perhaps reach out to us offline as well via email or phone call. I think it'll be fantastic. And thank you so much for well-organized plenary sessions. I'm really impressed with the way technical otherwise as well the way WHC is organizing this. Appreciate that much.
And Mr. Ranjit, closing comment from you.
Yeah. Thank you very much for this opportunity. No doubt that industry, the government, and the various organizations, and as well the universities are taking a good lead from this automation perspective, digitalization perspective. Just to add a few thoughts here, is that I am on several boards of advisory boards of universities, different boards, and I have been talking to them on digital literacy at the pharmacy level, B.Pharm and M.Pharm or MBA level, from the pharma industry perspective. And since the industry is completely changing and it's revolutionizing the quality perspective due to automation, and in the interest of patient, we would like the pharmacy students to mentally prepare for themselves to work on these aspects. So overall, all in all, you can see that government, the industry, the industrial organizations, associations, and the universities, academia have joined hands in last 1 year more to bring out the positive aspects, moving towards complete compliance to ensure the customers are very, very happy. So it's a really good step which is happening in India, and that is why Indian pharma industry is known as pharmacy of the world, as coined by our Prime Minister. So it's a really good scenario today. And in this today's program, World Health Conference, I really appreciate Umaji, you're monitoring the panel session very well and putting across the questions and bringing in quickly some interesting points for discussion and provoking us to speak from that perspective. So I really appreciate. Thank you very much, Dr. Anil Gargji, for your invitation, and let's be in touch for all your future activities as well. Thank you so much for the opportunity.
Thank you so much, Mr. Ranjit and Mr. Suri. I want to invite Dr. Garg for his comments on the session if he would like to share some thoughts on it.
Yeah. Thank you, Umaji, for excellent chairing the session and provoking speakers to speak from their heart and experience for the benefit of the participants. And this is really a platform where we can help the people in digital world, in the healthcare, and also reduce the cost of devices, manufacturing things, vaccines, medical medicines, like that. So this is a wonderful session, and this is supported and is sponsored by Essential. So I have to thank Mr. Krishnanan Suri for supporting us. Hope it will continue, and we will see that we should have some deliverables at the end of show. And thank you very much, Umaji and Mr. Ranjit and Krishnanan Suri for giving a wonderful account of this aspect of digital transformation. Thank you very much.
Thank you very much.
Thank you so
thank
much.
you everyone, and thank you, Dr. Garg, for this opportunity given to me to interact with the panelists and be part of this session. And thank you both the panelists, Mr. Suri and Mr. Ranjit. Aishwarya, it is over to you now. Please do. Thank you.
Thank you so much, ma'am, for excellently chairing the session. Thank you so much, gentlemen. We'll be meeting in half an hour from now, perhaps 40-45 minutes from now, for the next plenary sessions. So the sessions will go on in Hall A and B. The Hall A session will be on health informatics, cybersecurity, telehealth, and telemedicine. And the session in the Hall B would be on personalized, preventive, precision, and emergency medicine. So looking forward to a very invigorating session in about 40 minutes from now. Thank you so much, everyone, for having joined us. See you in just a bit or after a tea break. Thank you so much.
Good morning, Dr. Garg. Abel Archundia joining.
Good morning, Mr. Abel.
Welcome.
I'm very glad and honored to be part of this of this group. I'm going to try to adjust my lighting.
Yeah. Do, by all means.
Can you see me more or less sufficiently? It's just that it's I'm not in my usual home office. I apologize, but it's for us. You know, you have heard about Easter in Christian countries, and for Easter it is slightly different to. Oh, let me see. I have a new light source here. I'm able to. Oh, I don't have enough power. Oui, ça marche très. Oh, c'est fantastique. Oui, super. Okay, there we go. I think you can see me a little bit better. Magnifique. Merci. Dr. Garg, it's a pleasure to see you today again.
Thank you. Thank you very much.
I find the agenda for your participants is very, very interesting, and I'm honored to be part of this select team.
Yeah, we will request next year also in person.
Oh, that would be magnificent. I have, I think there is nothing like face-to-face and build lasting relationships.
Yeah, so next year dates will be 12th and 13th April.
Okay.
12th and 13th.
I will make plans because I think I have not been to India now for 2 years since COVID restrictions. And this would give me the opportunity to visit a few of my other clients as well. But your healthcare conference is so well respected and attended.
We seek your cooperation and support also. So that is there. And we definitely invite you.
Thank you. Do so with advance. I typically take about 2 to 3 months to secure sponsorship at the right level, and I think the attendance that your conference has is a very appealing audience of decision makers for the kind of things that we do. So the opportunity is there. And I think it's a matter of working with our marketing team to be able to build sufficient traction.
Okay. So welcome, Dr. Mariwala.
Sorry, I was on mute. Good afternoon. How are you, Dr. Garg?
Just fine. Thank you.
Good afternoon, everybody.
Good afternoon to you. Dr. Mariwala, where are you based?
I'm actually based in Mumbai, and I'm not a doctor. I'm Mr. Mariwala, so you can call me Sanjay.
Yeah. Yeah, Sanjay.
You can call me Abel as well. I am
Abel,
also
nice to meet you. Nice to meet you.
I come from a family of doctors, and my father was disappointed in me, but
you didn't become a doctor.
But you know that when you have an eminent father, everybody asks you, "Are you going to be like your father?" And I was not certain.
That's right.
I was not certain that I could, and I prefer to not disappoint him in his area of expertise and disappoint him in other areas. But I think that the mindset of the clinical doctor is very hard for non-doctors to understand. I mean, researchers.
I completely agree with you. I don't have any doctors in my family, but I know very many doctors personally very well, and I see a big difference between the mindset we bring to the table and the mindset they bring to the table.
Isn't it true that they are really motivated in general? And Dr. Garg, I'm sure that you could say a few words about this. They are motivated so powerfully by helping and making the world a better place. sacrificing everything, study, sacrificing family, sacrificing life. I'm very impressed with the discipline and purpose of medical doctors. And there we have one of the most respected one in Dr. Kingsland.
Kingsland, that's right. He just appeared and disappeared, I think, in a shot.
Oh.
There he is.
Good
There you are.
morning, colleagues. Good to see you. I presume we're just
Professor James
in the green room.
Yeah, welcome.
Nice to see you again. I think it was a year
Yeah,
ago that we last spoke.
Yeah. We will start in next 5 minutes.
In the order as on the agenda, am I going up first?
Hopefully.
Sorry, I just missed that.
Yeah, you will be the first speaker, I think.
Okay.
Did you get my PowerPoint, Dr. Garg? You had requested it. I sent it out. I hope you received it. Otherwise, I can operate it from here myself. It depends on what you feel comfortable with.
Yes, sir. We have received your presentation.
You received my PowerPoint. Excellent. Thank you. Thank you.
I also want to confirm that you have my own 2 to 3 slides in PDF. Could you confirm if you have my material, please? Otherwise, I can operate from my computer, but I prefer for... Okay, I will send it to you again, Dr. Garg. I will take a minute to do that. Otherwise, I can operate from my computer as well. But
So I'm happy to, if I get control of screen, I can just do mine from my own
Hi,
screen.
everyone. Can you hear me?
Yes, we can hear you.
Thank you so much. Pleasure to meet all of you this morning.
Yeah, we can see you now as well.
Oh, awesome. Thank you so much. I'll pull up my presentation to start out with.
Dr. Nanda Kumar, welcome.
Yeah, thank you so much, Dr. Garg. Pleasure to meet you, Dr. Kingsland, Dr. Archindia, Dr. Mariwala. And
Mr. Mariwala, you can call me Sanjay. I'm not doctor.
yes,
pleasure
please
to meet you,
call
sir.
me Abel, as I am also not a doctor.
So within next 3 minutes, we will start.
Sure.
Wonderful.
And Dr. Garg, once you finish your introduction, then I can start sharing my screen.
Yes, by all means. Session is yours.
Okay, great. And awesome. Let me know if you can see my screen.
Yes, we can.
Yes, yes.
Do you see the, let me see, make sure. Do you see my presentation slide or?
Yeah, it should be in presentation mode also.
Okay.
We see the
Do you see
PowerPoint.
the presentation mode?
Now we do.
Yeah.
And now we can see it. That's good.
Now it is better.
Okay, awesome. Thank you so much.
It is better now.
Okay, great. I'll start out with a quick introduction with a few slides, and then I'll pass it to the panel.
Okay, okay. So I think let me start to welcome distinguished panelists, distinguished keynote speakers, distinguished personality throughout the world on digital healthcare. This is a plenary session 4th, digital healthcare, health informatics, cyber security, telehealth, and telemedicines. Your views on this important aspect of healthcare for the poorest of the poor. This means it should be cost effective and innovative approach is a need of our. With this, I will hand over to Mr. Nandakumar Balasubramaniam, Chair, Professor from Oracle and Oracle Health USA. Professor Nanda Balasubramaniam, please.
Thank you, Dr. Garg. Welcome everyone for the session. Good evening, and I'm also have a very distinguished panel of speakers on our session. So with that in mind, we'll focus on digital health during this discussion, with the emphasis on healthcare informatics, cybersecurity, telehealth, and telemedicine. With that, in terms of the agenda, I'll give a quick introduction about myself and about what is it all about digital health. Then I'll let the other panelists on this session take over, give a brief introduction about themselves and talk about their focus on digital health. Then we'll move the session towards a panel discussion. I have 3 sets of questions that I'll pose to the panelists, and then they will give their input. And we'll allocate a little time at the end for some question and answers. With that in mind, in terms of myself, I am the head of digital omics at Oracle, and I've been here for 3 years, where I focus on the sectors of life sciences, which is pharma, medical devices, diagnostics, and now with the formation of our healthcare unit. We also focus on digital health and the areas of healthcare, genomics, and medical devices. In terms of my background, I'm a biochemist and an immunologist, and I've spent 30 years in the life sciences industry in the US, working for the major players such as GE Healthcare, Thermo Fisher, Illumina, and QIAGEN and other companies. My focus has been in genomics and proteomics, both from R&D, product development, global marketing, product management, market development, and now at Oracle, I'm focusing on the intersection of digital transformation for all of these sectors. And originally, I'm from Coimbatore in India, and I've been in the US for 38 years. With that in mind, I'll move to the section and talk about what are the key trends that's influencing digital health. You can see that there is this movement away from one-size-fits-all model to the area of personalized or precision medicine. And that is what is revolutionizing everything related to next generation healthcare. And that's because of the advancements that has happened in these areas of molecular diagnostics, specifically gene sequencing, and incorporation of that data towards personalized medicine. And that in turn has been made possible due to the affordability of these tests and the advancements in those techniques such as next generation sequencing, which in turn leverages a lot on the connected devices, the data that's flowing through from all those outcomes specific to the health situations of the patients. Nowadays, there is the movement towards incorporation of all that genetic data into the electronic health records, which in turn is offering value-based outcomes for the other players and payers and providers as well as to the patients. Most recently, you have seen the application of these techniques towards the pandemic that we had. And this is also because there's a convergence in the industry itself. You can see in our own case, you can see the partnership between a tech industry and a gene sequencing company such as Oxford Nanopore Technologies. One thing that's coming from all of this thing is the increased amount of data. That's why we call it the big data, the analytics and the bioinformatics aspect of it. But when you take all these things into consideration, we have to focus on the data security and data privacy aspects. At the end of the day, all these trends are the ones that influences next generation healthcare with the goal of providing better outcomes for the patients as well as other participants in this sector, both the healthcare providers, as well as the planners, as well as the government officials who are making critical decisions. With that in mind, as the next generation healthcare has said, what's there for everyone in this industry? You can see this entire aspect of digital healthcare, which is about $100 billion, and it's expected to be about $640 billion by the year 2026. And you can see that growth rate is about at 28.5%. And I mentioned about the trends, but also if you look at the drivers, yeah, we are getting over the pandemic, but a lot of the needs that came from the pandemic, it's transcending into this area of digital healthcare. And there's also the increased use of mobile devices and communication devices and video devices. This is where you can see that lately, I don't have to go to the hospital to see my doctor. I can connect to my doctor through video connections and have my consultations and everything until there's a critical need. And you can see even consumers themselves are focusing on preventive health in terms of the fitness and stuff. Many of them are using wearable devices to monitor certain aspects of their own health situation. And there is that focus on preventive health. With that, there's also the increased investments in infrastructure to managing all these aspects. And the governments, individual governments are favorable about this. And even in the US, there is the Affordable Care Act, where the government is enabling reimbursements towards digital care in this aspects. And there's also the increased usage of remote patient monitoring. But is this a cakewalk for digital health? No, that's not the case. There are some challenges that everyone has to take into account. For that, you can see one is that, when we're doing all these things, we have to take into consideration the communication gaps that can arise between the patients and the providers. There's also the increased amount of data that's flowing. So we have to take into consideration of data interconnectivity and the digital connectivity. And also with the technologies, with the software upgrades, the turnaround time to results, managing that data, correct? There is also this movement towards cloud. So you have to gather the data, store, manage it, and to derive insights from that, while keeping the cost down. So these are the challenges that everyone has to take this into consideration. With that in mind, I wanted to highlight that entire aspect in this particular slide. So if you look at digital health and the connectivity, it seems like for every patient that's in the hospital, there is about 10 to 15 devices that are connected to the patients to monitor their health. At the same time, there's a gathering of about 3 million data points. So when you have that much of data flows from the patient, you need to manage that data in terms of the storage, managing, interpreting the data, and so on. So you can see that data could be the patient health information. It could also be the information coming from the devices that can be used by the manufacturers themselves to make certain adjustments and to improve efficiencies of their own devices. But at the end of the day, the goal is to derive a meaningful insight from all of the data that's flowing through from the patient through the connected devices. So this is where an companies such as Oracle comes into play in terms of offering the layered technologies, whether it's from telecommunications, IoT, whether it's from using autonomous data warehouses, the cloud systems, virtualization, storage, as well as to do the analytics, leveraging AI, machine learning and stuff. And I'll give you one example in my presentation from this thing. So this is where you can see the flow of data from the patient and the usage of technologies to derive a meaningful insight. With that in mind, I'll jump in and give you an example of what Oracle has accomplished in partnering with Ellison Institute in Santa Monica in California. So one of the things is the leveraging of deep learning techniques to create fingerprints for breast cancer tumor markers. So the three tumor markers that we are looking at are the estrogen receptor, progesterone receptor, as well as the HER2 receptors. In the traditional methodologies, you take tissue sections, they're stained, and the results are read, and that's how they identify which marker is responsible for that particular breast cancer. But when you have thousands and millions of these samples, this entire process becomes tedious, error-prone, and so on. So in this case, we have moved on to applying one of the digital technologies, such as the derivative of artificial intelligence, which is deep learning, leveraging these algorithms and creating fingerprints for tumor markers, in which Oracle technologies have been capitalized on this, from file sharing to autonomous data warehouses to GPU, graphical processing units to do this thing. So the way we do this is the deep learning technique is that we started out with the sample sets that came from the Cancer Genome Atlas. Using that, we trained the system to read the outcomes from those things and to create the fingerprints for the estrogen receptor marker that is shown out here. Then we applied this deep learning model on samples that came from Australian Breast Cancer Tissue Bank. There were about 2,351 samples from this. And now to look at this outcome from this deep learning model, the next slide highlights this. So you can see the four-step process in terms of extracting the fingerprints, predicting the markers, averaging the predictions, and looking at the classification of those tumor markers. The outcomes that we received in terms of the area under the curve, that is a reading for the deep learning techniques, which is very high, which is close to 1. That's comparable to whatever the scores that were obtained by the traditional methodologies out here. And that is also reflected as the curves that you see here, which is called the ROC curves, or the area under the curves, where yellow represents the outcomes for the deep learning models compared to the standard models, which are in blue curves. You can see there's a high degree of correlation for each of the markers that were identified, such as the estrogen receptor, progesterone receptor, as well as the HER2 receptor. This shows that this technique of deep learning works comparably or even better than the traditional methodologies. So that's one example of applying these digital technologies and for classification of the breast cancer tumor markers. And this is working really effectively. And I've highlighted some of the technologies that were leveraged for this purpose. With that, I will thank my colleagues at Oracle, with whom I'm collaborating with, as well as with Ellison Institute. And I will, as Oracle itself is putting in a lot of effort into all of these things in terms of R&D, the cloud development of the cloud technologies, and the partnerships that we work across medical devices, pharma, drug discovery, and so on. I will stop at that stage and pass the baton to the first speaker in this case, which is Dr. Kingsland. And let me stop sharing. And there we go. You can take over, Dr. Kingsland.
Many thanks. Hopefully that is now projecting. Good, thank you. You can all see the screen. I'll just check with colleagues that that is projecting okay. And well, from the northwest of England, a very good morning. I appreciate it's late afternoon with colleagues. I'm going to go a little bit lower tech because it's going to be a viewpoint from primary care. Primary care, of course, in the UK. My background, I've spent 38 years now in all sectors of the National Health Service in England, 31 of which has been in general practice in as a primary care physician. So it's going to be a viewpoint of how we've accelerated some of the digital changes that have happened during the COVID pandemic. I'm also a clinical professor in the School of Medicine at the University of Central Lancashire, so I'm teaching some of this and do quite a lot of independent healthcare advice with governments as well. One of the aspects I'll be looking from where we've learned a lot is in something called the Digital Clinical Excellence Forum, which is a UK-wide forum at the moment, established in March 2019 as a collective voice for the growing community of digital healthcare providers. Some of these are international providers now, so it's a large learning network, and we're looking to produce standards of digital healthcare that cross the four nations of the UK, but also working now internationally closely with the American Medical Association, some universities across Europe, to look at international organization standards for digital healthcare. So looking at some of the reflections from the work of DICE, and this very much reflects into primary care about how we've had, we have this thing called the long-term plan at the moment, which is directing the thoughts and processes of the National Health Service over the coming years. And part of it was how we moved much more into digital services. Of course, COVID has accelerated that to where we were thinking that it might take 4 or 5 years. It's taken 4 or 5 months to change, particularly in primary care, some of the online interactions with patients. But what we learned from this, we've been doing some reflective work, some analysis, that the need for training and educational programs, particularly in consultation skills, are vital. Some of the information we're getting back from patients where the translation of the intimate consultation to an online interaction is not as straightforward as people think. And there's a whole range of things about the consultation style and improvement in remote care delivery. The rules for handling patient information quite significantly change, and that needs upgrading along with new data digital strategies and certainly coding improvements. That has really shone a light on how poor we are, certainly in the UK, in having standardized ways of importing into the many different clinical records that are being used. The nirvana is still to get a unified care record, which the NHS has been trying to do for many years, but we're still quite away from that. And the technical proficiency, adapting these new ways of working for clinicians who haven't been used to online types of services, and particularly for groups of patients, whilst the newer generations are well used to some of this, there is a lot of digital exclusion still in a relatively high income country of the UK, and the technical proficiency both for the clinicians and the people receiving care needs quite a lot of that. We're looking at how we can improve prioritization through digital consultations, and looking at how we can start to then import some of the remote monitoring, albeit one of the things we'll be talking about later, the realization that the connectivity, even across the UK, is relatively poor to really be confident in the interactions, and particularly the assessments working remotely with patients. But we've got other opportunities. We're now thinking through across the UK about demand management and how we utilize digital services, not always the first choice of patients, and certainly to scale primary care, in which we've always thought, certainly within the NHS, the cornerstone and where the most demand is, and 90% of all contacts within the NHS is in the primary care system. Just a quick note of what we're doing practically for this. I won't dwell on this. There's a website at the bottom, but we have produced a level 7 master's level for both consulting doctors and nurses in the main, but improving the skills and competencies, which we've really found have been quite significantly lacking during the time where COVID has moved much of the consultations online. and looking at some of the legal and governance aspects which have raised issues, as well as the technical competencies, the types of platforms that we're developing, and the ability to create digital platforms that can collect data to move towards this unified care record. When you start to analyze the amount of systems we have just in a small country like the UK, we are far away from a fully unified care record. I only show Nostradamus because he didn't get it right all the time. We seem to insist on predicting the future. What it's shown us in the last 2 or 3 years, we need to ground all our future developments in data-driven population health improvement, where we get better insights into future population health need and its management. Sometimes I reflect on our long-term plans as sometimes being the best guess of what might happen. We've also realized the enormous potential to provide more evidence to improve patient outcomes, which again, on reflection, sometimes the service delivery isn't based on sound evidence. I mentioned about developing platforms for integrating and analyzing diverse data sets, because again, the healthcare change, particularly in the UK, which has a lot of the wider determinants of health now, are leading people to have complex care needs, which aren't directly related to their health. It's related to their living environments, their wealth, environmental issues, a whole range of things now that are leading people to use the NHS, but their underlying problems are not necessarily disease processes in the sense that we've always thought of. The other thing we've reflected on as well is the value of patients. We have rapidly moved to this digital world, but going back to many big pieces of research, this is some research from some time ago, but it hasn't changed recently. The public's top concern in the UK, and I suggest across the world, is waiting and access. So the accessibility to their consulting clinician and shorter waiting times may be serviced by the digital revolution. But the one aspect that many patients are reporting that digital services are not good at is the interpersonal attributes of care, the non-clinical humanistic factors, which remain vitally important. Compassion, personality, what we always call bedside manner, listening and patience, which patients are reporting are very difficult on remote consultations. And the continuity as well, when we're looking at immediate access remotely, sometimes we're starting to see there's a loss of the continuity, which is a particular issue on patient values. And I think as we accelerate into the digital world, we mustn't forget those humanistic factors and get the balance right. That's not to say we draw back from the learning we've had over the last 2 to 3 years, but I think we shouldn't forget some of the important parts of any high-performing healthcare system. The experience of care is always number one. And sometimes we're finding that the digital service, there's a lot of pushback, certainly in the UK at the moment, about how we are moving to remote online consultations and almost denying access to the face-to-face interactions, which has shown the biggest dip in the NHS's approvals from the annual responses that we get from the patient surveys. The other thing is just very briefly to say, we mustn't forget the digitally excluded as well. My children in Generation Z now, they've known nothing else but a world with technology, computers and mobile phones. They don't even know who Elvis is. So there's a group who are very much tuned in, but we still have generations, a large part of the baby boomers who are going into old age, who are digital immigrants. But one of the interesting things that some research has shown, and this research is mainly from the US and Australia, there's little in Asia or Europe, but it does show the values of different generations. And the only one value that is interesting about Generation Z, the digitally enabled group of people who want this online, remote, immediate service from healthcare. However, if they're looking at what's important to them at the moment, business development, finance, they want face-to-face interactions. They want to see the whites of their eyes of their financier. They want business meetings that have those humanistic factors, where they want healthcare online. What happens when they grow old, have long-term conditions, complex care needs? We need to build in the potential for those humanistic factors. That's not pushing back on, but I think it's to give a balance from what we're seeing sometimes, this roller coaster of everything's going to be digital, remote, it works, we've got massive opportunity for data. I think we mustn't, my message from the primary care perspective is we mustn't forget the humanistic factors and the fact that as those generations change, what their needs may be. So finally, Chairman, I'll just finish with another slide and another quote. This is attributed to Marie Antoinette. What does the future hold when COVID-19 has finally settled, but that may still be some years off? The perceived change to digitally enabled healthcare, but as generations change and values change, we need to get the balance right between the digitalization of care and the humanistic. So I think it's not necessarily a watershed moment. Certainly COVID has accelerated the abilities, the knowledge and the utilization of digital services, but to say that is the only way in the future may be a little bit of lazy thinking. We'll need to revert to some of the direct humanistic and build on and learn from what we've rapidly developed, certainly across the UK in online services. But whatever the future holds, it must be a collaborative approach to healthcare need and delivery as societal issues change. But I think the one thing we're pushing back on in the UK is that the new normal of a digital service is not contractually imposed. It's evolved to make best use of the technology we have linked with patient needs and sometimes wants. Chairman, at that point, I'll hand back to you.
Thank you, Dr. Kingsland, on that wonderful perspective on digital healthcare and how that's being implemented in UK. And also it's wonderful to hear about some of the challenges that are associated with it. It's not an easy cakewalk for everything. It's a good perspective. We'll come back to these areas of Q&As and discussions later on. In the meantime, I'll pass the baton to Dr. Maroof to give his perspectives in this case. Dr. Maroof.
Hello, good evening from Japan. Can you hear me?
Yeah, yes. Very well.
Okay, thank you very much. So, my name is Rafiqul Islam Maroof. I'm from Japan. I am as a professor in Kyushu University Hospital. This is from the city of Fukuoka, Japan. Originally, I'm from Bangladesh, but I'm living in Japan for more than 30 years now. I'm working with Kyushu University. At the same time, I have a position in Grameen Communications of Bangladesh. So today I will make a presentation on our research work, what is a portable health clinic for maternal and child healthcare in COVID-19 situation. Actually, Portable Health Clinic, it was a joint research collaboration between Kyushu University and Grameen Communications of Bangladesh. And basically our main vision was to provide primary health care for the unreached communities in the developing country like Bangladesh. So this is not a high tech, this is a simple technology, but this is very effective and this is very affordable, sustainable and usable system so far we develop. And basically, if I say what is a portable, it is a affordable, sustainable telehealth system for unreached community, especially in the developing country where there is a huge shortage of healthcare workers and doctors. Of course, the healthcare facility has a lot of limitations in that areas. So we design a model, what we call portable health clinic, so that it can be used by the rural health workers. And actually, it has four main components. One is the device, a set of device with basic medical sensors that can take about 20 vital informations. And it is operated by a health worker in the rural site. And the devices are connected with the internet, and all data are transferred. We have an online server system. So whenever the health worker collect data, that were transferred to the online server system. And in the city, we have doctor call center, and doctor can monitor the data instantly. And doctor can talk to the patient, provide the consultancy. So this is the basic model. So to understand it better, I will show you one simple video. As I said, this is a set of devices like this box. It has about 20 various sensors that can collect 20 vital informations. And when we provide the service, every patient are registered, and every patient has a unique barcode ID so that we can identify each of them. And once the patient is registered, then health worker collect the vital information is the simple devices. And after collecting the informations, in fact, all data are transferred to our online server system. So all data are transferred through this system, and the system has a triage protocol. It can classify the patient in 4 categories. Orange and red patients are severe patients. They need the doctor consultancy, and instantly they're connected to the city doctors, and doctor provide the consultants. Doctor talk to the patients and prepare the prescription and transfer the prescription to the box to the village. So with the box beside the medical sensor, there is a printer, so health worker can instantly print the prescription and provide the patient. So what you can see that a patient being at the village, they can talk to the city doctor, they can get the prescription instantly from the doctor, and they can collect the medicine. But as I mentioned that we developed this as a primary healthcare tool, but we find that this can be uniquely used for the maternal child healthcare, because in the rural areas in the developing country, women folks suffer most. And we find that maternal child healthcare is a very urgent issue in the rural areas, because I can show some data. You can see that statistics shows that in our region, especially in the Asian countries, India, Bangladesh, this area, we have a huge infant mortality rate. In case of Bangladesh, for example, we have currently 23 per 1,000. So, but if you see the development, there is a good improvement since Bangladesh was get independence in 1971. From 1971 to now, it becomes, in 1971, it was 163. Now it becomes 23. So it's a huge improvement. But if we like to go to the single digit, it shows that we need another 20 years. But we cannot wait for that time. We have to do something. So we think that maternal and child healthcare is a matter where we can use the portable health clinic. And if you see the maternal mortality, still it is also very high in our area. So there was huge demand in the rural area, and we thought that the MCs should be used for using the portable health clinic system. And actually, to improve the maternal, the infant mortality rate, and what we need, according to WHO recommendation, there is a very simple solution. If we can provide 8-stage continuum care to mother and babies, it can solve a huge problem. It can reduce the mortality rate, improve the mortality rate hugely. And if you see the rural sub-center, health sub-center in the rural areas of Bangladesh, they actually have that 8-stage continuum care service. But unfortunately, when we have the survey in the rural community, we find that only 11% villagers, women, they get at least one antenatal or postnatal care. And if we consider that who took the all 8-stage care, we find not a single person who took the care. And we get some information, health checkup, and we find that about 52% patient has some sort of issues, and at least 70% has urgent need to get treatment. But usually they don't go through these services. They don't know about their health status. And the reason why they don't go to the sub-center, first of all, they has a lack of awareness. They don't understand the significance of this 8-stage care. They usually feel that when during the delivery time they need to see the doctor, but they don't care about the antenatal, even the postnatal cares. And another issue is actually it's a little distance for the pregnant woman to visit the centers. And also, as I mentioned, that in this kind of centers, usually they have diploma or paramedics doctor. Usually there is no graduate doctor. So people are reluctant to say, go to there. So that's why we developed our portable health clinic system for MCH care. And for that, we just needed to add some additional sensor in our systems, like ultrasound image and some sort of Doppler machine was added, portable machine. And using this, and where we have the trained health workers in the rural area, so they can use this system. And how it works, I will show you another video that will help you to understand the situation.
When you live in a developed country or have access to all kinds of medical services, the sound of a newborn crying creates a festive mood. But when you live in a remote area of a developing country, bringing a new life brings in a whole lot of questions. How would the 9 months of pregnancy be? Will the delivery be smooth? Would the mother and child even survive? Like most other villages in Bangladesh, earlier there was no modern healthcare facility in Mumtaz's Chaigaon. After the death of the first child in the womb, the treatment of evil spirits through amulets started. However, she was actually needed to be seen by a doctor. Mumtaz is lucky. During her second pregnancy, the Kyushu University of Japan and Grameen Communications of Bangladesh jointly initiated a specialized program in their village called Maternal and Child Health MCH Care, which is a part of their Portable Health Clinic project. The annual General Health Checkup Program of the Maternal and Child Health Project for all potential women between the ages of 15 and 49 is taking place today in Chaigaon. 500 women are about to be examined today. This general health examination consists of 15 important tests, including BMI, body temperature, blood pressure, oxygenation of blood, blood glucose, hemoglobin, cholesterol, uric acid, and urine protein. While the PHC model is widely admired around the world today, in the MCH project contains several additional devices, including an easy-to-carry Doppler machine, a small ultrasonograph device, and a special instrument for measuring infants' weight and height. With the help of these, an experienced health worker can understand the physical condition of the mother and her baby. Though these health workers are at the very bottom of the project pyramid, their first task is to sort out the initial verification, primary data collection, physical checkup, and insert all these data to the online server properly. Then connect the patient directly to a remote specialist doctor of this project through a video call. If the path shown by the Maternal and Child Health Project of the Portable Health Clinic program is followed, then the day is not far when the atmosphere of this country will not be heavy for the death of another newborn.
So this is the actually the all figures, all the person in this video are the real field workers of our project. And during this COVID situation, actually in Bangladesh, the situation started in February 2020. And at the initial stage, we had when the situation was not severe, our health worker visited home and provide the home delivery services. But from the March 2020 to May, there was a lockdown situation. So we stopped service. Initially, we don't have any preparation to provide the offline support there. But later on, when we developed some phone-based service for the patients. So during that time, even it was lockdown, we could provide the phone-based consultancy. And later on, the situation improved and we started again the home visit. Again, there was a situation lockdown, we had to stop and we had to provide the phone-based contract. And finally, now the situation is improved, we started the home delivery service. So if you see during the lockdown period, what we did, we collect information by telephone. We collect both information, COVID symptom information and MC's information are collected. And we provided the consultancy using our doctor providing using the own telephone-based service, not the video call, only the telephone service. But after the lockdown period, when our staff started visiting the patient's home, but before visiting home, they make some confirmation by telephone about the body temperature, coughing situation, and breathing issues, and all other COVID symptom of the patients. They collected this information before visiting the patient. Also, they check themselves their situation, and after confirming the situation and maintaining COVID etiquette, they visited the patient's home and provided the healthcare service at their patient's home. So this is the simple presentation from my side. Actually, in conclusion, I would say that this is a very simple technology. It's a cost-effective and simple technology, can be operated by the low-level health worker, I mean paramedics in the rural areas. As we have the very limited human medical resource in the rural area, that this system can make a good combination of experts and rural areas using this telemedicine system. And as we provide the home delivery service, so participation in continuum care is ensured. So we find that about 300%, we can increase 300% participation using this system. And the home delivery MC service model of the PA system can go uninterrupted during a COVID situation also. So that's all. This is my presentation about the portable health clinic for MCH. Thank you very much for your patience.
Thank you, Dr. Maruf. That's really revolutionary and yet very simple. And also it's a blessing for the underprivileged and as well as for the inaccessible sort of the patients that are out there. And I'll be curious to talk to you a little bit more about the data transmissibility across this entire workflow that you have, but I'll follow up with you on that. And I'm sure we have some questions that we can address. With that in mind, now I'll pass on the baton to Dr. Archindia, and we will look forward to hearing from you, Dr. Archindia.
Very well, thank you very much. I will now share my screen, hoping that this works. Otherwise, if you are able to share on my behalf, I would appreciate that as well. I think that you have now the material.
No, you could go ahead. You can run the controls from your side. It's easier.
Very good. Okay, I think that it's now on screen, and that I think it's better. So I will click it and go. I represent Istari today. A couple of words of my background. I have been head of IT, global CIO for big pharma companies, Novartis, Sandoz, and Bayer over the last 17 years. So the perspective that I bring to the table comes from the head of IT of many of the organizations that sit in the background, facilitating clinical and medical practice behind some of the statements that my colleagues very eminently just shared. Over the last 2 years, since COVID started, I decided to shift my energy to increasing the resiliency of the data that underpins the solutions that we heard from Oracle for telemedicine and for clinical practice, including in the NHS. As you can see, I will make very simply 3 points to allow for the panel to continue to questions. So I've narrowed down my material a little bit. First point we heard from all of the eminent speakers before is that clearly data has now become our healthcare crown jewel. It is evident to all of us in the panel and clearly to those of you in the audience that this data flows from patient to system to clinician to practitioner, inclusive of machine learning and artificial intelligence agents. And it is possible to tamper and it is possible to intercept this data for nefarious purposes. Hundreds of millions of employees and workers and healthcare practitioners using digital platforms for research, marketing, sales are truly now depending on the integrity and the reliability of the data that they use. And also we must acknowledge that we are merely custodians of this data, that we are consented to use this data by patients that own this data. And in some legislations, the secondary use of the data belongs to the hospitals. But the majority of the ecosystem today is merely custodians of very delicate data flows, including patient information, which is extremely, extremely delicate. It is also very profitable for bad actors, because you may know that patient health records, when they are intercepted by bad actors, they can command up to 7 times more profit than just financial records. So a patient record can be bought in the dark web for up to $700, whereas a financial record can be bought for $100 and even as low as $45. And why is that? Because the richness of the data sets that enables the solutions we just heard are incredibly valuable. And we are, many of us, subject to legislation that makes us want to really report and subject to fines if we are not exercising or work well. The reason for this is that the technology architecture that we most follow is very fragmented. There are commendable efforts by agents like Oracle. We heard some of what they are doing around integrating solution sets that would enable a little bit more of an integration and interoperability within layers. But in general, the ecosystem that we heard consists of very different data exchanges among very different platforms that need to be assembled by solution providers such as Dr. Maruf, that has to be able to really assemble all of this. But we have to keep in mind that every one of these interfaces represents a potential security gap. And this is something that we need to be conscious of and address. A pragmatic agenda for creating resiliency that we all need to adopt consists of 4 steps. And this is true for every one of us in the call and participants in the ecosystem. Number 1, we need to think about the crown jewels that we are custodians of with a perspective of who would want to use this data for nefarious purposes. What is the value at risk? Is it the value to lose or to have data loss of intellectual property? Is it about putting out in the wild hundreds of thousands of patient records and have an understanding of what the bad guys would want to do with that data? Secondly, we need to build a coalition of support around creating an ecosystem where we can achieve acceptable levels of risk. Anything that we have heard so far represents some degree of risk. And what matters is that we get to the point of risk where it is acceptable versus the next alternative, which is to either not offer telemedicine, not offer affordable care and access, not offer artificial intelligence or machine learning empowered data diagnosis. So we need to achieve that acceptable level of risk in a coalition mode. I think that my colleagues, all of them mentioned collaboration, partnership, and that should be our first instinct. The next thing is that we need to secure these core data assets and crown jewels across all of the enterprise and beyond our enterprise. Primarily, identify the crown jewels that we are most responsible for, and this may be patient data, this may be prescriptions, this may be algorithms or diagnosis tools and tooling. And then lastly, make sure that we are talking to our partners ahead in the value chain and enabling us with data to ensure that we are avoiding at all costs being the weakest link of this fragmented landscape that I shared. The last point that I will make is that in data science and in many of the solutions that we have heard, it is not about having a rock solid perimeter and not about building a castle that protects our data. It is about creating adaptability in every one of the elements of our landscape so that we can evolve and survive. It is a very difficult environment from a resilience perspective out there. The crisis in Ukraine and Russia is headline stories, and it is very clear that there are any number of bad actors that now have military grade technology that could bring us down. It is not the best wall that would keep people out. It is the security and resilience mindset that is most adaptable, that is going to allow us to thrive in precision medicine. So with that, I will hand back to the chair and open the panel. Thank you very much, and look forward to the discussion.
Thank you, Dr. Archindia, for highlighting the value of the attention that needs to be focused on data security and data privacy. This is very critical because we've seen a lot of incidences with, cyberware, ransomware attacks across, and the criminals have found out it's more profitable to deal with, to enact such kind of attacks on hospitals and healthcare systems than any banks themselves, because it's easy to get the money out of that. So you have highlighted a very critical area, and we will focus on all those things on our panel discussion on that. With that in mind, I'll pass the baton to Dr. Mariwala to talk about nutraceuticals and other aspects in this case. Dr. Mariwala.
Thank you. Thank you, Dr. Subramaniam. Good evening, everybody. I would like to congratulate and thank the World Health Conference. Could you have my presentation run up, or do I need to do
You
that
can
myself?
state it from your side if that might be easier from your side.
All right, sure. Let me just give it a quick shot. All right, they started.
Yeah, there we go.
sharing
We
it.
can see it.
Okay. Right. So first of all, I'd like to thank the World Healthcare Conference for organizing this meaningful event, where like-minded professionals gather to share the knowledge and recognize industry-leading efforts with the global healthcare needs. Pay due attention to your health is not a new message. As a kid, I heard it from my parents. As a teen, I became a little conscious myself, and as a father, I tell the same thing to my kids. However, the means and convenience to take care of health have transformed dramatically, as we've talked about today. Starting from healthcare devices to treatments, we have all come a long way, and we see different technologies available to us. The last 2 years of the pandemic have given us a whole new thrust, in a way, a blessing in disguise to the healthcare sector, that we've been able to invent and solve problems for the mankind far quicker and faster than we have done it before. And the pace at which innovation has taken place has been record breathtaking. I'm going to talk a little bit differently about what everybody talked about, and I'm going to talk about it from the nutraceutical business point of view, because that's what I am. I'm in the business of nutraceuticals, and that's what we should. I want to focus on. Sorry, I'm not able to move this forward. Yeah, okay. Can you see this now? All right. It's going too fast for me.
Okay, you might have.
Yeah, I might have pressed
There
too
we
many
go.
times. Let's go. There we go. Oh my God, it's gone back too much. This is just a little introduction of myself. I'm a third generation entrepreneur who's involved in this natural products business, and we have created nutraceutical solutions from natural products, and that's our business fundamentally. I'm sorry, this is moving very slowly for me for some reason. So let's look at the pandemic with a different lens, focusing on the positives. The health sector has gained more prominence ever since, and if you look at the world, the 10 biggest deals in the world, the 3 probably biggest deals in the world are in the healthcare sector. So it's attracting a lot of attention, a lot of capital, a lot of investments, and hopefully it's all going towards the good of mankind. Okay, a 360-degree transformation accelerated with COVID in advancements in medical science, with significant digitalization, innovation, and sustainability, and the spurt in digital technologies with speedy access to data analytics is certainly helping all of us do a far better job and a far quicker job of getting to solutions for our customers and our healthcare sector. Okay, the preventive healthcare is getting more relevant, and this is where I step in. And fundamentally, prevention is better than cure is the dictum that we all live with, and we do practice it in every day of our lives. it needs to apply to our healthcare as well. Yoga, health supplements, functional foods as go-to health options, and green health and nutraceutical industry are gaining more prominence. And how can we use digitalization in these sectors is the focus of what we want to talk about. The nutraceutical segment has grown and is continuing to grow significantly. It's capturing a lot of attention because fundamentally, if you can prevent an illness from happening, and you have chronic conditions, chronic medicines help a lot in dealing with these conditions. The question is, how do you spot this, and how do you identify what is it that you're going to be hit by? How do you look at your future? How do you look at your DNA, and how do you look at what is it that you could be at risk for? Are challenges that come in the way of some of the lifestyle-led changes and requirements that we need to apply in the nutraceutical segment. So let's talk a little bit about digitalization. This is where what I'm going to talk about is how does digitalization help the business, facilitate the consumer, and make the consumer's life and the patient's life far better. And the real challenges here are, how can I get personalized nutrition? How do I get personalized preventive healthcare? What can I do to use my technology accessible to me on a day-to-day basis so that I can improve the quality of my life and improve the in life I lead on a day-to-day basis, whether it has to do with my sugar management, my cardio management, my weight management, my fitness indexes, or whether it has to do with tracking and monitoring my conditions on a regular basis so that I can time my dosages well, and I can time my medicines or my injectables appropriately. How can I use this database also for clinical sciences, building clinical databases and using it for clinical studies that can help create far better products and far superior responses to customer needs, so that we can also isolate and identify genotypes that need special type of preventive healthcare handling and testing, which can give us rapid results, which can be self-administered. That data can be made available to doctors and patients more effectively, and to the industry in terms of the databases that we talked about. The key condition here is how does this integrate and work together, and how do we make this happen across the world and on a pace and rapidity with which it is happening in parts of the world. And I think that's one of the things my colleague from Bangladesh talked about, that in certain areas like India and other developing countries, we do need a lot more doctor-specific, patient-specific, low-cost solutions that need to be deployed so that the improvement in healthcare takes place at a far greater pace, and access to healthcare where the number of practitioners, where the practitioner penetration is low. How do we use digital power to make some of these things happen? And how do we democratize the healthcare market far more effectively for the benefit of these consumers? Whether this can be done through telemedicine, diet-based, or medicine-based, or in nutrition-based. I think all these are questions that we need to answer, and I think this is really where the focus of the attention needs to go. I'm just going to skip through this very quickly, but this is more to do with what India can do. This is really my last slide, which talks about how do we leverage synergies through collaboration and working together in these areas to discover different ways of approaching this testing, the validation of these tests, increasing rapid tests that are available to consumers, as well as digitizing the data, training the doctors. In fact, one of the biggest challenges that you face in this case is going to be doctor adaptation of some of these technologies. Is also one of the areas which I think Dr. Kingsland talked about, and we need a lot of awareness building and training and development in that space as well. I think that sums up my slow but quick presentation. Thank you very much.
Thank you.
Thank you, Mr. Mariwala, for highlighting the value and the essentials behind preventive care. You can see that with healthcare, there's the diagnosis, there's the treatment, and then comes this aspect of prevention. Prevention is so many things, you know, using proper nutrition and diet makes a big difference for all these things. With that in mind, I really appreciate all the input that each and every one of you provided. And I'm going to throw certain questions to you as panelists to address some of the critical aspects. And you can see that there is a good bit of convergence in this case from each one of us. We have had a primary care physician, you know, I'm on a technology side. We have someone from the cybersecurity, someone from nutraceuticals, and it's been a revolutionary thing to see that, you know, treatment or the portability of medicine in a box, in this case from Dr. Maruf. With that in mind, from your individual perspective, what do you think is the number one issue in digital healthcare that needs to be tackled immediately? And for time purposes, I'll call out maybe Dr. Kingsland, maybe you can start out from your side and we'll just move around. And I'll open the floor for that.
Chairman, thank you. I know I'll need to be brief. Probably number one, I'd say the issue that's challenging me and our sector is connectivity. Mobile data doesn't work when you're mobile. How often during the last 2 years have we been on consultations where somebody is saying, I'm sorry, my connection's not very good, the video's got to go off. So we're still struggling in the UK. 5G is sporadic. And I think the connectivity, if we're going to be confident, particularly in the utilization of ongoing diagnostics, real-time diagnostics, then I'd say number one issue that the UK needs to address, I don't know the rest of the world, but the connectivity issue, that we have the confidence that that interaction will never be interrupted and transferring of data is secure and rapid. But at the moment, we're struggling with that.
Thank you, sir. And now let me pass it on to Dr. Maruf. And your thoughts on, you might have to, you're muted.
Sorry. Thank you very much. Thank you very much. Actually, when we talk about the issues, there are a lot of, and actually when we talk about digital healthcare or telehealth, there are various issues. But especially in my practice, when I considered the developing country and we provide the telemedicine service, in our case, I would say one of the main challenge I feel about the medical sensor, quality sensor, for portable quality sensor, I mean, because in the rural areas, what we use usually, small devices. And in our program, we are running our activities in different Asian countries, especially India, some part of India, Malaysia, Indonesia, Bangladesh, and Thailand also. But we find that in different countries, they are using different kind of sensor. If we like to use the same sensor, it's difficult to find the same sensor in all these countries. And this is a big issue. And recently we are doing some comparative study of various sensors. And we find that there are a lot of differences in the accuracy, in terms of accuracy. So we are collecting different sensors and comparing the value data of the result of the sensor in compared to a standard Japanese lab result. And we find there are very much variation in the results. So we especially look forward to have some global standard portable sensor. There are many various sensors, but the issues is standardization. Of course, they are passing some standard, but still there are some differences. That's why when we go for the comparative data study, comparative analysis, we find some variation. So that is a big issue from my side.
Thank you, Dr. Maruf, from your side. And now let me pass that on to Dr. Archundia and your thoughts on the number one issue in digital healthcare.
Thank you. What I perceive to be, both when I was investing tens of millions of dollars in artificial intelligence, machine learning, and now when I'm let's say in the defense side, protecting the enterprises my colleagues have mentioned, the number one issue I see is that we do not have standards with regards to data records. So if I have patient health information that is valid, for example, in the Mayo Clinic or in Sloan in New York, and I come over to the NHS, my health record, my clinical history has to be rebuilt. And this is increasingly a barrier to creating data sets that are big enough at the level of detail that we need to be able to bring forward the age of precision medicine and telemedicine that my colleagues have spoken. All of us continue to think about silos in terms of solving for my data problems and defining my data standards. And there isn't consistency between, we're ending up with an archipelago of algorithms, data solutions, preventative diagnosis that is not shareable. Most recently, I had to assemble a gold data set of 400 patients for a rare disease, and I had to buy information from 23 different databases and convert it to a single modality so that my algorithm could run over these different data sets. In the future, we really desperately need companies like Oracle to help us create standards across their data, their clients, and across the different layers that they mentioned, so that we look at things with a homogeneous data set. If you think about things like the Matrix, the main reason they are fantasy is that we cannot exchange data with any sort of standard and harmony today. That, to me, is the number one issue. We have invested as a society hundreds of millions of dollars to try to come up with better solutions, but we're still far from there.
Yeah, thank you, Dr. Archandya. I mean, I know that one of the things that have already been highlighted in many of the partners that we work with is data silos within an organization, because people, even within a single organization, one group can hold the data, to themselves, then pass it on to everyone. That data sharing is a big issue in this case. And specifically from Oracle's standpoint, I think we have worked with NHS and we have saved them like 1.3 billion pounds from the data management perspective. That's been a success from Oracle's perspective itself, and as a use case example that we have. With that, I will pass it on to Mr. Mariwala to share his thoughts on any issues that you think might be critical that someone has to handle with.
I would say two fundamental issues. I think one of them was touched on by with respect to the data speeds and bandwidth. I think the other one is clearly the training and awareness building within the medical community. I think we need a very strong process of putting that into place so that you make doctors far more digitally literate.
That's wonderful. It's great to get your perspective in that regard, and data speeds and stuff. It's talking about latency and bandwidth, and with 5G and other aspects coming into stuff. We just had a conference yesterday. We talked about it. So we can highlight that coming back. With that in mind, I'll move on to my second question to all of the panelists here, where my question is, where are the unique opportunities for innovation in digital health? As you see that you presented each one's perspective, maybe we'll start out with Dr. Kingston and say, where do you think if you have to move forward and where can we innovate, and that could make a difference for everyone in the globe? Dr. Kingston?
Yeah, happy to start. I'm going to move to a very different aspect. Part of my portfolio over the last 10 years has been looking at the primary care development of disaster management. And I've been working in India and Nepal. I'm actually over in Nepal in early May with some training programs for disaster management. And from the primary care perspective, whilst primary care isn't often involved in the response, but it's in the mitigation and the preparedness for all sorts of disasters. And some of the work we've been looking into, which I think is a not unique opportunity, but a really interesting one about the satellite technology, geospatial data for prediction of disasters. And there's some interesting work. There's a number of companies have been talking with, they're using terms like landscape genetics, but system alerts about where disasters may be happening, and particular collecting data from all sorts of sources, from news, social media, blogs, research, which can start to look at this mitigation aspect, which has always been the most difficult of disasters. We're very good, well, not necessarily very good, but we know how to respond. We can mobilize at the time, but how can we prevent or determine where disasters are going to hit? So there's some interesting work through that satellite technology. I think that may be on a global scale one of the huge impacts that we might have. Yeah, that's revolutionary and good to know about your thoughts on that aspect, Dr. Kingsland.
With that, I'll pass it on to Dr. Maroof and your thoughts on future innovations in digital health.
Okay, thank you. Actually, I think that when there is an issue, there is some opportunity also. As my colleague, Dr. Abel mentioned about the standardization of data and this kind of thing, I feel this is one area where there is a lot of opportunity we can work. Recently for the PHR, EHR, and this kind of issues are there, and FHIR is there. Many people are using it, but still, I feel that for the standardization of the PHR or this area, there is a lot of things to work on, and especially when we have a lot of access from one. When we think about the say medical tourism and this kind of thing, when we find that many patients move from one country to another country, one area to another area, but still these days they had a lot of issues to bring their data to the next level. So we need some sort of data standardization in that area. So like using the feature and EHR, this area, I think we have a lot of opportunities to work, and that can be converted in an opportunity, and it can produce a good facility for the international patients from medical tourism and this kind of areas.
Thank you, Dr. Maroof. And I think that's a very critical area because, like I said, in each patient can be connected to 10 to 15 devices. And those devices coming from different manufacturers is very critical that that data is very well standardized so that that data could be, the data interconnectivity becomes a very critical aspect of that. With that, I'll pass it on to Dr. Chindia and your thoughts on innovation for the future.
Thank you. You know, we have discussed a couple of the most appealing things, and I think that the notion of machine learning or artificial intelligence applied to precision medicine is now maybe no longer innovative because we're more in the phase of seeing results and getting to scale on that. But if you think about it, all of this is only possible because of access to data. And access to data depends on patients and clinicians like Dr. Kingsley providing consent to the primary and secondary use of this data by the machine learning agents. I suspect that the next generation of innovation will come in the area of consent management. And bear with me before you shoot me down. Think about this. Today, as a patient, I donate my data or my doctor donates my data on my behalf so that precision medicine can be created. I suspect that the next generation of innovation in this space will be insurance companies or healthcare providers like the NHS establishing some sort of partnership with the people who donate data and the people donating the data getting some benefit out of it. So for example, if I am willing to donate my entire genome for sequencing and real-time evidence as I go through life, and I'm willing to be connected to the sensors that Dr. Maroof was talking about, hey, I want for my healthcare to be free, and I want access to the best healthcare available in the world in exchange for giving you the most precise and detailed data that I do. Conversely, if I want to be extremely private with my data and I just want the benefit of others donating their data, then I will pay for that precision medicine. So I suspect we will see a lot of developments in the field of consent management and data sharing in exchange for value. I think that patients are waking up and patient advocacy groups are waking up to the idea that the data is extremely valuable and they do not want big pharma companies or large corporations to benefit of this data coming to them for free. So I suspect we will see a lot of innovation in terms of the next generation machine learning and artificial intelligence coming from true ownership and value sharing. In a nutshell, it will be value sharing of data consent and data access. Back to you.
Thank you, Dr. Ashwindia. And that's highlighted. I don't know if all of you are familiar with this, the people that are dealing with the HeLa cells, basically science. Those were the cells that was provided from Henrietta Lacks. And that cell was used, but no one received any consent from that patient. And recently that had a lawsuit against one of the companies that has been selling those cells, but the family has sued the thing because the HeLa cells are being used without the patient's consent. So that's a perfect example of that, but at least from a traditional perspective. With that in mind, I will pass the baton to Mr. Mariwala to talk about his thoughts on innovation for the future.
I am looking at it from the preventive healthcare and nutrition part of the work, the industry, and I look at the number of people that suffer in poor nutrition, and I think we need to create databases that can help us get access to those people and their limitations in food and nutrition that they consume, so that, you know, what can we do to look at their diets and balance their diets in a little more effective way so that they're advised appropriately, and rural healthcare penetrates that segment, I think is really the need of countries like India, for example. And that's where large populations lie as well, of people who are undernourished and poor, you know, and poorly fed, which is what causes health concerns and questions for them as the population continues to grow in these regions. So some amount of innovation in that space is, I think, what is going to give us a tremendous amount of a boost in improved healthcare at the rural level. Penetrating the bottom of the pyramid is, I think, the need of the hour for a country like India, for example.
Thank you, Mr. Mariwala, on that. That's very critical to have that kind of databases. And I think even within the US, you know, we have so much diversity of people coming from so many different parts, and their dietary standards change, and that also has an impact on their own health care. And that kind of having a database and that standardization is very valuable. With that, I'll push it on to the last question in this thing is, based on each one of your experiences, do you have any regional success stories or learnings in digital healthcare that can be propagated to other parts of the world? I know that Dr. Kingston, you mentioned about the use of satellite technologies to predict disasters, and you work in Nepal, but anything else that you can shed your light on transferable skill sets that can be used from your own learnings?
If I may, I'm going to go from satellite technology to back to basics, because one of the things we've noticed, we've been working with the American Medical Association as well, and they've noticed a similar, the rapid change to online consultations without the development of the necessary skills, because the consultation changes quite significantly, the expectations that we've talked about, the legal, the governance issues, and the data protection, and also the use of the technology, which isn't common to many clinicians, and adopting a particular new type of interaction needs training and education. And I left a note on one of my slides, but our main success is the development of this master's course, which has been well received across the UK and is being adopted, and we're making available at the moment only in the English language, but I think it would translate to all sorts of interactions, which would make the patient experience far more better than some of the experience they've been receiving by this rapid change to online consultations.
Thank you, Dr. Kingston. I appreciate that. And I'll pass it on to Dr. Maroof and your thoughts.
Okay, thank you. Actually, the system, the portable health clinic system that what we developed, actually our main vision was to develop a system that can be used any part of the world, especially the developing countries. And since our development, we have already bring it in 10 different countries, but I feel that there is a lot of opportunity to use this kind of simple technology especially in the developing country in Asia, Africa, and other areas. At the same time, when we develop it for the developing country, we find that there is a good opportunity for this kind of system, even in the developed country. Now, you know, I am in Japan, so we are also thinking how we can use the portable health clinic type system in Japan, because the developed country has a big issue these days, and that is the aging population, aging community. So when the aging community is increasing, it's getting difficult even in a country like Japan, because the number of young people are reducing and senior citizens are increasing. And so the doctor-patient ratio is in future, it's going to be in a critical situation, even in the developed countries. And it is very important for the senior citizen to provide them the healthcare service, possibly in some form of home delivery care. So our system, like a portable health clinic, we are working on this system to make it little customized for the developed world, like Japan and European countries and other areas. So although we started for the very basic, very primary healthcare for the developing country, but we find that we can improve it because this is a modular system. We started with the non-communicable disease, then we developed the MCH care on it. We also developed the eye care of the portable health clinic, and we can extend it in different other areas as per requirements. And at the same time, when we use it for the developing country, but we feel we can use it with some customization to the developed world also, especially to deal the aging community. So thank you.
Thank you, Dr. Maruf, and that's really enlightening in that sense, because we had practiced something like that when I was at GE Healthcare, because if you look at MRIs and stuff, normally it's made in the US and shifted to other countries. It's a very expensive process, but they came up with a thing with the reverse globalization. You know, they looked at practices of that being used in other countries. You don't need a very high resolution for the MRIs and stuff. And now that they propagate, and they brought that idea to, and they had a segmentation of the market. That was an example that we had used with reverse globalization of that aspect. So it has a practical value. With that, I will pass it on to Mr. Archindia and his thoughts on this aspect.
Thank you very much. I am very excited by the discussion so far in the panel, and I think that I will mention the achievements of my former colleagues at Bayer in creating a series of algorithms based on assembling data sets for machine learning around the early diagnosis of tumor and non-tumor abnormalities in tissue. The reason this, I think, is very transferable is that what I saw is that the algorithms that we tested and trained on one type of solid or non-solid tumors, we could then extend to other types of lesions easily. So that was one direction of travel. So using the same algorithm that was trained in one type of tumor, extending it to other types of abnormalities. That's one way to grow. But the other very interesting is that you can take that algorithm and make it eventually open source. What that means in technical terms is that it belongs to all of us. It does not belong to anyone. It belongs to everybody. That to me is going to be the fundamental promise of precision medicine, that we can perhaps train and develop algorithms for diagnostics and eventually for companion therapies that are based on machine learning, and that eventually we can put them in a library that is accessible to physicians, clinicians, and researchers everywhere in the world, that they belong to humanity. And that, I think, is what would be most dear to all of those in the clinical profession, in the medical profession, that are healers at heart. You are not moved by profit, you are moved by impact. And in my mind, being able to enlist the support of hundreds of algorithms that are out there already, and that they belong to all of us, would be, to me, what would be the most scalable of this. Now, of course, this will be equivalent to the going generic or off patent of medicines, such as, for example, those medicines to prevent infection, medicines to prevent other kinds of disease that are now part of the public domain. I wish that we have an equivalent in algorithms of machine learning that can be enormously scalable. We are not there yet, but that is what I see as the next frontier.
That's wonderful to know that, yeah, because with these open source technologies and tools that are available, you can propagate that value across the globe more easily. And that's, very, very important in this case. With that, I'll pass it on to Mr. Mariwala on his thoughts. I don't know, did he get disconnected? I presume he got disconnected, but he can come back. In the meantime, thank you so much for each one of your inputs on, your presentations, as well as your thoughts on those 3 questions. We'll throw the floor open to any audience who has any questions. They can post it. Dr. Garg, any questions from the audience or anyone out there that we could address?
I think we have not received any chat or question.
Okay.
But I have a question.
Go ahead, please.
And my question is that what are the 3 main steps three main steps one has to take. This means our country has to take, any country has to take, to increase the affordable health care to the masses.
Wonderful. Thank you so much. Maybe I'll throw the floor open to the panelists. Maybe anyone, Dr. Kingsland or Arjun, maybe why don't you start and maybe your thoughts on this in terms of increasing affordable care?
And this is question to you also, sir.
Sure, I will also answer. I'll let the panelists start out and then I'll close it out. Anyone?
I'm going to take a stab at it, Abel here. I think that to me, if we can find a way, I mean, many of my fellow panelists talked about the notion of access and accessibility. I think that Grameen and Dr. Maruf have shown the way it is possible to serve very diverse populations. But if you think about the needs of countries like India, Brazil, Mexico, China, the problem is the ratio of radiologists and other means of diagnosis. The great majority of these populations will never have access, or not in the next generation, access to a physician or a radiologist. So empowering initiatives like what we heard from Dr. Maruf, I mean, so that we can bring medicine using things like the cellular phone to those in need. I think that would be, in my opinion, the single best thing we could do, to bring effective remote medicine based on simple biomarkers by means of smartphone-enabled primary care. I wish this for the next generation of the needy coming up in Brazil, Sub-Saharan Africa, the Southeast Asia, and we're talking about billions of people.
Wonderful. Thank you so much for that. Anyone else, Dr. Kingsland or Dr. Maruf?
Happy to have a stab. I always revert to I think for triple value healthcare. I think if it's the three main steps, it links with the value we place, and there's always going to be a link with policy and politics, because the first thing is how we allocate resources. Certainly on high-income countries and some of the struggles we have with health inequalities is the allocative value sometimes in the NHS isn't best. You know, so we focus our resources on things that we know. So it's very difficult to through contractual mechanisms when you're being paid to take the blood pressure of wealthy people as opposed to focus your efforts on children in poverty. So sometimes our contractual mechanisms have to change, and if we're changing care, then we have to change payment systems, and that's one of the big issues for politicians. So the allocative value is really important. Then how we utilize the technical value in our system, utilization of resources, because sometimes we have all sorts of waste and duplication. So it would be looking at how we increase the utilization. And then the final thing is the value of people and patients, because sometimes we allocate what we think people need or where the politicians think are best deployed, as opposed to what matters to people and patients. And some of the things that they need may not be how we are deploying. So there's this concept of triple value healthcare. I don't think it's the three main steps that Dr. Gard was asking for, but I think some of those issues that need to be addressed if we're going to have affordable healthcare is how we reduce waste and duplication in a system, how we allocate it based on the real need, and that's where our data comes in to allocate resources to the greatest need, and we don't often do that. And then what really matters to patients, how we measure the impact of our resources based on patient needs and sometimes wants. And we really struggle with that in the UK as well.
Thank you, sir. And how about you, Dr. Maruf?
Okay, thank you. I think I agree with all of them, what already mentioned. But from my point, I would say that to ensure the quality service to all the citizens of a country, in the developing countries, especially where we are lacking our infrastructure problem, we are lacking of our human resource problem. So infrastructure is something that is development is, if we think physically, it's a very expensive one. So I would recommend for the infrastructure to promote the ICT. We have to make the best use of ICT. If we can make the communication, we can make the internet connectivity, it can improve the connectivity, then we can share our human resources, because in rural area we are lacking the number of doctors, but in urban area we have a lot of doctors. So if we have a better network facility, if we have better infrastructure, then we can share the human resources, urban doctor, and we can use the rural health worker. So if we can make a good combination of rural health worker with the trained urban doctors, with the professional doctors, if they can work in a team using some network, then that could be a best use of their human resources. But another big issue I feel that, especially in the developing country, whenever you develop a system, whatever cheap price you set, still people have some struggle to pay the money, especially in the rural area. So I think there is a big issue, and that is the health insurance. Every country should have some sort of health insurance policy. Government should think of it, whatever level it could be. It could be micro insurance or some sort of that kind of thing, but that must be there. Otherwise, any healthcare service will be very difficult to make it sustainable. So I would recommend to develop the ICT-based internet infrastructure, and I would recommend to make best use of resources with a combination of expert and health worker, rural health worker. That is, we need the combination of them together, because we cannot have a huge high quality human resources. So we have to make the combination so that we can make the best use of them. And health insurance is a must for any level.
Thank you, Dr. Maruf. And I'll close out with an example from Oracle to address Dr. Garg's question on this. Is one of the areas is epilepsy, right? There are 65 million people around the world that suffer from epilepsy. But the diagnosis and treatment is a very expensive process. And the leading center for that is the All India Institute of Medical Sciences, where Oracle has partnered with expert AI in UK to come up with a solution on this. What we did is they come up with a portable system in which if a patient that suffers from seizures, you can put a cap, and with the electrodes, that information is sent to an app on a mobile device. So that captures the moment the seizure starts, they can start imaging the brain, and that imaging is done on the mobile device and immediately sent to the clinician who can act on it. So with that case, they can actually see where the seizure started in the brain and how the seizure is moving to give immediate relief. Imagine in the other case, if the patient had to go to the hospital, it's a very, very expensive process. It is limited only to certain people. Now, with this expert AI and the Oracle collaboration through new startups, Oracle helps with a lot of new startups on this to make this technology more affordable, and you can bring it to the masses. And that's one example from our side for the diagnosis and the treatment of epilepsy. So I'll stop at that stage and thank each and every one of you for your time, your participation, as well as for your input, and to Dr. Garg for giving us this opportunity. And I'll close out that. Any closing statements from you, Dr. Garg, or anyone else? It's been a wonderful experience learning from each and every one of you.
Thank you, Dr. Nand Kumar, Balasubramaniam, and all the experts for giving their full and you can say today's final on this issue. There are a lot of learning to me, to all the participants, and all from each of us. So thank you very much. It is a wonderful session, and thank you for sharing and giving presentations. Thank you very much.
Thank you and goodbye.
Bye.
Thank you.
Allah, we will have this conference next year from
Okay.
From 12 to 13, not 14, 12 to 13 of April 2023. And we will invite your organization and you to kindly support us and share wealth of information.
Thank you, sir. Really
Yeah. Our purpose is that best technology should reach to the poorest of the poor. That is our mission. And modern healthcare is a need of our to each and everybody.
Thank you, sir. Appreciate that. And it's been a wonderful experience.
Thank you very much. Thank you for
Bye.
Bye. Very ably cheering. Thank you very much.
Thank you, sir.
Yes, Puneet.
हाँ जी सर.
इस सेशन में आ गए सब लोग.
Yes sir. Dr. Pyara is there, and we are waiting for Miss Heather. And Poonam is also there.
Founder and Chief Radiologist, Mazan Imaging Chairman Health. So a very warm welcome.
Thank you. Thank you.
All of you gentlemen and
Yes.
ladies for having
All are
joined
there,
us
sir.
in this session.
Yes.
Hello, Dr. Garg.
Yeah. So welcome. This is good morning there.
Yes, indeed, on Pacific Time, United States. Lovely to be here.
Yeah. So within a minute, we will start. Welcome, ladies and gentlemen. This is a plenary session 6, neurology, mental health, behavior health, and psychology. And we have a distinguished panelist, distinguished speakers. Ms. Heather is a founder and chief executive officer, Equilibrium Health. Dr. Perry Vigilance, Vice President for Population Health and Social Impact, same organization, Equilibrium Health. Lucy Jong, co-founder, Carco Neurotech UK, and Poonam Bhargava, Director, Vinod, the Learning Academy Certified Holistic Wellbeing Counselor. So, welcome, Poonamji. Welcome, Perry. Welcome, Heather. And now we will request Dr. Heather to kindly address us. Dr. Heather, please.
Thank you so much, Dr. Garg. It is my great pleasure to be here. First, may I respectfully correct, I am not a...
Your voice is less. So kindly increase the volume.
Is this better? Okay, very good. Thank you. Just first, respectfully, I'm not a physician. I am an entrepreneur in the field of health transformation, and it's my great honor to be here. Dr. Garg, may I first confirm within our use of time just how much time you would like for me to speak on my segment within our allotted time? I apologize, you're muted, Dr. Garg.
Unmute, sir.
Ma'am, you and Perry can speak 40 minutes, 20 minutes each.
Okay.
Is that okay?
Yes, that is just fine. Thank you very much.
Okay.
All right. I am going to share my screen. Is everyone able to see my screen?
Yes.
Okay. Thank you very much. It's my great honor to be here today. My name is Heather Lee Flannery. I am the founder and chief executive officer at Equidium Health. I come from the intersection of emerging technologies and healthcare and life sciences. And my work focuses on particularly how to achieve health equity globally by changing the way that we process, collect, and use information about patients globally. We have this term we call data liquidity, which is meant the ability to freely use health information in many categories, which I'll be talking about today, in a way that preserves the privacy, dignity, and agency of the subjects of the data, people like you and me, and patients everywhere. We're deeply partnered. We are a technology company, but we build new kinds of public health interventions in our company, led by Dr. Vigilance, who will be picking up after me to go into detail on what those public health interventions look like. And the two of us together are going to be talking with you particularly about the behavioral health implications of our work.
Heather, interruption. Speak a bit loudly or increase the volume, please.
All right, let me see. One moment, please. Let me see if I can correct something. Just a moment. I think I will.
It's okay. It's okay now.
Okay, very good. Here we go. So the first idea I would like to start out with as we think about behavioral health in this new, massively technological society, we must think differently about the definition and our understanding of the nature of data. And when we think about behavioral health, for example, let's say prevention of suicide or suicidality. Human beings in crisis in a digital society leave signals of their crisis in their data all over the ways that they engage in digital experiences. This data it's not the same society that we began treating mental health in even 10 years ago. It is a radically different world because of the way that data is collected and used, and the amount of signal and evidence of mental health crisis or perhaps chronic mental health illness is now evident in data that is available to some people and some institutions some of the time. But we have the opportunity to radically improve the way that we can use this data for mental health purposes in ways that were unimaginable even 3 years ago. So the technology that I want to tell you about is extremely new, but it represents transformative potential for the field of behavioral health and public health. And in our opinions and in our great conviction, we believe that this new family of technologies can make it possible to better implement social determinant of health interventions. So the first thing I would like to tell you about is my mentor and friend, Dr. Melvin Greer. He is the chief data scientist at Intel Corporation, and there's something he said that made a very big difference in my life and has influenced the way that Equidium Health and our partners and allies are seeking to implement technical transformation to achieve public health aims. People talk about data being the new oil all the time. Data is the new oil. We believe that that is the wrong mental model. It is not the correct metaphor for us to think about data. especially not the most intimate and the most private data there is, which is about the inner workings of our private minds, our families, our homes, those things that are most directly impactful to population health endpoints. In this technological society in which we now live, personal data is inseparable from personhood. This may not have been true 15 years ago. It may not have been true 10 years ago. But the tragedies unfolding in the COVID-19 pandemic and the disparities in outcomes, morbidity, and mortality in especially vulnerable populations have shown us that when we must move almost immediately to a digital-first health system, digital inclusion needs to be conceived of as nothing less than a basic human right. And if digital inclusion is continuously about the data that is generated with every breath we take, every heartbeat, every step we take in our location data, every participation in the economy in which we live in any non-cash transaction, then it is imperative that we reconsider how we think about this information, how we process it. Because as Dr. Greer said, data is not oil and data is not fuel. Data is people. Personal data being inseparable from personhood is fundamental to the strategies that we outline that we think can affect or create entirely new and very exciting possibilities. In this, I'm honored to say that we have partnered with Dr. Greer to create the Equidium Foundation, also under Dr. Vigilance's leadership. So you'll be hearing more from him shortly on the work of the foundation and how this influences this intersection of emerging technology, public health, behavioral health, dignity, agency, and privacy. There is this law that many of you may be familiar with called Amara's Law. Amara's Law you can read about on Wikipedia and find anywhere you like, but here is the essence of that law. It means that human beings think about the impact of technology and technology progress in a linear way. We imagine things happening at a particular pace that doesn't involve radical disruptive change. And we also tend to get very excited about new technologies. We get inspired at the beginning. And so at the beginning, when a new innovation, we become aware of a new possibility, there is a period of extreme enthusiasm, wherein we estimate the time horizon, not the potential, but the time horizon in which a technology can in fact begin to benefit society, benefit you and me and our families and our communities. But then when we begin to see a non-linear acceleration of the impact of technology, we move into a stage where we greatly underestimate the timing of when these capabilities can impact and how especially, and this is not part of Amara's Law, but in part of my personal opinion, there's also great difficulty understanding when it is not only one emerging technology that we are considering, but rather the convergence of many emerging technologies, trying to conceive how one very radical, very fundamental technology can change the world is very difficult to do. Trying to imagine how 5 or 6 of them all emerging at once, that almost defies the capability of the human intellect. Now, I say all of this because I'm going to tell you about emerging technologies right now that I believe are extremely relevant to the short-term future of the fields of mental health and psychology and the ability to improve social determinants of health, rethink public health. I understand if you're skeptical, but I would suggest that you consider that your skepticism may be influenced by cognitive biases such as Amara's law, where you tend, all of us humans tend to believe that, oh, this is far, far away. 6 years ago, we never could have imagined that almost anywhere on earth you could use an app to call a car to come get you and know exactly where it was and exactly where you were going and be able to pay for it and just get right out of the car without even stopping to pay. And in just a few short years, the entire ability for human beings to achieve transportation was reworked. And that was a Web 2 innovation. And if you've heard about Web 1, Web 2, and Web 3, Web 1 brought us the ability to communicate in one direction. You could publish content from a website out to the world. Web 2 brought us the ability to engage bidirectionally and created the capability for all of us to be content creators and for all of us to engage in extraordinary social technologies like Uber, for example. Amazing technologies there, but we lost something along the way that we didn't intend to lose, that was unintentional. We lost the privacy that we all have intrinsically in a non-digital world. We don't have to fight for privacy when the information's on pieces of paper. When the information is literally everywhere, it's different now. As you may have been aware of the Cambridge Analytica scandal that revealed to the world how much information is actually available and can be cross-sectionally analyzed in order to predict and frighteningly influence our behavior. From the perspective of mental health professionals, the idea that the most vulnerable cognitive states in patients that we treat can be discovered by artificial intelligences quite easily and then deliberately, meaningfully exploited. For example, in order to produce a form of social unrest that might favor one political party over another. This has happened in countries all over the world. It has been clearly shown. We don't think about the mental health status of those populations enough. We don't think about what it means to be a person affected by depression or anxiety. A person, perhaps that could have any number of different social, emotional, and cultural vulnerabilities being deliberately and skillfully influenced, targeted in a way completely unique to their psychographic profile, their demographics, and so much more about them that you as their providers could ever reasonably know. It's truly frightening. And it means we have to get control. We have to give the control back to the data subject in how this information is used. But that means if we create a just system, then the data subjects, the patients, you and me, can make that available volitionally, by choice, can make that available to our caregivers, to our community health workers, to the people who need to help us and want to help us. We can unlock that information while still remaining in dignity as so much of our selves are now revealed in big data about us. The technologies I'm going to talk about are blockchain, AI, and advanced privacy preservation. The important thing, you may have heard a little bit about blockchain. The important thing to know is that for our industry in healthcare and life sciences, the vast and important critical idea is that blockchain can both unlock the potential of AI while critically providing the guardrails, the protections that we need so that that AI can be trusted, can be ethical, can be dignity preserving instead of creating great undue and unintended influence over individuals, families, and communities. So just a very quick thing, there's a lot to know about these new technologies. When it comes to blockchain and Web3, there's really only one important idea, only one thing that really matters. And it's to understand that blockchain is adding computational trust into every aspect of our evolving digital society. That means provable computational trust. Right now, we only have the ability to go on the words, the brands, the institutions of everyone that we work with. But in the future, as this technology is injected, into every aspect, it means there will be computational trust, or there will be the glaring absence of computational trust. And quickly there will come a time when there are systems, institutions that can deliver this computational trust and those who cannot. And we believe that there will be a strong, compelling need in the near term to interject this computational trust into the systems that handle personal data, especially for healthcare and life sciences purposes. In finance, this is already going very strong. It has hit finance like a tsunami. These are just some headlines to give you a sense. 9 countries have already introduced central bank digital currencies. The market cap of crypto is over 2 trillion now, 2 trillion US dollars. We now have this as part of our discourse in our geopolitics. So this technology has hit our world in a very big way. And now what's coming next is it is going to impact healthcare and life sciences. And with leaders like you, like all of us here assembled, we can shape the way that technology impacts society. And I believe it is our responsibility to do so, to deliberately, thoughtfully, intentionally design the way that these very powerful technologies are used to benefit humanity. And especially in our most personal and private and vulnerable spaces, this is more important than ever. We in healthcare and life sciences, we have so much more at stake than the financial services industry does or the finance industry does. Not only is our data radically more complicated, it is so much more complex. But we also, if there are to be errors or fraud in finance, you're talking about a loss of profitability. In our industry, you're talking about morbidity and mortality. It is the relationship of that industry to their consumer, their finance consumer, is so different than ours, where our relationship is the ultimately sensitive relationship, the most sensitive relationship. So we have such important work to do, but such inspiring potentials about what is possible. So in this future that is coming sooner than we think, coming very soon, remember Uber. Remember how fast it happened and how it's only accelerating. Consumers, patients are going to be outfitted with infrastructures that allow them to aggregate, curate, analytically utilize, exchange, and monetize far more data about themselves than any single enterprise or government ever could. This can unlock enormous potential. When we think about mental health and social determinants, generally, most of that data doesn't exist in traditional health records. And mental health status is only as present in mental health records as a population was able to access care. If a population was never able to access care, then there is not any data anywhere about the mental health status of that patient. We have the potential to derive that data in a way that empowers the data subject and keeps them in the center of their care and hopefully the achievement of their own goals and aims, social, emotional, cultural, and economic. So something that may not be obvious or intuitive about this is that this same technology that can assure identity can also assure anonymity and has the ability to create gradients between anonymity and identity and confirmation, verifiable identity that has never existed in human history. This has enormous implications for sensitive and stigmatized mental health conditions where in many circumstances patients affected do not wish to be identified. And we think it can be a life-saving change to be able to access care anonymously, but to have verifiable data for the provider to know that the patient is real, to get real, valid information, and then later, when the patient has decided it is safe to trust, they can choose to reveal their identity. We believe that that has radical potential in the field that we're here to discuss today. Something that is important to know is this idea. We already live a digital life in another digital world. This idea of the metaverse, where that world is going to become more immersive, more stimulating, more emotionally rewarding, potentially more addictive. All of that reality of the metaverse is also part of what is coming now. And this has vast implications both for how can we take a digital twin that is assembled around an empowered and protected data subject and use that for human subject research that is on a digital twin that has absolutely no risk to that human being in the form of in silico research. The ability to perform in silico research on digital twins in the field of mental health, where we have far more complex and rich data, such as what you see on this slide, is one extremely exciting potential. And so with that, I'm going to skip several slides here because I want to get to a key point, and that will help me transition to Dr. Vigilance. A couple of key points. First, this one. We live in a technological paradigm where any data that you want to use for analysis purposes has to first be centralized. As healthcare and life sciences professionals, you know how difficult that is. The data capture, how you govern that information, how you get consent to move it from place to place, very, very inhibiting to progress and very compromising to the privacy of an individual. Well, this family of technologies makes it possible to stop doing that. Most of the time, maybe not all of the time, but most of the time, what we actually need from the information is derived data. We want analytical findings. We want insights, whether we mean at a clinical level or at a population health level. It is the derived data or the value of the data that all of us are really working toward. Well, now it's no longer necessary to centralize data in order to create derived data. We have the ability to bring the analytical process to the data, wherever it is, under the custody of an individual patient or residing at an institution. This has radical implications for our field, and the technology to enable this is here. It just hasn't been implemented yet, but it has already been created. And we are at the precipice of truly transformative change. So the one thing I want to suggest is that we would need to inspire consumers to be willing to share their information. And we believe that altruism, personal goal attainment, and economic participation are all motivators of individuals. But importantly, their motivators change over time. And I think I'm at time. What I wanted to end my talk with and segue to Dr. Vigilance was about how in the future we are going to need a new class of utility. And I mean utility literally like water or power. And that new class of utility needs to facilitate for the person this ethical, protected use of their personal information. So we call these person-centered data utilities, and Dr. Vigilance leads the effort for one called Health Utility Grids, and also our related work at the Equidium Foundation. And with that, I'll close my commentary and thank you all very much for listening to what I have to say today. Dr. Garg, do you want to make any transitional statements, or should Dr. Vigilance begin? You are muted, sir. I'm sorry.
At the end, Dr. Vigilance should continue. Please.
Okay. Thank you very much. Over to you, Dr. Vigilance. And I'm just going to leave this slide up for you to discuss the utilities.
Thank you. That's perfect. Can everyone hear me okay? Yes, excellent. Thank you. And thank you again, Dr. Garg. Thank you to the World Healthcare Conference for inviting us to attend and to participate. It's an honor and a privilege to do so. I definitely want to also give thanks to our founder and CEO, Heather Flannery, for not only that address, but for stepping forth and putting this very, very bold vision and into action, and actually bringing partners together to make this work a reality, not only in the US, but elsewhere in the world. So thank you for your vision and for your leadership. I want to start off by saying that we would not be having this conversation at all had we been more effective globally in the pursuit of and the actual achievement of health equity. Health equity is something that a lot of people are talking about at the moment. There's a great deal of attention being paid to it. It's been called different things over the years, but it's an important North Star for us to keep in place. And our pursuit of that is incredibly important with respect to everything that we're doing, not only on the technology side of things, but just generally with respect to health and wellness. Just a bit about myself very quickly. I am clinically trained in emergency medicine. I was actually born and raised in the UK, grew up in London, grew up in the South London area specifically, and came to the US in my late teens. Went to undergraduate college here and majored in biology, and then went on to medical school and public health school at Johns Hopkins. Did an emergency medicine residency at Howard University Hospital, and went on from there to work in a few different settings, clinically, and then also in the nonprofit space, and then in government, where I was an assistant health commissioner in Baltimore City, and health commissioner in Baltimore County, and in our nation's capital, Washington, DC. Spent some time in government, doing the public health work as an appointed official. And then in academia, I was the Associate Dean for Practice at George Washington University's School of Public Health, also in Washington, DC. And in the last couple of years, I've become more involved in health technology related ventures because of the understanding that individuals like Heather Flannery and others have, that we have a dire need in this ever increasingly digital world to engage health technology more effectively in the pursuit of health equity and the improvement of health and health outcomes for all communities. Some of which are more able to engage than others, but that is the sort of position from which I come into this. So there are a couple of different things that I wanted to talk about during my time. And one of them is to sort of highlight the fact that although we talk about healthcare a fair bit, healthcare is just one piece of the health pie or health puzzle. Health itself has a number of intersection points, intersections between health and housing, obviously, education, employment, workforce development, community development. There are intersections between health and all of these things. Healthcare has an important role in that. But these other determinants, the social determinants of health as we refer to them, are also critically important. And that ecosystem of other sectors that are engaged in healthcare, as achieving health, are very important, and we'll talk a bit about those. The other point that I wanted to make at the outset here is we talk a lot about patients, but patients are people before they become patients. And what I mean by that is that people are in their communities, not necessarily engaged in healthcare. They may not have a doctor. They may not see somebody as a provider on a regular basis. And therefore, their data, as Heather was referring to, is not captured in a healthcare system because they are not yet patients. And so one of the premises that we come from is that while the electronic health record or the health record in whatever format it is, paper or electronic, is incredibly important in the healthcare setting, it has limited use to the social and the determinant spaces that are outside of healthcare, but that are incredibly influential on health and health outcomes. So when we refer to consumers, we are talking about people who may be patients or people who may just be citizens, living their lives, interacting with these different systems and involving themselves in their day-to-day as they go through life. And some of this is obviously involving technology and potentially some other opportunities as well for interaction. And to the point of healthcare not being the only sector that is important here, healthcare cannot continue to try to go this alone. I know healthcare tries to partner a lot with different organizations, and in the US, the spend on the social care side of things, it pales in comparison to that of other countries, where the social spend is very much aligned with the healthcare spend. And we need to be doing more of that merger of healthcare and the social care side of things in order to achieve some of the outcomes that we're referring to. And it's the only way that models like ours, and in general, how health equity is actually going to be achieved. So I wanted to, in sort of going into this from a health is more social than medical perspective, talk a little bit more about the data and the data that is collected about people, about all of us in different sectors, and how taking a patient-centric approach, as we do at Equidium, and a consumer-centered approach means that the consumer is at the center of this wheel of interactions with healthcare, interactions with community-based organizations, interactions with government organizations and retail and many others. There is data that is generated by all of those interactions, and that data typically sits in those individual spaces, in those individual sectors. Rarely does it cross over because those systems are themselves sovereign, if you will. There is the siloedness to each of those. Even within government, as I have some experience in, even within a single city's government, different agencies will make use of different data systems for the same consumers because they're serving them for different needs: housing, transportation, education, etc. But those systems don't speak to each other. There is little to no interoperability in those systems on the data side. And so on the programmatic side, there isn't any either. And individuals as consumers, as users of these services, have to walk through multiple doors, often repeating the same information to many different people about themselves, and information that is impactful in one sector that may impact a different sector is not necessarily shared. And that can be just within one particular enterprise, i.e. government. The same can be true in some of these other sectors. Community-based organizations face these challenges, as do health systems. So imagine a situation where instead of these silos existing as they do in these silos existing as they do in these sort of individual spaces, a network of those organizations being created to create a more comprehensive view of the person in the middle, the consumer, that individual who gains access to all of these different services and whose data, with that person's consent, can be shared with other organizations outside of the ones that they are primarily engaging with. Being able to do that and creating this new, better data is a part of our goal, if you will, and creating the infrastructure for that is another part of that. The infrastructure for that is what we refer to as a health utility grid. So in the same way that you think of utilities as being gas or electricity or broadband, for example, where those particular assets flow through those pipes and wires, in a health utility grid, the information that is gathered by an individual and from an individual with their consent is what flows. That data is what flows through the pipes, if you will, of the health utility grid, and being shared by a number of different types of organizations or with a number of different types of organizations. It enables a more comprehensive view of that person and the ability for the systems, multiple sector systems, to be able to better serve those individuals, because they will then be able to be matched with services that are either put directly in front of them or can be put in front of them by making use of an intermediary, like a community health worker or some other kind of health advocate. Now, why is this important with respect to mental health and with respect to sort of behavioral health? It's because there are a number of great studies out there that have highlighted the fact that in this digital world that we're in, there are significant opportunities for people to feel very isolated, to not feel engaged, and to actually become disconnected from each other by virtue of the way that we are doing more of our interactions. And some of that disconnection is at the institutional and the enterprise levels with respect to how we are served by those organizations. And so the putting the person in the middle of this construct, if you will, and empowering them with ownership of their own data and control of their data and the understanding that it will remain private and that it is secure, can significantly enable individuals to be able to access services that they have a desperate need for, not only for themselves, but also for their families, and potentially has the opportunity to be data that offers them an ability to be remunerated as well, because our data is valuable, as has been shown by the examples that Heather gave with respect to Facebook and the Cambridge Analytica situation and just their model in general, monetizing you as the individual. So that is something that is a new construct. The health utility grid we see as something as being an opportunity to empower not only individuals, but communities and enable them in a number of different ways so that we can improve health outcomes and on the way to improving health equity within these communities. But this requires a great deal of change with respect to how we address what's called the digital divide. This is the lack that there is with respect to connectivity in some communities, but not only broadband connectivity, but even access to hardware, tablets, PCs, smartphones, etc. There is a divide there. And in pursuit of tequity, a term that my colleagues at the HLTH Foundation and Ipsos like to use, there is this need for us to not only provide improved access, but also improve ability for people to adopt the use of those technologies, consistently use them, and then as a result of that, have meaningful outcomes. The Equidium Foundation sees digital inclusion and digital equity as a cornerstone of the work that is needed to be done in order to effect all of the changes that are happening downstream with technology companies, not only like ours, but others as well. If we are truly going to be able to engage everybody in these new ecosystems, we need to be effective in our digital inclusion strategies. So our education efforts with respect to this will include some digital inclusion curricula that will be provided to communities directly and to others who are serving communities. We'll be advocating on behalf of those communities and on behalf of policies that are engaging of communities related to technology and the ability for individuals to achieve some self-sovereignty around their handling and use of data, empowering them to be able to actually do the things that we're referring to with their data, because it is their personhood, as Heather mentioned before. There are a few other elements to this that include the opportunity for people to engage using their data as a donation, if you will, donating assets related to their data for the purposes of the foundation. We are a nonprofit foundation. And because of our technology leaning, the open source software elements of things for our developers who are particularly concerned about low middle income communities and communities of color, improving the ability for those developers to be able to use open source software that we can provide them access to in order to put better products into the hands of communities for their use. So in wrapping up, the commentary here is very forward leaning, and we recognize that as of today, as is on this slide, there are data and technologies used by single enterprises, but in the new tomorrow, there is going to be a need for the individual to be able to be not only capable, but enabled with respect to their own personal data, such that they can engage in the sharing of that data with a number of different organizations who will be networked themselves for the purposes either of improving health and health care and for the purposes of the research end of things, and also to reduce some of the isolation that there is between these sectors that fosters and increases the isolation that is felt by the individual user, all of which impact how we feel as we go through our day-to-day lives, how we operate and interact with one another, and how we actually interact with and interface with the world that is out there. And we believe strongly that in a number of different conditions and use cases, from mental health and behavioral health, which impacts so much of our physical health, this can be highly beneficial and is something that we see as being not only something for the now with respect to changing how interoperability is dealt with, but for the future as we look to becoming more integrated and more engaged in a person-centered and health equity promoting paradigm shift. So with that, I will actually, probably a couple minutes short, but I will turn back over to you, Dr. Garg.
Thank you. And thank you, Heather. You made a very important observation and very important work regarding the betterment of community, their health, total health. Health means total health, not only healthcare, but total health, which we understand, and improve the healthcare ecosystem through data sharing and improving it. We understand that as far as this data is concerned, data of personalized healthcare is concerned, is much more costly. I must use the word costly. 7 or 8 times costly than financial data, because it's a personal property of a person. So for the betterment of masses, for the betterment of community, we have to encourage person to share data. I agree with you. But there should be a standard system of collecting data, which is a question mark as on today. This differs from organization to organization, person to person, and country to country. So you have to work on this aspect. I am not sure you must be working, but this is a question mark. So standardization of data of personal health care is a need of our. And we totally agree that for the betterment of the community, planet, and environment as a whole, we have to cooperate and get this data in the organization which will make full use of it and make it public for the betterment of health ecosystem. Now, with these words, I will ask a few things later, but I will ask our other colleague, Ms. Poonam Bhargava, Director, Winard, and the Learning Academy Certified Holistic Wellbeing Counselor, to kindly address. Poonam, please.
Yeah, thank you, Dr. Garg. Am I audible?
Yes.
Thank you. First and foremost, thank you to you and the World Healthcare Conference organizers for inviting me. It's an honor to be with Dr. Vigilance, yourself, and Miss Heather and the others. Thank you so much. It was very, very vividly brought out by the earlier speakers. I endorse when we talk about data as a soul, data as life, and it is so imperative that data can be collected authentically. And when we talk globally, we know healthcare is in the ecosystem it is. The developing countries are doing their bit. But we need to see, when Dr. Garg mentioned the planet, we need to see collectively as to where each and every country stands and what they need to do for the betterment of their healthcare landscape. So that brings me to a very pertinent point before I introduce myself and open this discussion, that behavioral health has undergone a complete decline in these 2 years. Personally, I have seen a lot of people psychologically, socially, emotionally, suffering. And if we can call those data, it gives us a very grim picture. So if we look at the grim picture that there is, according to the survey reports done by UNESCO and WHO, we will be able to better address the issue that is currently at stake and needs a lot of addressing, specifically because the mental health care experts now feel that if we do not handle it immediately, it can lead into a social and emotional crisis. So I would just introduce myself. I'm a certified holistic well-being trainer, a mindfulness coach, a Reiki master. I work in the space of thoughts and emotions because emotional intelligence is something that is the next stage for everyone. Emotionally managing your managing your emotions intelligently is the new way forward. How we can make people aware, how we can make them not seek mental help if they still think it's a stigma. There are some very important key points that we as mental health care professionals we can bring out to the general public, that how it is changing, how people are thinking differently, and how with the use of technology and digital inclusion, like how you all mentioned, we can completely change the face of our healthcare system. So just let me know if you can see my screen. Yeah. So basically, it is very important for us to understand what mental health really is from the perspective of how behavioral health and mental health, the two aspects are connected. And since I work in the space of thoughts and how one acts and feels and thinks, so identifying emotions, feelings, and moods become very important. And what has the pandemic given us? The range of emotions which we are unable to even point out would really help the data to be collected specifically so that we can address it very accurately. And what are the 7 unhelpful coping mechanisms that one can look at, and a very nice, like how she mentioned that we can look at Wikipedia and figure out what is happening in the space of researching data. Ms. Heather had said this is ABCDE is also an approach where we can analyze our own selves if we feel that taking help is a step away. So if we really look at the road that we need to really tread on and see, the milestones in blue for a mental health worker is starts at the awareness of symptoms that one comes with, to the eagerness with which one seeks help, the diagnosis, the treatment, and the post-treatment care. And then finally, how one actually maintains it. So the rehab part or the maintenance part. What is very glaring is the three things in red. That, just before the diagnosis, 70% of treatment gap across all mental disorders still persists. And this is something which we really need to look into and target. And how just between the diagnosis and the adherence, patient dropout rate has been consistently 60 to 70%. So most of who start with treatment cannot complete it. And when you leave midway, it really doesn't lead to a good data collection. It gives a skewed value. And how there are several people who post treatment cannot continue keeping it up, and then 75% severe disorders persist. So keeping this road journey in mind, we can delve directly into what the survey reports talk about. So even before the pandemic, we had, according to the IGP, we had about 50 million children. I would be talking about the Indian subcontinent perspective. We had about 50 million children in India that suffered with mental health issues. And 80 to 90% never sought any support or any help, which is really alarming. The post-pandemic has given us, according to the UNICEF survey report, that 1 in 7 it's a very alarming numbers again, that they feel depressed and they do not feel interested in doing their normal chores also. And only 41%, which we can call our youth, the leaders of tomorrow, they believe in seeking support for mental health problems. Now, if all the digital inclusion and the technologies that we have to our advantage aren't really made aware of completely to this youth, then most of us would still be struggling 10 or 20 years later. And only 25% of students with a mental health problem ever seek help. Gets us to the estimated 1.03 trillion economic loss because of mental health conditions, which WHO has estimated in these 18 years. And we are just about 8 years away from that particular loss. Now, the impact it has led on children, it's just the tip of the iceberg. We cannot even imagine and predict. One of the most important mental health issues that in India we have currently seen depends on factors like anxiety, depression, and loneliness that the pandemic as emotions have given us. And if we can see, Instagram is supposedly responsible for the highest anxiety, depression, and loneliness. You know, a youth would want, okay, I haven't had enough followers. I'm not getting very good remarks. People are not liking me. Body shaming, issues like that are currently on an upsurge. How we have to protect and guard ourselves from social media is also, I feel, very importantly a concern of a healthcare worker as well. So I like this word. I say check up above neck up. It's so important. It's so important because everything that resides and is to be seen in the next generation is residing in our brain, in the folds of our neurons and cells, and most of which we really need to protect ourselves from. So the state of well-being in which an individual realizes his or her own abilities, like how WHO says, or can cope with the normal stresses, can productively and fruitfully work, only then will we, or can we say that we are on a road to well-being or maintaining well-being. If any of the aberrations happen in this space, we come to the first palpable and perceivable factor, which is the behavioral health, and how it is related to the other areas is that it impacts not only the mental health, it impacts the physical and the other habitual health also, because the cognitive habits that one forms is directly proportional to how we will be behaving. So it is so important that we address the thing that is the intersection of all these three health components. So factors like eating, drinking, excessive use of substances, unhealthy sleeping patterns, I mean, everything contributes to this. So like how Dr. Vigilance said that transformative healthcare, how these issues have to be handled, I think in the Indian context also, we would be needing this kind of a very transformative healthcare approach, because we still feel that we are geared to address the other clinical approaches, but we aren't very geared for the mental issues still. And we all know that there is a lack for mental health care workers, where we have a dearth of mental psychologists, counselors, psychiatrists. Their role comes much, much later. So the behavioral aspect, since I deal in CBT and REBT techniques, it is also a very slow and a time-consuming process, and it is a one-on-one. So we need to come up with a plan where we are able to address people, because data is definitely in billions now, and how we will be addressing that. So definitely it is not oil and it's not fuel, but it is a story that everybody will have in their own perspective. And when I say that, then actually it has given us to each a very different emotion. but we try to keep up with it. We have a very cool facade, and we really do not take care of our subconscious range of emotions. We could be depressed, we could be miserable, we could be tongue tied, we could be passive aggressive. We definitely do not address those issues. And I, as in the capacity of the founder director of my organization, have made an attempt to bring it to the youth and the school going children here in India, that you have to learn to look within. You have to learn to address your immediate issues so that they don't become critical. And when we look at issues, we just come to the first thing, which is thought, because they create reality. And if we harbor a lot of negative thoughts, this is what usually happens before we move into the world of psychiatry. So I would just like to very quickly take us through these few slides, because these are the first things. Emotions are the first things that enter our body. When I saw the smiling face of Miss Heather and a very conscientious approach of Dr. Vigilance, the first emotion that I got was how passionate they are for their work. So that is the first neurotransmitter that got released in my brain. And this is something which we feel all the time around us. And so we need to be aware of what are my basic emotions right now, or what am I feeling, and how can I bring about a transformation. So, but we definitely should be addressing them, because if we do not, then they will intensify. And maybe sometimes we tend to ignore the milder ones, but if we address even the mild ones, we will nip them in the bud, and we can potentially save ourselves from the outshoots of emotions, which would be feelings and mood. So emotions come first, followed by feelings and then moods. Feelings actually integrate the emotion that I feel, like how I'm feeling very very conscientious right now about what we are doing on this particular platform. And this feeling will persist for a very long time, because people will actually start looking within. And then when they do that, maybe over a period of a few weeks and months, they can integrate their mood with their feelings and feel more relaxed or well in control with what they have been ignoring. So this is available on the internet. It is a very beautiful picture to have in your phone as your wallpaper, or on your desktop. A beautiful polar depiction, polar opposite emotions are pictured. I mean, if you can see the outer circle where my cursor is: joy, trust, fear, surprise, sadness, disgust, anger. They are the 8 emotions, and how we can actually oscillate between serenity that you get in mountains or complete ecstasy when you get into a beautiful organization, and how we sometimes stay in the zone of joy. So a good emotion, which is a positive emotion, we can let it intensify, but we cannot let anger intensify into rage. We need to address why we get angry, and be how anger becomes anger because we start feeling annoyed at something. So this emotion wheel also tells us if we are in the midst of an overlapping emotion. And overlapping emotions give us different feelings that sometimes we are unable to cope with or unable to handle. And we start becoming passive aggressive, or we start dissociating, or we go into an autopilot. Because when emotions take over more than 3 at a time, then it also creates brain fog. I always feel emotions can be looked at positively. People describe depression as someone who's locked up. But for me, a very beautiful positive meaning and a possibility could be that it is a hidden anger you don't feel justified having. So we can release it. And if we continue releasing, very few cases of depression probably would exist. Likewise for anger. It isn't to feel a certain in an outrageous manner to feel something, but it's time to make a change. For anxiety, we could probably say Well, we feel events, people, and situations are important because otherwise we won't have anxiety. For loneliness, I would probably say it's time to say hello to others. And for shame, we could say letting others define who you should be will actually make you feel belittled. So, how about we start defining our own selves? Now, when we talk of emotions, we do not we have so many of the negative emotions. Positive emotions we share, and it's such a sad thing that we are not taught to share our negative emotions. We're taught to deal with it. Now, how about not dealing with it by actually burying and stuffing it, because that's one of the first unhelpful coping mechanism that we do, and it turns into a volcanic eruption later when too much of stuffing has happened. How about we do not take a different route by ignoring what we are dealing by abusing our body? How about not becoming passive aggressive? Because the pandemic actually made a lot of people lonely, isolated, not with each other, So they had to just keep everything within. And how the pause actually told us to behave in a certain way. So, how Dr. Garg was talking about the paradigm, I feel that's where the paradigm needs a shift and a change. And this is very, very simple that we all did actually binge watching. We had too much time on hand working from home. But one of the things that we do not realize and we do is displacing emotions. Like if I'm feeling too much of anger at work or in my relationship with someone, I would probably not realize that I'm stomping my foot or I'm slamming a door or I'm probably hitting my pet. So we shouldn't be shifting blame, which we really do, or playing a victim card, catastrophizing, why me? Now, when we identify which unhelpful coping emotion we are currently in, the road opens to becoming and making a very beautiful transformation. So exactly this is what most of us do. And if we see really 1% of what we worry about really happens. And that is also a probability ratio. So I've got 5 coping emotions and just very simple, which we can all practice. Name it to tame it. So ask yourselves, are you feeling envy or jealous? Because they have different meanings. Am I worried or anxious or lonely or depressed? And then follow just one mantra, which is a fill in the blank statement. So I choose I'm feeling dash, therefore I choose to feel dash. So if I am feeling lonely, I could probably say, I'm feeling lonely since 2 days, therefore I choose to feel loved by inviting a friend over or going out. It's a way to immediately understand my inherent feeling and emotion and trying to talk to myself and sinking in and tuning into my body. The second helpful coping emotion could be journaling. And this is what I think most of the organizations, I'm not sure, Dr. Vigilance, if yours is doing it, they are trying to really teach how to journal emotions because writing is very therapeutic. So I could be saying, Dear Diary, today I felt anger and rage when my mom compared me. Now, when I put it down, I definitely know the accuracy of my emotion. And then I also know, why do I get triggered? What is it that has made me get rage? The intensity is maximum. And then probably I can see within and say, oh, well, I don't believe in comparison. Or maybe I'm not as good as my brother. Or my mother's remarks pressurizes me. Or maybe I just feel I'm unique and I'm not cut out to follow others' footsteps. When I figure out my trigger by journaling and figuring what is happening to me, and not a mental note, but a written note, then I should talk to myself, okay, what should I change? Because here we are talking about behavioral outcome. What should I change? What should be my next move? And I can say, well, it's time to change my reaction. I react all the time. Let it be my response. So my shift would be very palpable from reaction to response. Maybe I can have a dialogue and tell what exactly I feel every time my mother says something. And it can let her feel what happens to me with her words. So striking a dialogue in today's time is probably the best strategy. Or we could figure out our core belief system. What is it that I feel? What is it that I'm not letting myself overcome? So there are some beautiful break ideas that we can take when anxiety, loneliness, takes over. And sometimes, when I look at these, I feel sing out loud really helps. It just releases all your pent up emotions, or maybe a hug. It gives out that hormone that is a happy hormone. Since my first slide already talked about emotional attachment to physical care, because once you take care of self, you're emotionally taking care of your own self. So it is SELF, sleep 6 to 8 hours, exercise, liquids, and proper nutrition focus. And C would be cultivate wake up and bedtime routine every day. Avoid lifts and vehicles. Some physical activity will happen there. Relax, taking a stroll, meditating, and then engaging in my me time, which is very important. This me time could be my journal time. We also need to take care of mental, social, and emotional states of our well being. Again, mental note taking, no. Keeping a journal, yes. Exchange negative thoughts with positive ones, like how we just did. I choose to do this. I am feeling this, therefore I choose to do that. No is very important at times. We need to say it. Talk with your go-to person. Like, yes, there has to be no isolation anymore. We can pick up the phone. Telecommunication really helps. Ask for help and listen. It's a very beautiful technique. Julian Treasure is a very famous TED Talk speaker. He spoke about rasa. He said this is a Sanskrit word which Dr. Garv, you and I would be knowing. It means juice. It is ras, right? And it's an acronym. It stands for R is receive, A is assimilate, S is summarize, and A is ask. So it just makes us a very beautiful listener. I also read very recently a beautiful thought on feedback. Feedback is very powerful. Feedback can improve, and feedback can also catastrophize if you do not need one. So when we practice the listening technique with rasa, we can just ask, do you want me to offer any solution or help, or you just want me to be a listener? And that can take care of mental well-being in a big way, because we do not lend ears, we just lend advices. For social self-care, we should sign up for anything. It could be learning, study group, anything, because it keeps us young. And we can always use our gateways. I say we have 3 gateways: eyes, nose, ears. Observe our awkwardness. Okay, I am physically awkward. Am I fidgeting? Am I clasping my fists? What am I doing? My awkwardness, am I slouching, or am I actually stammering? What is it that I am observing which was initially not present? So socially, it will really help us a great deal, because we'll be able to fix it. Call or visit a family member or friend will definitely keep you in the social milieu or in the social orbit. And initiate conversations. I always feel if we can start with sharing our feelings, we can actually make the others share their feelings too. The A is allow yourself some attention. It's very, very important. If your voice is heard by you, then it will be heard by others. And this is so nice. Lunch, dinner, grab a meal with a fellow student. I think this is something we should do to understand what is in my control and what is not in my control. Because something that is not in my control, I should not fret and fume. People were so upset and angry when others weren't getting their pandemic doses done. Well, it's not in my control. How can I get angry over that? So what can I control? I can control my choices, my anger, my jealousy, my attitude, how I treat myself. That is definitely under my control, and others also. Not being locked up in a room, and definitely seeking help. Now, I should not really fret and fume for these things: the past, mistakes of others, the pandemic, opinions of others, how others behave, choices, thoughts, and their response. So this can be made whenever I see the awkwardness in me, and I will be able to relax and not take a step ahead. The fifth, and this is something which is called the ABCDE analysis. It really helps. So what A is, it is like if you are feeling a certain way, which means that your inner world is not synced into your above the neck world, then we can see and understand, okay, what is my activating event? If my activating event, for simple reasons, is that I failed somewhere, then what is my belief about that event? And if I'm able to name it, if my belief is I'm not good enough, then what is my consequence around that? My consequence with C could be that I'm feeling disgusted or suicidal or miserable. Now, once I've figured this out, it could be in multiple scenarios, then I will dispute to challenge my irrational belief. And my irrational belief is that I'm not good enough. So how can I dispute that belief? By seeking a complete opposite thought, meaning change the negative into the positive. And I could say, if I study, I will probably pass next time. So my dispute is always with an if conditional belief, because it will lead to a better result, and the else will always be a better result as well. So if I study, I will pass next time, and then my effective new belief would be I will be good. I will be probably, if I continue doing this, I will probably become best at it. Since this ABCDE analysis is self-help, it can work in all the areas of our physical, emotional, social, and mental well-being. We just need to write it down in order to be able to speak to our own selves. With that, I can just say, I hope I have not overshot. Thank you so much, Dr. Garg. I think this is just a little bit of, my contribution to improving the space that we have to create for our youth in the mental well-being scenario and space.
Thank you, Ms. Poonam, for excellent presentation, and we will see that this should be useful for the masses. We will just do something so that it will reach to number of people, and number of people will contact you and have word of wisdom and advice from you, so that they should be out from this dilemma. And one more speaker, I think, if she is there. Lucy, are you
Hello,
there?
hi.
So
Yes, I am.
You can have a quick presentation, please.
Sure, of course. I think it's like a great presentation. So thank you so much for that. I'm going to actually move on to talking about, imagine that you're actually happy to see your loved ones, but your face is too stiff to actually show your emotion, and people always think you're angry, although you're actually indeed happy. So this exact thing that happened in 2014 when I first met someone with Parkinson's, and they were saying, I'm very happy to see you, but I look angry because I can't smile anymore with Parkinson's made my face stiff. So charcoal have been built to bring smiles back for people with Parkinson's. We started in 2014, but this is 2021, so last year, when we met with one of the gentlemen and the couple where the gentleman had stage 4 Parkinson's and his face was stiff. As you can see, he's trying to pose for the photo, but you can see that he can't actually smile very well. And this was the first day that we brought the Q1 device that we're developing to this couple for the gentleman to start using it to help with his symptoms. And about 5 months later, they sent this photo with a gentleman with a massive smile. And he actually shared his story around the local magazine about how the Q1 actually helped with his symptoms, and now he can smile again. So today I'm going to explain to you how we brought smile back for this gentleman and how we are aiming to bring smile back for millions and millions of people around the world. Unfortunately, there are 10 million people around the world who are suffering from Parkinson's. It is fastest growing neurodegenerative condition in the world. Charcoal is developing a medical device and AI-driven solution to improve care and life for people with Parkinson's. We are CE marked in Europe and UK. We are ISO 13485 certified as a medical device company. We have filed a patent for the device and the technology. So when we first started, we started talking with lots and lots of people with Parkinson's to learn more about their lives and how we can improve the quality of life for our individuals, and really trying to understand what are the main challenges that people are going through with the Parkinson's. So we summarized to these 3 main phenomena that is actually making their life difficult. And firstly, movement symptoms of stiffness, slowness, and tremor really makes their daily lives difficult. Even doing buttons on their shirt, going for a walk, making a cup of tea becomes really, really challenging with the symptoms. People manage the symptoms with the medication such as levodopa, but taking medication on time can be very challenging when it's on your daily life. To just check the time every single time is actually really difficult. However, failing to do so can lead to sudden deterioration of the symptoms and cause further injuries, for example, losing the balance and causing the falls and fracturing any of their bones. Thirdly, tracking symptoms of Parkinson's is very challenging. It is not just motor symptoms, but non-motor symptoms as well, with lots and lots of different diverse symptoms developing in different speed. But when they actually go see the clinicians in about 6 to 12 months, between the checkups, it's really difficult to update them in like 10 to 15 minutes of how they've been doing throughout those times, and giving an overall view of how they're living their lives and what kind of symptoms are really bothering them. So we really want to check the symptom progression so that we can give the optimized care. So Charcoal have developed a Q1 and Q app to help with these problems. Firstly, the wearable device that uses medical adhesive that sits on the sternum improves movement by delivering focused vibroprotective stimulation and cueing, which I'm going to go into a bit more detail shortly, to help with the symptoms that people are experiencing. Secondly, while the device is worn on the sternum, it also gives a medication management alert. It's a discrete medication alert so that people can take their medications on time. Thirdly, through the application we have developed, the application delivers medication alerts, but also has games and different questionnaires that collects data of the qualitative and quantitative measure, so we can better track and care for the symptoms. So really, what does the device actually do to help with reduction of the device? It basically combines two well-known phenomena that has been studied from 19th centuries. It was first discovered by Professor Shaku, where our name comes from, where people come to him on a carriage ride had actually better symptoms than him actually visiting them. Secondly, it combines with since then there are lots of studies around whole body stimulation and focus stimulation, and it was this focus stimulation that was actually shown to really improve with movement. I will shortly share the animation to everyone to have a better understanding. Cueing is a metronome type of stimulation, and it has been proven to help with movement, especially with the walking and freeze of gait. So what I'm going to do is I'm going to quickly share, if I can share the sound as well.
Parkinson's disease is a
Can I quickly
progressive
ask if you can
neurodegenerative
hear the
condition.
sound?
Loss of pigmented midbrain neurons in the substantia nigra pars compacta leads to many motor symptoms of Parkinson's, such as rigidity and bradykinesia. These symptoms have also been linked to an excessive amount of brain activity in the beta frequency band across the motor cortex and subthalamic nucleus. This beta activity normally decreases before and during voluntary movement and increases again when staying still. Research suggests that vibratory signals transmitted from the skin and muscle to the brain may be able to modulate cortical activity, reducing the amplitude of beta activity. This puts the body in a ready-to-move state and reduces stiffness and rigidity. Vibration was first suggested to improve Parkinson's symptoms back in the 19th century by the renowned neurologist Dr. Jean-Martin Charcot, who noted that patients' symptoms were less severe after arriving by railroad or carriage. Over the years, we have refined our understanding of this finding. Recent studies have found that localized stimulation, placed on a peripheral part of the body, can be effective and more practical than full-body vibration. Through extensive testing, Charcot Neurotech found that the sternum may be the optimal position for effectiveness and ease of use. Charcot's Q1 is a non-invasive device which uses localized vibration, termed focused vibrotactile stimulation. Here we will describe the best current understanding of how the Q1 works. High-frequency vibration can be detected by mechanoreceptors such as muscle spindles in the tissue surrounding the sternum. They have been shown to send sensory neuronal signals through 1-alpha nerve fibers to the brain. These signals encode for physical touch and proprioceptive information, which are important for motor and balance control by the brain. The Q1 also uses a validated therapy for Parkinson's called cueing. Medical professionals commonly advise using cueing to help people with Parkinson's with their motor symptoms. Cueing can be delivered in many ways, such as rhythmic auditory cueing, which can be achieved using a metronome. Visual stimuli have also been explored in the experimental setting, and many professionals recommend cognitive cueing, such as counting in one's head, to help with movement. The Q1 uses rhythmic pulses of vibration to provide cues, which are discreet and less distracting to people as they go about their day-to-day activities. Cues like this provide a stimulus that can help people with Parkinson's initiate and sustain regular cycles of bodily movements that are implicitly learned, like walking. In order for movements like walking to be initiated, inhibition of neuronal activity in the supplementary motor area of the brain is required. This is controlled by structures of the basal ganglia, each possessing an internal rhythm. In Parkinson's, as the neurons in the basal ganglia are damaged, the internal rhythmic activity is disrupted, and hence the control of movement deteriorates. This is a possible cause of other characteristic features of Parkinson's, like freezing of gait. Tactile cues delivered by the Q1 may help relieve symptoms by modulating the disrupted basal ganglia SMA circuit, potentially bypassing the circuit itself, allowing reinitiation of learned movements and avoidance of freezing. While both focus stimulation and cueing have been studied extensively in the literature, the Q1 is the first widely available device to combine and deliver them in a practical and patient-centered manner. With this combination, the Q1 may help to relieve the key movement symptoms experienced by people with Parkinson's. To learn more, please visit our website www.charcotneurotech.com. This animation has been reviewed by Dr. Alistair Noyce, Professor James Kilner, and Professor Kyumil Kwon. Parkinson's.
So if I may share the video testings that we are doing with people with Parkinson's to develop the device actually. So this gentleman, even at his best medication status, he experiences freeze of gait. So this is a very classic measure to evaluate Parkinson's movement. And as you can see, he's experienced quite a severe freeze of gait when doing a timed up and go task. The benefit of the Q1 is that it is actually a device that they can use during the daytime in their daily lives, and you'll be able to see him using the device straight after doing the same task, and immediately that he'll be able to see improvement in his walking. So when Charcoal was developing Q1, we have actually had a lot of evaluation, and we were looking into different measures, including daily activities where people with Parkinson's wanted to improve with their daily activities, such as like writing or like using their phones and so on. We did clinical measures. As you can see, timed up and go is one of the very classic ones that you use. Golden standard of the UPDRS, which is Unified Parkinson's Disease Rating Scale, is another thing that we've been looking into. But more importantly, it is the quantitative feedback of what did people actually say about feeling smoother, easier, and more coordinated when using the Q1 device. We are continuously doing more study, and we are publishing studies on the journals, as well as we are producing white papers ourselves. So if you're interested, please do visit our website to read further of all the reports. The application that we are developing, as you can see, is doing lots of things, but the main thing is controlling the stimulation of the device, setting up the medication alerts, and also tracking the symptoms of how individuals are doing. As you can see, it is the data is actually showing the strong correlation between the game and the clinical measure, because it needs to be important for people with Parkinson's as much as it is important for the researchers and the clinicians. We are currently doing many more studies, but current diagnostic accuracy will be able to determine between people with Parkinson's and healthy cohort. So the Q system that Charcoal is developing is basically benefiting people with Parkinson's, as well as the stakeholders such as NHS and healthcare providers, by improving the quality of life by reducing the symptoms of Parkinson's, and also optimizing the care and medication by having a better understanding of how individuals are doing through their daily life. There were quite a lot of efforts into improving the quality of life for people with Parkinson's, but the real kind of different unique part of the Q1 is actually we are tackling the symptoms itself, meaning that rather than improving one particular movement, such as walking or eating, we are actually looking to overall improvement in their movement. Very luckily, we were able to work with lots of people with Parkinson's from the beginning, and by people just sharing their experiences and sharing their improvement, our waiting list have grown to over 7,000 people, and this is increasing every single day. So our aim really is to bring the devices to people with Parkinson's as soon as possible. So currently there are tests run that are going out to individuals, but we're really working on further studies such as health economic analysis and business cases, so that we can get the devices through NHS or Medicare or our insurance companies, so that individuals do not actually have to pay for the device. We were very, very lucky to be able to work with institutions and VCs and funds so that we can carry activities and research. But more importantly, we were able to work with lots of people with Parkinson's, which really gave us a great insight into their daily life and how we can help them further. So together, we are always looking into this kind of messages from individuals with Parkinson's who use the Q1, and that they are able to go back to their activities that they used to love to do. To bring this to individuals, Team Charcoal is a combination of innovation design engineers, clinicians, neuroscientists, physicians, and engineers, and we work together to bring the interventions for individuals with Parkinson's. We have incredible science advisory board as well with the neurologist and movement disorder specialists, so that we are directed well with the clinical measures and also preparing for the clinical trials to learn further. We are also guided with the business advisors and regulations advisors. So yeah, all together, we are aiming to bring smiles to as many people as Parkinson's. And if I do have time, I would love to close the presentation by sharing our last video.
And particularly the one we were talking about taking your card out of your wallet. You know, it's the person standing behind you that you can hear tutting. It makes you stressed and anxious, and then it slows you up. And then people get frustrated, so it makes you even more anxious. So I used to love shopping, absolutely used to love shopping. And now I pick my times when I go because I can't do crowds.
At Charcot, we have worked closely with the Parkinson's community to develop the Q1, a non-invasive wearable device that uses tailored vibration to relieve the movement symptoms of Parkinson's, such as slowness and stiffness of movement and freezing of gait. Worn on the sternum using comfortable medical adhesive, the Q1 has been shown to improve the user's movement at the push of a button. The Q1 works by delivering two scientifically validated phenomena, focus stimulation and cueing, which together make movement easier and smoother. The Q1 is easily recharged with the included dock, which doubles as a case for the device and spare adhesives. Small and quiet, the Q1 is discreet and can be easily hidden beneath clothes. It also features medication reminders delivered through vibration, so you can make sure you get every dose on time without alerting everyone around you. We've been lucky enough to work with people with Parkinson's from day one. Our user testers have been instrumental in taking the Q1 from a university project to what it is today.
I was moving with Parkinson's.
Yes, I feel better. I'm standing on. The walking is definitely better. The standing is better.
Yeah. Well, I've watched Celia walking there, and it is 10 times better than the way she was walking yesterday afternoon. But watching you walk there, you're back to the way you were walking last year doing that.
How do you feel? Can I ask you if you felt any different from the point that we arrived?
Yes, I do feel different.
Can I ask you how you feel different? Oh.
I feel better already.
You feel better? Well, you don't look like it.
We were very happy to launch our first limited run of Q1 devices at the end of 2021, and are currently working towards providing all those on our waiting list with their Q1 as soon as possible. We hope you'll join our amazing community of enthusiastic, friendly, and like-minded people, and help us on our journey to improve quality of life and bring smiles to as many people as we can. If you'd like any more information or are interested in joining the waiting list, please visit our website or get in touch with us.
Thank you very much.
Thank you, Dr. Lucy, for giving a full account how to cure patient with this disease, which is very, very important, and bringing a smile to the people who are suffering. Thank you very much.
You.
Great job doing. So, Heather, Miss Heather. I will address you that there are three things in my mind at this moment. Number one, personal data. So change of mindset is required. Change of mindset, this means they say that this is our personal data. And so change in mindset is required, is an order of day. Number two, data management, for which you are very competent, and your organization and such other organization can do miracle. Then two more things. There are data silos in countries, in organizations, though it should be otherwise. Free flow of data is required, is the order of day. So this is a very, very questionable thing. And number fourth, which is most important, standardization of data is not happening world over. Is not happening world over. So how can we standardize data of a person and personal health care? So something is to be done in this direction. Your views, please.
Thank you so much, Dr. Garg. And if I may just quickly commend my esteemed co-panelists in this plenary session, Poonam and Lucy, both of you are absolute inspirations. Thank you so much for sharing your wisdom and your work and your progress. Just truly wonderful to hear and learn about. So with that, Dr. Garg, to your question about data standardization and how it is indeed not happening fast enough world over. There are two things that I would like to suggest. One is that we as an industry in digital health for the last 30 years have been trying to achieve what I will call semantic data perfection, where we implement data standards and harmonize the world on data standards. I think that there has been progress and there is important work in this area, but I also believe that we will never achieve data standardization in the ways that we've been going about it for the purposes that you describe. There are intrinsic limitations to achieving that when new data types are continuously emerging all over the world. It is not as if the definition and nature of the data itself is fixed. So since it is not fixed, the standards can never completely keep up. Further, huge amounts of the most important health information is unstructured entirely. So this refers to things like imaging data, the notes and commentary of physicians and providers. And then there are new data classes like genomics and multiomics and proteomics that require entirely new analytical utilities that move us into digital biology. So the point I wish to make is not that it is impossible or that we're sure to fail, but rather believing that data standards is the way to solve it may not actually ever work because of this scenario that I'm describing. Instead, what I believe is that we will be able to create the value we need from data, including pre-processing it to normalize it for analytical use using artificial intelligences. And that in fact, it is this intersection of AI, against big data that can prepare data for processing through things like automated data enrichment, ethical annotation of data, and more related ideas, plus as much data standardization as we can realistically achieve. We should not give up on data standardization. We should do our best, but we should have a realistic notion of how far data standardization can get us and where AI has to pick up from there to get us to the population health and public health and health equity goals and values that we all share. Thank you.
Heather, I have to say two things. When I was doing research, I was aiming perfection. I was aiming perfection. My professor was very learned, and he said, don't look for perfection. Perfection will come, but keep on doing, keep on doing. And that is what I thought, that in this direction of standardization, work should be done, digital data should be collected, and the person, because it's a personal data, they should be well educated and well informed, sensitized. That is a requirement. And so I agree with you that there is no perfection or there is no standard in the world as on today, but we are moving in that direction. Okay? Before I say anything, I will request Poonam Bharkav to kindly address this issue also. Please.
Okay. The issue of data standardization?
Yeah. Requirement of digital data, patient data for uniformity or for better healthcare.
Absolutely. So there are 4 stages, as we could see in the healthcare scenario. We can start from the first stage, which is when we talk about patient healthcare, we say prognosis, diagnosis, prevention, and maintenance. What is happening in the healthcare industry is because the data is confidential, the data isn't being provided by patients. We feel there's still stigma around saying that I have cancer or I have a critical sickness. So that data isn't really coming. If that data isn't entering the digital pool, it is not letting us have an estimate of our current situation. And that current situation can affect the standardization as you are talking about, sir. Now, the standardization is so important, like how Heather also mentioned. It is a process which is iterative. It is a process which is ongoing. We have to continue upscaling it and inventing better technologies maybe, or creating awareness around it so that the inflow becomes trustworthy. It becomes more where the patient and doctor interaction rests and depends on how we are dealing in this domain, and how the transparency lets us have a better outcome from the perspective of not only collection, but from the perspective of having serious work done on that. So it is in the process already, because we are seeing better results pouring in year after year, but we have to still go there. We have to still get there. If I may just use a little bit of my experience in dealing with the youth, because I deal in the space of middle school till about postgrad college. I have seen students coming out with taboo topics, but only in the presence of someone who is able to give them a listening ear, not with their own parents. So, this is again where I'm talking about data insufficiency. It stays only with one person, it doesn't travel and go all the way to add to the pool that we are building on. Now, this serious problem has to be looked into from the educational perspective. How can we really bring about uh, the the visual communication aspect and educate people? That probably will help us in better standards and in standardizing the data that you're talking about.
Thank you, Mr. Poonamji. Either I have to say there are three things. Number one, that if data is available, then we can move from here to some other country or some other place, and same tests are not required. So affordability, the quality of data, speed, and transparency, they are need of our. But more than that, what is required? Education or awareness, which we are lacking still today. You are talking of US, it's okay, little bit, but as far as these Asian countries are concerned, we are very reluctant in giving information of our health, our personal life. So attempt has to be made in this direction to create awareness so that you will get data. And second, efforts are to be there for creation of standard. We should move in that direction, and hopefully a brighter day will come. Lucy, you have to say something?
I just want to say, like, sorry, was there a question? Sorry, there's a little bit of breakage from my side.
Question is that digital data is need of our for affordability, for quality of healthcare, for transparency, and speed of Medicare.
Absolutely. I have to say, like, I think that's where we're kind of going, like moving towards to, where we collect the data in the right form and analyze them so that we can have a better insight to individuals, symptoms and the progression and what the individual profile is and so on. One thing, if I may to add though, so I have no doubt that that's kind of where the technology is going to lead us with more effective and efficient way of the healthcare, which will benefit not only patient, but their family members and clinicians and like everyone all around. Although I think I'm sure everyone kind of agrees, it is actually also very, very important. How do we kind of use this data and what the privacy and protection is so important? How do we anonymize where it's possible? How do we make sure that the data doesn't get leaked? So I think balancing that is very, very important. And I think this is not just for the regulations and the government to kind of put the procedure on, but also the medical devices who needs to take a good practice into their development to ensure that everyone is protected.
Yes, thank you. And Mr. Vigilance, last word on this aspect.
You spoke to the reluctance that individuals have with respect to sharing personal health information and personal data. Unfortunately, that reluctance is not shared by enterprise, really. So there is a significant amount of our data that is taken. We sign off and give consent to our data being pretty not inadvertently, quite advertently shared and prospered from for the purposes of advertising, research, etc. So our reluctance on the part of the individual to share is not mirrored necessarily by the industries and the organizations with whom we share information on a regular basis. And so there's this mismatch of perception with respect to what is shared or what should be shared and what is actually shared. And our data moves in a very liquid way according to a set of rules and premises that are not controlled by us. And that, I think, is part of what needs fundamentally to change. And so I agree with you, and I certainly appreciate the comments from both Poonam and Lucy relating to their specific areas of concern. But a seed change in how we view data and how we can make that data relevant to the individual so that they can prioritize it and put it where it needs to be for them to live their best life. So the standardization question is, I think, a very good one. And there's work that needs to be done there, but there may need to be a range within those standards so that individuals in different settings can see themselves in the appropriate place. When we make everything equal and the same, not everyone can necessarily get to it. So that is an equality sort of way of looking at it. From a health equity perspective, we give different people opportunities to engage as they can. And I think that that's going to be an important degree of fluidity that we should have as we move into this new space.
Yeah, I agree with you, Perry. And so the question is, as far as data quality is concerned, their standardization is concerned, transparency is concerned, and speed is also required at this moment, for which sensitization and awareness is to be created. Dr. Hittar, we will just conclude with thanking you. We had taken much time than it was proposed because it is a last session. So I overshoot this intentionally, and the subject is very, very close to our heart, and we see future in this. And that's why we have requested you to stay some more time and discuss. And in fact, we will have this conference next year on 11th and 12th of April. And this will be in person. So we will request all the panelists, all the distinguished speaker, to be there in person. I will send invite. And this is a very good, very learned panel and excellent presentation by each of them. Thank you very much for sparing time, energy, and your time for that. Thank you very much. Thank you.
Thank you. Thank you, Dr.
See you next year.
Thank you very much.
Yeah.
It was lovely being with you all and sharing this space. Thank you so much. And thank you, Dr. Garg.
Thank
Thank
you.
you so much.
Thank you. Thank you.
Likewise, thank you.
Yeah,
Thank
your
you.
presentation was excellent.
Thank you.
Thank you.
Thank you very much.
Take care.
Much.